الكلام ده مهم يا احمد. ساين ايه مباشر؟ اقفل. اوكي كنسل. اوكي. Hello.
Good morning.
Good morning. Oh, you changed your jacket. Okay.
No, same jacket. Yeah.
Okay.
It's just change the pajamas underneath.
Okay. I open the camera just a minute. Well, so can just give it 2 minutes and then we start to be actually in time. Okay.
Perfect.
فين اقفل ده دلوقتي؟ طيب اعمله ايه؟
شيل الماركة.
طب استنى، عايزين نعمل حاجة تانية. احنا قلنا كيت اللي هيقول الاوبننج ولا؟ Okay, Keith.
Yes.
Every one of us will have 5 minutes to open the forum. So would you like you start or I start the opening speech? I think you start.
No, you can start if you want, and then I'll go after you, and then I'll go right into my talk.
Okay, good. Because when I start, I will brief the people about the program, and I will mention that you will do the opening speech and start your talk. Okay. بقول لك ايه، بيبان هنا معانا ناس قد ايه؟ فين؟ لايف ولا فين؟ 48. اوكي. So 1 minute and we start. 1 minute.
Perfect.
الصوت كده هيبقى واصل برضه. اعمل شير. فين الشير بقى؟ بلاش اوبتمايز فيديو كليب. لا احنا شير. لو انا فتحت ده صورتي حبات برضه. لا لو فتحت ده كده. 3 2 1. Hello, everybody. Good morning or good afternoon or good night, wherever you are in the world. We have participants from Latin America to Osaka. So whatever the time now, I send you greetings from Dubai. This is Usama Shauki, and I'd like to welcome all of you to the 15th edition of the Gyne Forum. People ask why you choose the name Forum. Forum is a Latin word. At the time of the Roman Empire, near the Colosseum, there was a place where the wise people gathered to study, to discuss matters of the state. So it's my honor and my pleasure that in the 15th edition, the honorary president of this forum is Professor Dr. Keith Isaacson from Massachusetts. I'm going to introduce him more, but I really appreciate his generosity to be the honorary president. Well, people might ask, Osama, this is a Zoom meeting. In fact, the COVID crisis showed that the Zoom could be even much better than staying in such dark, not illuminated rooms with the boring lectures, and people feel truly sleepy, okay, when you stay for a long time in a dark room, and not everybody is you lose concentration after the second or the third. You find everybody holding his mobile, using the WhatsApp. But on the Zoom meeting, you can follow the distinguished speakers from the angles of the world, where you are sitting in your home or at your office, or even sitting on the beach, sipping your drink, and you are watching in details the contents of a scientific meeting. So I do believe that Zoom has offered us a privilege. Today is Saturday, and it's a weekend in many places. So whomever wants to join us, just sit on the beach and follow us. You can meet everybody in one screen. The Gyne Forum this year is 3 parts, 3 arms. In the morning, and together with Dr. Keith Isaacson, we have a comprehensive hysteroscopy half-day workshop with distinguished speakers, Attilio Di Spiezio from Italy, Dr. Yaqub Khalaf from UK, and we had a very interesting topic we just finished now, and they are playing on the simulator for the moment. The program will start now. After my opening speech, I will handle the screen to my dear friends, Dr. Keith Isaacson, to welcome you and directly go to his presentation. His presentation title is very attractive. Everybody know that in Amazon Prime, you can watch Tom Cruise or you can Brad Pitt. So wonderfully that we will watch Keith Isaacson on Amazon Prime talking about Asherman. Keith Isaacson, a past president of the AGL, and maybe for not everybody know that he is the one who introduced safety in hysteroscopy by introducing the bipolar resectoscopy. That was a huge revolution. So we are glad and proud of him, Keith Isaacson. And then we will move to the icon of infertility in the world. A man who stands on more than 200 publications, a man who changed the practice of assisted reproduction, Professor Abul Ghar. If I only describe him as a scientist, it will be only 10% of the talents of this man. He's not just a man living in the world, but he's the whole world living in a man, and he will tell us what science fiction and could be the future of infertility. Then we move to Professor Hassan Salam, a companion to Bob Edwards, and the man who witnessed the birth of ultrasound and introduced it to the Arab world. Professor Hassan Salam was the pioneer of assisted reproduction, and the first cases done in the Middle East by him. And we'll finish the first session by the man who put the guidelines, Professor Yaqub Khalaf from UK. Simply, his signature is the guidelines that make everyone follow it. So let us to know from him what are new guidelines for infertility. So, ladies and gentlemen, I'm very glad for the crowd joining us. And I promise you, I will not say only science, an entertaining session full of experience of these people. I was very careful to choose the people who have experience, who lived long lives, and then they put the squeeze of what they learned into your hand. Professor Keith, thank you for your time. And in the morning, you captured and you gained the admiration of everybody, and looking forward to continue your presentation and your charm in the coming talk.
Thank you very much. I want to start, thank you very much, Osama. And I want to start with this picture. I love this picture. Because Osama, to me, has been a wonderful friend for many, many years. And I'm so honored every time that I've been able to visit his hometown in Cairo, that he welcomes us into his heart, into his house, and he has a wonderful meal and treats us like family. And that's just his personality, and he's very much cherished. And I couldn't be more honored, Osama, that you asked me to participate as the honorary president. And ladies, gentlemen, esteemed colleagues and distinguished guests, I am honored to be with you virtually in the magnificent city of Dubai. And again, thank you, Osama, for inviting me to be part of this year's international conference on gynecology and particularly hysteroscopy. It's both an honor and a pleasure to be with you today as honorary president of this prestigious gynecologic association. I wish I could be there in person, but perhaps next year. The fact that you are all part of this vibrant assembly, you are participating in the embodiment of progress, passion, and relentless pursuit of excellence in gynecology and hysteroscopy. Together, we represent over 4 decades of dedication to the field of gynecology, with particular emphasis on operative procedures. The field of operative hysteroscopy has grown tremendously over the years, evolving from a pioneering concept to a pivotal technique in modern gynecology. In my 35 years of practice, I've witnessed firsthand the transformation that has occurred within our specialty. I've seen the joy in the eyes of patients whose lives have been profoundly changed by our work. I've experienced the exhilaration of scientific discovery, the development of innovative tools and technique, and the forging of international collaborations. Our specialty is more than just a medical procedure. It is an art. It is a science that has touched the lives of millions of women worldwide. It represents a beacon of hope for those struggling with reproductive health issues. It is our shared mission and privilege to expand this hope to reach everyone in every corner of the globe. But my dear colleagues, we must not rest on our laurels. Our journey is far from over. Today, this conference serves as a gathering point for the brightest minds in gynecology. Together, we shall embark in the stimulating intellectual adventure, exploring the cutting-edge developments and operative procedures, challenging existing paradigms, and forging new paths of excellence. We are on the cusp of a new era, one where our collective wisdom, our innovative spirit, and our commitment to women's health will propel us to uncharted territories. Let this conference be the spark that ignites global movement, one that fosters collaboration, celebrates diversity, and champions the relentless pursuit of excellence in our field. Let us inspire and be inspired. Let us learn and teach. Let us embrace the challenges and celebrate the victories. And most importantly, let's do it together as one global family, united in our passion for gynecology. Welcome, my friends, to a conference that promises to be nothing short of extraordinary. Let the discussions begin, the ideas flow, and let's make history together. And thank you again, Osama, for organizing this wonderful conference. So after that, I was given the honor and privilege to talk about one of my passions, which is Asherman syndrome. And I chose the title Amazon because, as most of us know, Amazon chose its name because it covers everything from A to Z. And in this particular talk, I'll try to be as brief as I can, but I want to cover everything I can about Asherman's, from the etiology of the syndrome to the actual outcome of our therapy. So to think about what causes Asherman syndrome, we first should understand the physiology of what happens to a woman's endometrium every month that she ovulates. It's long been felt that what happened was the body sheds the lining of the endometrium down to the basalis, and that the free edge of the glands and stroma will then just undergo metaplasia and regrow itself. But it turns out it's a little more complicated than just that. It turns out that with the influence of estrogen and progesterone, that there are actually endometrial regenerative cells or stem cells that are supplied to the endometrium either through blood vessels or other sources that we'll talk about. And it's the proliferation of these progenitor cells or regenerative stem cells that actually participate in the regrowth of the endometrium that allows for implantation of an embryo and the growth of a healthy pregnancy. So as you can imagine, if we remove the source of these stem cells, then we'll get endometrial atrophy, scar tissue, lack of menstrual flow, and the creation of Asherman syndrome. So they also found that these stem cells not only come from the bone marrow and the blood vessel, but they're also epithelial progenitor cells or stem cells located in the basalis of the endometrium. So what I really want to show in this particular cartoon, and this is, I refer anyone who's interested to this wonderful review of the regrowth of endometrial repair and regeneration that was published in 2021. And what this is actually showing that all three of the theories that I had just mentioned above are actually take place every month. So there are stem cells that are within the epithelium of the base in the basalis of the endometrium. There's a different set of stem cells further up the lumina of the glands that are a little more prolific. And then at the end of this epithelial cell migration, there is actually metaplasia. So the original theory was true, but there's also stem cells coming from the bloodstream, and there's stem cells or progenitor cells at the base of the endometrium. Why is this important to understand? Because look what's right underneath this basalis is the myometrium. And when we damage the endometrium all the way down to the myometrium where there are, and we remove these epithelial progenitor cells, you can certainly understand why a patient would undergo Asherman syndrome with scar tissue and endometrial atrophy. So for me to kind of picture this cartoon and understand it, it's very helpful when I'm caring for a patient who has intrauterine disease. But the basalis is actually not always just a straight line. This is also a basalis where it's unclear where the endometrium stops and the myometrium begins. So it's nice when it's nice and smooth like this, but there are many patients in whom it's like this, which may be one of the reasons why not everyone will get an Asherman syndrome when they undergo D&C, but some people may and some people may not. So the etiology of Asherman syndrome is trauma that denudes or damages the basalis layer of the endometrium to the myometrium. 90% of the time when we see it, it occurs in a recently pregnant uterus. It is a 40% chance of it occurring if a patient has a postpartum term D&C. There's 22% chance with a postpartum hemorrhage, 67% chance with a therapeutic abortion, and other causes such as uterine myomectomy, C-sections, diagnostic DSCs, TB, and irradiation can also be causes of intrauterine scar tissue. And there is an impact on fertility. Certainly when patients who have scar tissue and have these tissue bridges that lead to cavity obliteration have an increased risk of ectopic pregnancy, recurrent miscarriages, preterm labor, abnormal placentation, and pregnancy wastage up to 90%. So 6 to 20% of women with primary infertility have some scar tissue. 25% of women who have recurrent miscarriages have scar tissue. Again, 25 to 40% after a postpartum D&C have scar tissue. 6% of women with 2 or more failed IVF cycles with good embryo quality will have some intrauterine scar tissue. It's found after a hysteroscopic myomectomy in approximately 9 to 10%. It's found after uterine artery embolization, infection. And again, 43% of women who do have scar tissue will present with infertility. Why do I harp on these numbers? I harp on these numbers because most gynecologists, particularly in the United States and obstetricians, feel that Asherman syndrome or scar tissue is a very, very rare disease, where it turns out it's not rare at all. It's just, unfortunately, it is grossly underdiagnosed because it ordinarily takes a diagnostic hysteroscopy to make the diagnosis. Now, there's no universally accepted classification for how much scar tissue is actually present. The ASRM classification was devised in 1988, and it takes into account 2 factors: the extent, the thickness, the amount of menstruation in a woman with scar tissue. And they have 3 categories of mild, moderate, and severe. There's a European Society classification that was developed in 1995. And then there's a March classification, which I happen to like because it's actually quite simple and it's the easiest to communicate from physician to physician. And the March classification essentially says there are 3 types. There's mild, moderate, and severe. And the way to look at this is mild is typically less than 30% of the cavity is affected, moderate's between 30 and 70%, and severe is more than 70% of the cavity is affected, or the cavity is agglutinated where you can't even see the upper cavity or the fallopian tube. So it's fairly easy to classify, and it makes it easy to follow a patient's progress and to communicate with other clinicians. So to make the diagnosis of scar tissue in the uterine cavity, we need a hysteroscope. The hysteroscopes that I use are typically anywhere from 3.8 to 5 millimeters in outer diameter. They have a continuous flow system where there's inflow and outflow and the ability to place an instrument. Again, to treat the scar tissue, I typically just only use cold scissors. The scissors are 5 French, or they're 1.5 millimeters in outer diameter. And there are times where I'll use the sharp tip or the blunt tip scissors, but never use heat. And as we'll talk about, never use a tissue shaver or morcellator to remove tissue. When we're treating intrauterine scar tissue, we just want to separate the walls. We don't want to remove tissue. And we most often will treat Asherman syndrome and diagnose it in the office using the vaginoscopic technique, in which we do not use a speculum, do not use a tenaculum, do not use a paracervical block. And typically the patient is given a non-steroidal anti-inflammatory, and that's the level of anesthesia that we utilize. We do these procedures truly in the office, which is like the same exam room in which we do annual exams and pap smear. There's absolutely no anesthesia machine, no external oxygen, nothing. But we do have a collection system that we use for every patient, in which there's a disposable drape that collects the fluid so we can measure the fluid that comes out. We know how much goes in, and we can monitor our fluid status if necessary. You need your tubing, and we have a collection outflow bag, and that's it for doing our procedures. It typically takes about 20 minutes between the time the patient comes in the room, has her procedure, and is able to exit the room. And it's about a 10-minute turnover time before we're ready for the next procedure. So on any given clinic day, I'll do between 5 and 7 hysteroscopic procedures while I'm seeing my other patients. So when we do Asherman's surgery, again, what you want to do is the goals are to separate the tissue, which is adhesiolysis. You don't want to remove the tissue. You want to use cold scissors. When we use cold scissors, there is recurrence, and we'll talk about how to reduce recurrence. It's about a 30% recurrence, but if you use heat, such as with a bipolar or a monopolar knife, then your recurrence rate is as high as 57%. That includes radio frequency energy, monopolar, bipolar, or laser. So we want to avoid thermal instruments. And another reason is because it's not uncommon to have a perforation when you're doing severe Asherman syndrome. It happens in up to 10% of patients. And if you perforate with just cold 1.5 millimeter scissors, you can just stop the procedure. If you perforate with a laser or with monopolar or bipolar energy, you are obligated to do a laparoscopy to make sure there's no injury to the bowel. And at all costs, avoid the tissue shavers when you're treating Asherman syndrome. The surgery can be done with transabdominal ultrasound guidance, which I use frequently, particularly if there's complete obliteration of the lower uterine cavity. So you don't know which way the cavity is going, anterior, posterior, left, or right. So we'll use the transabdominal ultrasound guidance. Laparoscopy is rarely necessary, almost never necessary. Laparoscopy does not prevent perforation. Laparoscopy will just tell you that you already perforated. So let's go through a couple of cases of patients who present with Asherman syndrome. This first patient, again, is a 38-year-old patient who had lost an in vitro fertilization pregnancy at 23 weeks. She had an abnormal hysterosalpingogram. She's already gone through one hysteroscopic lysis of adhesion procedure with and was given postoperative balloon and estrogen therapy. And now she's having a second attempt. We start with a transvaginal ultrasound. And just by transvaginal ultrasound, I look for the endometrial echo in the cervix and in the fundus. And it looks like there's going to be a disruption in the lower uterine segment. Then we switch to the three-dimensional ultrasound. And again, it looks to me like the mid cavity is going to be normal, as well as her left cornua. But it appears that there's going to be scar tissue in the right cornua. So it helps for me to be prepared when we're doing this hysteroscopically as to what we're going to find. And then when, again, these are kind of real-time videos. This is a vaginoscopic approach. So I'm going to fast forward it a little bit. And what you can see is, to no surprise, in the lower uterine segment, the area between the cervical canal and the lower uterine segment was completely obliterated and scarred. We take the blunt tip scissors and open this. This is at approximately after 1 minute and 20 seconds. And once that is open, we know the cavity is open. We'll go further. Put the scope inside. You can see the opening to her left cornua and left tube, and the right side, as predicted by the 3D ultrasound, is completely agglutinated. So our goal at this point is to identify the right cornua and the right fallopian tube and try to restore normal anatomy. Again, all this is done just with the cold scissors. The patient is wide awake. Cutting the scar tissue is not painful, but when you do cut, if you do cut the myometrium, it is painful, and the patient will tell you that you are actually in the wrong plane. So here we finally got to the right cornua, and there's normal endometrium in that right cornua. And when you see that, you feel pretty good and fairly confident that you're going to be able to restore the anatomy back to normal. And then you will talk about what our preference is to use an adjuvant to try to keep the scar tissue from reforming. We just finish that until we're done with the entire adhesiolysis on that right side wall. But you can see it's starting to look like a normal cavity. Second case is a 36-year-old patient who had a DNC for retained products of conception. She had cyclic cramping, but she actually had no menses, and she had a history of polycystic ovarian syndrome. When we do the 2D ultrasound, again, it looks like there's going to be scar tissue just in the lower uterine segment, but there is some endometrium at the fundus based on two-dimensional scan. On the 3D scan, it's not as pretty, but again, we can see a normal, relatively normal fundus, but there's going to be scar tissue in the lower uterine segment. And indeed, when we do the hysteroscopy, we find it fairly much completely obliterated in the lower uterine segment. Right here, we take the scissors, open that up, and she did have old blood that came out once we opened this. So she was continuing to menstruate, and that's what was causing her cyclic pain. And her cavity again, was normal once we're on inside and past the scar tissue in the cervical area. So this is the only area in which there was scar tissue. Third case is a lot more difficult. It's a 39-year-old patient who underwent an endometrial ablation with the NovaSure device. I'm seeing more and more of this, that they have regret after the NovaSure or ablation, and then they want to conceive. She had already had 2 hysteroscopic lysis of adhesion procedures by Dr. Charlie March and had been on estrogen for the last 6 months. But this is a telling ultrasound that we could see the lower uterine segment. But this is, again, without using saline, we could see that there's absolutely no endometrium beyond the lower uterine segment, and her prognosis is quite poor. So we can open up the cavity, which I'll show you, but there's absolutely, and we can create a space, but there is absolutely no normal endometrium once we do that. And I would have told this patient and many just like her that her best chance of actually carrying a baby or having a baby is going to be using a gestational carrier or adopting, because even though we can create a cavity, we cannot to date we cannot recreate the endometrium that has all been destroyed. And this was a case in which a patient was sent to me in which she was undergoing an infertility hysteroscopy, and the gynecologist thought that in the mid segment of the uterus that this was all polyps. So he took the tissue shaver and he shaved all of this, doing his so-called true clear curettage. But in doing so, he removed all this endometrium to the myometrium. And as a result, this patient ended up with severe Asherman syndrome, as you can see there, in the lower uterine segment, as well as in the mid segment, everywhere that had been curetted with the tissue shaver. So I encourage all of you who are following this presentation not to use the tissue shaver as a curettage device, because I think it's difficult to know and control the depth of your tissue removal. And once you get it down to the myometrium and through the basalis, it's a good chance your patient will end up with scar tissue similar to this patient, which actually reduces their prognosis tremendously. So it's really not difficult to treat Asherman syndrome and to separate the tissue and create a normal cavity. But what is very difficult is, how do we prevent the scar tissue from coming back? The recurrence of the scar tissue has been reported anywhere from 20 to 60%, depending on the severity of the scar tissue. The methods to prevent recurrence include hormonal therapy, physical barriers, second look procedures, and we'll talk a little bit about the investigational agents. So second look hysteroscopy was published by my fellow Jim Robinson in 2008. And what we had done it back then is, after the initial procedure, the patient would come back in the office at 2 weeks, and then again at 6 weeks post the initial procedure, break up any filmy adhesions that's starting to recur. And what we reported back in 2008 was a 95% improvement in menstrual flow, and 46% were able to conceive where they couldn't before. So okay results, not terrific, but not terrible. Now, the question is, most of us, and I, including myself, up until about a year ago, have been putting patients on high dose estrogen after the initial therapy. And then finally, Mark Emanuel and his group published a report in 2023 of looking at the value of putting patients on postoperative estrogen. And at the end of the day, he did a study of 114 randomized women followed for 3 years. And half got the estrogen, half did not. And it turns out that there was no difference in reproductive outcomes or in menstrual flow. So I stopped giving patients estrogen if their estrogen levels are normal already. If they happen to be hypoestrogenic from a GnRH agonist or postpartum or for breastfeeding, I will give them estrogen, but I don't do it routinely any longer as a result of the data from this study. Physical barriers that are used to prevent scar tissue include IUDs. Again, these are commonly used in the Netherlands, but you have to be careful with your IUD. You don't want to put in a copper IUD because it creates inflammation. So what they're doing in the Netherlands, they're taking the Paragard, they're removing the copper, and they're putting in just the plastic portion. The Lippes loop was first used and was a great idea back then because it had no hormones. And you also have to be careful with the Mirena IUD or the progesterone-containing IUD because the progestins cause endometrial atrophy, and that's not what we want in the setting of tissue healing. So if you use an IUD, just make sure it doesn't have any hormones in the IUD and it doesn't have any copper. Balloons are commonly used. The Cook balloon that we had used, which was in the shape of a uterine cavity, was triangular. And the United States is no longer manufactured, so we don't have that any longer. It was never approved for the treatment of Asherman syndrome, and there were no randomized data on its outcomes. So people have used a Foley catheter. You leave it in for 7 to 10 days, probably better than an IUD. But there's still a fairly high recurrence of adhesion rate versus the control. So here are all the investigational agents. Asherman's has a website that's very active. It's a Facebook group, and people talk to each other, and they're on either Viagra or the pentoxifillin. People have started to try the PRP. And there's absolutely no data yet that any of this has any value. I don't think it's any harm, but none of it has ever been shown to be valuable in helping patients prevent recurrence of adhesions. So there are some intrauterine gels that this one is actually manufactured in the United States. It's not available in the United States, but it is available in Europe, called Oxyplex, in which you inject this 10 cc's of hyaluronic acid that turns into a gel, and will keep the walls apart for about 2 weeks. It is the studies that have looked at it, and I know Attilio has published, or I couldn't find Attilio's study, but I know he has used this in the past, and they've felt that they have fairly good results, but there's no large studies yet showing the outcome. There are 2 other investigational agents. One is made by WOMED out of Paris that uses 2 compounds. One's called PLA and the other is PEO. These are extensively used in the body, and they're both FDA approved. And what they do, again, is you put this one is called the WOMED leaf. It's under investigation in Europe and China. And it actually discharged into the uterus, conforms to the shape of the uterus, stays for approximately 7 to 10 days, and then it will degenerate on its own and come out. And we're just waiting now on the results of the trial to see if that's going to help reduce the risk of recurrence. There's another company that makes a different type of hydrogel made out of polyethylene glycol called Gyne. And again, similar concept. You put the gel into the uterus, and what you see is the gel conforms to the shape of the uterus, and it looks like this. It conforms to this shape. It takes literally 2 or 3 seconds to solidify. Then you take it out, and this will degenerate over a time of 2 weeks and come out on its own. and they are doing a randomized trial now in the United States to look at its efficacy. So I'm encouraged that there are several companies that are looking at novel devices because they realize there's a market opportunity, because a lot more patients suffer from this disease than had been previously appreciated. So what are our outcomes? Outcomes are kind of hard to find. I want to just go through our outcomes that was published about a year ago. We looked at over 356 patients who were treated for Asherman's in a 2-year period. We tried to reach them by phone survey, since about 80% of our patients come in from out of the Boston area. They're national, internationally. 127 of these patients attempted to conceive. 96 out of 127 did get pregnant, but there were quite a few miscarriages. The live birth rate with mild disease was 52%. Live birth rate with moderate disease was 55%. And the live birth rate with severe disease was only 16%. So the results are okay, but there's a tremendous room for improvement. And I think the improvement's going to come, hopefully, in the prevention of the recurrence of adhesions. One thing that's interesting, particularly for those of you that practice ART or in vitro fertilization, is that it's not uncommon, or actually it's very common, when a patient is undergoing IVF, that the IVF physician or healthcare providers will measure the endometrial thickness at the time of the embryo transfer. Many IVF units have a cutoff that if the lining is not greater than 7 to 8 millimeters, they cancel the transfer. You can't do that in the patients who have scar tissue, who have Asherman's, because their lining, they could have very normal tissue adjacent to scar tissue. And so we actually looked at the outcome of embryo transfer based on the endometrial thickness in our patient population that got pregnant after adhesiolysis. And what we found, interestingly, is that those who had a 4 millimeter lining had the same success rate as those that had a 10 millimeter lining. Granted, the numbers aren't huge, but this is the largest series to date that looked at the impact of the lining in patients with Asherman syndrome. It's not near as predictive as it is in patients without Asherman syndrome. So again, if we had less than 7 millimeter endometrial thickness at the time of transfer, they had a clinical pregnancy rate of 33.3%. And if it was greater than 7 millimeter, the clinical pregnancy rate was 31%. And there's no difference in the p-value. So do not cancel a patient because of thin endometrium if they've had a history of Asherman syndrome. We also have to worry about the placenta accreta spectrum in patients that have had Asherman syndrome. So the placenta accreta spectrum is, do these patients undergo, or do they have a higher risk for a placenta accreta when they deliver after being treated for Asherman syndrome? And this was published again by one of my fellows, Giovanna Tavkar, in 2023 in JMIG. And what she saw was, yes, there is a increased risk of placenta accreta in these patients. We had looked at the 97 patients who had a term pregnancy. 23% of these patients had some form of placenta accreta syndrome. And the risk of hysterectomy was actually quite small. Only 2 out of the 97 had a hysterectomy. But the risk of a stuck placenta accreta, again, was 27%, where normally you would expect it to be in the 1 to 2% range. So this is still a major factor. I'm not sure which came first, the accreta or the Asherman's, because think about it, all these patients had a stuck placenta before they had Asherman's the first time. Most of these patients had postpartum D&Cs to remove retained products of conception. So there's some factor in their uterus that puts them at higher risk for the placenta growing into the muscle than patients who don't have Asherman syndrome. But I don't think one causes the other. And I'm going to stop with that. I want to thank you for your attention. I hope I didn't go too far over, Professor. And it's been an honor being with you. And I look forward to listening to the rest of the afternoon. You're on mute. You're on mute.
So I forgot to press the mute. Actually, you exceeded my expectations because I am a big fan of Asherman, and I do really value many of your slides. Let me ask one question about, would you recommend concomitant monitoring of the procedure by laparoscopy or ultrasound? And you know that Mark Emanuel has a very nice idea, which I don't know why it is not popular. He does concomitant per-operative hysterography, and he has an X-ray machine. So every time he injects the contrast material, take a picture to see how much cavity created and then go on. So what's your opinion about that?
So I do frequently use the transabdominal ultrasound for guidance. So it's uncomfortable when the patient's awake. Again, most of my patients are being done in the office. So when you have a full bladder and you're putting pressure with the abdominal probe, it's a little bit uncomfortable. So you have to go quickly. So I do that when I don't have a good view of my landmarks, which are the opening to the fallopian tubes. I don't see a place for laparoscopy, again, because it doesn't tell you which direction to cut. And I think if you're doing these in the operating room and you have an X-ray machine available, I think it's a brilliant idea. It's just not practical in our situation because we don't have that technology in the office.
So when you use the ultrasound concomitant, I mean, you stop operating, do ultrasound, and then continue, or concomitantly somebody holding the probe and you are cutting?
Someone's holding the probe and I'm cutting. So I can, particularly if there is known to be endometrium there by the 2D or 3D ultrasound ahead of time, then they can help guide me saying you're too posterior, you're too anterior, you need to go to the right, to the left until we find the proper cavity.
One more thing, because in counseling of the patients, in my practice, most of the cases are severe Asherman. So in my opinion, I always say Asherman surgery is not one-time procedure. The patient should be prepared sometimes, like failure of IVF. We do 2, 3, 4 times. So what is the situation with you?
Yeah, we always do a second look. If they live locally, we'll do the second look at 2 weeks and at 6 weeks. And if they come in from out of town, we'll just do our second look at 6 weeks. So at that point, we're taking down the scar tissue before it organizes, and it's very filmy, and before it comes back as very dense tissue.
Okay, the last question is something personal, because I'm a big fan of Charles Marsh. I know him since long time. Probably he was doing Asherman when I was watching Tom and Jerry. So in 1 minute, can you tell me where is he now? Who is Charles Marsh? Because he's a big authority in Asherman. Have you met
Charlie?
him?
Oh, he's a good friend. Yeah. Charlie and I, we were in touch about once a week, but he retired. He's still in California. And he is thinking about moving to the East Coast of the United States. But as of last week, he was still in California. He's treated over 3,000 patients with Asherman syndrome, and his retirement project is to write up his results of those 3,000 patients.
Well, from Dubai here, I raise my hand and salute you. Keith, I appreciate your presence with us from the early morning, and everybody appreciate your scientific contribution and the valuable knowledge. So from Dubai, with love and best wishes. Thank you very much, Keith.
Thank you very much. Thank you.
Okay. So, ladies and gentlemen, now I introduce briefly the next speaker, and as I said, I like to describe him not a man living in the world, but the whole world living in a man. And this is not an exaggeration. You have to know about his contribution more and beyond assisted reproduction. No doubt he was the first gynecologists in my country and in the Middle East to introduce IVF. And he actually, at that time, the success rate were 6 and 8%. And he, with his perseverance, he stayed and developed until he became on the top. And this man stands on more than 200 publications. But what I adore more with his publication, his textbook reference about art. You should see his book about his collection of artwork, painting, and sculpture. I just wanted to give you a glimpse about the personality of the person you will meet now. Dr. Professor Muhammad Abul Ghar, the professor in Cairo University and director of the Egyptian IVF Center and the founder of the Art of Art in my country. Professor Abul Ghar, everybody is so excited, not only to listen, but to see you and to enjoy your wonderful storytelling about the future of IVF. Sir. Is Professor Abul Ghar with us?
Yes. I sent.
Good afternoon, sir.
Hello,
First,
how are you, Professor Osama?
Before the lecture, everybody wants to know, where are you sitting now with this lovely brilliant shirt?
On the beach on the North Sea.
Oh my God. So thank you very much for taking
I sent my talk recorded, so they will run the recording now.
Okay,
they should run the recording. I sent it a week ago.
And then maybe
and then if you have discussion, I'll be there with you.
Thank you, sir.
The future of IVF. I would like to thank very much Professor Shawki and the organizing committee for their kind invitation. They have chosen the topic, the future of IVF. For me, this is a very important and very interesting topic. The first point is IVF. There are lots of unnecessary investigations and investigations which will not prove to be of any value, which were done before starting IVF. These should be revised. And I think that only very few investigations should be done before the IVF, which include ovarian reserve, AMH, and maybe basal FSH, thyroid profile, prolactin, and then the general condition of the patient, kidney and liver function should be assessed. And that's all. There are many tests which are routinely used now, and some of them are quite expensive tests, and these tests should not be performed because now there is a proof that these tests are of no value. Sperm DNA fragmentation and clinical outcome in a systematic review and meta-analysis was shown that over 30 studies, when we extract the data, the current sperm DNA fragmentation have really limited capacity to predict the chance of pregnancy, and there is insufficient evidence really to adopt routine using it, and this is a rather expensive test, and I don't think it should be done anymore. The uterine natural killer cells. In a systematic review and meta-analysis, it was shown that there was no difference in the pregnancy outcome or miscarriage rate or repeated unexplained failure of implantation stratified by natural killer cells. These tests, there is no evidence that they are of value. They take time, money, and then you have to treat these patients with very expensive treatment, and all is of no use. The time lapse for embryo incubation. Time lapse is a beautiful equipment to monitor the embryo during its progress. However, there is no proof that it improves the IVF outcome, and there are several randomized studies which showed no difference in the clinical pregnancy rate if you use the time lapse or you use a regular incubator. Now, with the use of artificial intelligence, time lapse may have a value, and the videos used by time-lapse may have an important role in the artificial intelligence in choosing the right embryo. The practice committee of ASRM said that antiphospholipid antibodies does not affect IVF success, should not be done, and all these treatments for this condition should not be used. And the assessment of antiphospholipid antibodies is not indicated for couples undergoing IVF, and therapy is not justified on the basis of existing data. What about the ERA test, endometrial receptivity test? In randomized and retrospective studies, it was clearly shown that the ERA test is of no evidence-based benefits. What about hysteroscopy? Hysteroscopy before the first IVF. This is a very common thing done in many clinics. And actually, in a multi-center randomized study, quite old, over 10 years old, where over 370 women were randomized in women in whom vaginal ultrasound showed normal findings. The clinical pregnancy rate was exactly the same in the hysteroscopy and the no hysteroscopy group. The conclusion is that women with normal vaginal scan should not be suspected to hysteroscopy. And hysteroscopy in recurrent in vitro fertilization failure. The trophy study is again a large multi-center study in young women with normal vaginal ultrasound and history of 2 to 4 repeated miscarriages. Patients were randomized, large study, 350 patients in each arm, and the live birth rate was 29% in each group. So hysteroscopy in patients with repeated failure is actually of no value and should not be performed. And this is again a very large study with 1,400 randomized patients, which showed again that the live birth rate is not affected if you do hysteroscopy, and we should not do hysteroscopy. What about laparoscopy if we want to do IVF? Laparoscopy is of no value. Once you decide to do IVF, there's no point in doing laparoscopy. Laparoscopy may be only used to ligate, separate, or excise the fallopian tube if there is a hydrosalpinx diagnosed by ultrasound examination. Otherwise, there is no indication for laparoscopy. What about endometrioma? Should we do surgery before IVF? No. A systematic review and meta-analysis in 11 studies showed clearly that there is no need to remove the endometrioma. And again, removing the endometrioma is dangerous because it might affect the ovarian reserve by removing part of the ovarian tissue. The uterine septum was a problem for many years because there were no good studies to tell us, shall we remove the septum or we keep the septum? Recently, 2 studies. The first was a non-randomized study, and this one I'm going to skip, and I'm going to concentrate on the randomized study by the same author from the Netherlands. This is an international, multi-center, randomized study of septum resection versus no resection. There was no significant difference in the live birth rate between septum resection, 31% live birth rate, and expected treatment, 35% live birth rate. So now, with the available evidence, it is clear that the live birth rate is not affected by excision of the septum. And here I'd like to warn you that section reception excision by unexperienced hysteroscopists might have serious problems and intra-uterine synecdoche and maybe perforation of the uterus, and doing an undicated condition by an not experienced hysteroscopist is a major catastrophe. There are lots of treatments, lots of drugs, lots of things given during IVF treatment which has no evidence, no proof at all. Heparin, for example, a systematic review and meta-analysis of 5 randomized studies, large number of patients, over 700 patients, no significant difference in the clinical pregnancy rate and live birth rate if you give heparin or you don't give heparin. What about different other lines of combined adjuvant treatment? Aspirin, antibiotics like doxycycline, cortisone like prednisolone. In a case-controlled study, all these combined treatment in large number of patients with the addition of estradiol patches or no estradiol patches, they are all of no value, no significant difference in the life birth rate. And all these treatments are time-consuming, expensive, and makes the IVF a more complicated management with no reason. Now, patients with poor ovarian reserve. This is a real problem. And lots of protocols were used trying to improve the pregnancy rate and the outcome of these patients. Actually, very few lines of treatment could do a minor change in the outcome. Giving DHEA was associated with higher rates of ongoing pregnancy, but the evidence was not good. Restudying and re-evaluating these studies after removing trials at high risk of performance bias, then the result was clearly shown that DHA is of no use. It does not improve the pregnancy rate if you give it. And the British Fertility Society clearly announced that this is not recommended for use. Intravenous immunoglobulin, there is insufficient data to recommend its use and its administration. It is an expensive treatment. It might have some risks, and there is no evidence whatsoever that it is of any use. And the whole immunological theory behind failure of IVF does not really have a good proof, and this should not be proved as it is expensive treatment for no reason. Recently, the PGTA, pre-implantation genetic screening, was used, and after some years of its use in the 90s, a very famous and well-known meta-analysis showed that pre-implantation genetic screening for aneuploidy does not improve the pregnancy rate. And since then, it completely stopped. Until recently, with the development of new techniques to study all the chromosomes, then it came to light again. And it is being used extensively in different parts of the United States. However, in Europe, it is used much, much less. There are many, many trials, but the good trials, the large randomized trials, failed to show that the PGTA increases the chance of women. The assumption that it is useful is not true based on 5 things. IVF fails because of aneuploid embryo. That's why we should test for aneuploid embryo. And this proved to be wrong, because aneuploid embryos, mosaic embryos, who prove to produce pregnancy and healthy babies. And again, doing PGTA was done to eliminate aneuploid embryos, as this will improve outcome. Again, this proved to be wrong. Elimination of aneuploid embryos did not improve the pregnancy rate. The whole thing was based on taking a single trophoctoderm cell from the blastocyst and assuming that it will present the whole trophoctoderm. And this proved to be not correct. And again, the baby is developing from the inner cell mass. And I take the biopsy from the trophoctoderm. Does the trophoctoderm has the same chromosomal findings like the inner cell mass? This proves to be wrong. And then ploidy does not change. The embryo does not correct itself. This proves to be wrong. So all these things prove to be wrong. That's why now there is no good evidence that we should use pre-implantation genetic screening for aneuploid. But doing it for genetic diseases and etc. PGD, this is another story. The practice committee of the American Society of Reproductive Medicine showed that the value of PGTA genetic testing has yet to be determined. The studies which showed higher birth rate have important limitations. So clearly, the American Society does not recommend this. In the future of IVF, there will be more of egg freezing. More younger women, unmarried, will come to do freezing of oocytes. This will improve the outcome of IVF because now we'll be using more younger oocytes and we will do less cases of elderly women. Stimulation protocols probably will be simpler. More long-acting drugs will be used. Patients will have 1 or 2 injections. Minimal monitoring. Monitoring could be done from home, and there are actually studies from Belgium in which the woman is giving a probe of ultrasound and she is directed how to use it, and the video is sent by email, so she doesn't have to go to the hospital for monitoring. In the future, artificial intelligence will be more involved and will be an integral part of IVF. It will be very useful to control the laboratory. It will choose the best sperm and the best embryo to be transferred. So in conclusion, results will be better in the future. Single embryo transfer will be routine in most of the cases, and IVF may become more cost effective. The idea of this lecture is that IVF could be done in a much simpler way. Very few investigations, very few surgeries are done before IVF, and minimal procedures done, and no new techniques or new things which should be first studied properly in randomized studies before it is being involved in the IVF. In this way, IVF will be cheaper, and we are going to keep the same results. And thank you very much.
Thank you, Dr. Algar. Can I open the camera?
Thank you very much, Dr. Osama.
The whole stuff. Sir, when you start talking, we don't want to lose you, okay?
I know I'm there.
Yeah, I know, because you create an atmosphere like when we listen to you, like Frank Sinatra or Umm Kulthum, okay? So we enjoy your wisdom as well as your science. So let me touch with you some points. Once upon a time, I was a resident and my professor was Dr. Abulghar, and he was telling us about how he deal with the IVF cases. And Professor Abulghar said, the patient sit in front of me and she wants to speak too much. I ask her only two things. Show me the semen analysis and the histography and shut off your mouth. Okay. Does this changes now, or you still find these two basic arms? Show me semen analysis, histography, I don't talk too much.
No, of course, there are some changes.
Yeah.
The AMH is becoming a very important issue. And I believe that any woman before going to IVF should have AMH plus her birth date to find out the age, because these two factors are the most important factors in deciding the success rate.
AMH alone or AMH
and
antral follicle count? And what is the minimum you accept?
No, it depends on the age. In younger women, you can accept any AMH, even it is 0.5, for example, nanogram. In a patient who is 20, 22, 25, if you are going to retrieve 1 or 2 oocytes, this patient with these oocytes, you can achieve a good pregnancy rate. But women above the age of 35 with low AMH, definitely they have a very poor prognosis. Women approaching 40 or over 40, I never touch them. I never touch them with IVF because they must have a good antral follicle count or AMH, and also they should be told that the pregnancy rate above the age of 40 is only 10-15%, above the age of 42 is only 5%, above the age of 43 is 0%.
Your talk, sir, makes my heart feel pain, because I see many patients in my country, 42 plus, many patients, and they pay a lot of expenses for IVF. So we should
the patients gets very upset and very angry when I tell them this, and I refuse to treat them. And I tell them that I don't want to let you pay a lot of money for drugs for the procedure. And finally, you will have a psychological depression following the failure. You better have the shock now in one day and finish it. Of course, in our area, the egg donation is not available in most of the countries. It's only available in Lebanon officially. But many patients, when I tell them about possibility of egg donation, they are shocked. And maybe 50% of them, or those who can afford, they come back and said, we want to do it. And I refer them to Greece or Spain, a center in Greece and a center in Spain, and I refer them there.
Sir, it's a very appreciated courage from you to mention this issue, because it's a very sensitive issue. And I add myself to you that egg donation doesn't look as ikhtilat and sab, but still there is no brave religious man to stand.
Both the Al-Azhar and the Egyptian church, both of them, they do not accept egg donation. But as a physician, I feel it is my duty to tell the patients what are the available lines of treatment, and to tell them that this is not available in Egypt. Of course, patients who look poor, who looks poorly educated, I don't discuss this. This I only mention to patients who it looks that they understand a bit and they can afford. And the first word I say to them, please, I'm going to tell you something. It will go through one ear, let it go out from the other ear, as if I have not said anything. If they are interested, they will ask more. If they are not interested, it's finished.
But sir, I don't want to expand the discussion into deep religious matters, but is it allowed in Iran? The Islamic Republic
in Iran, yes, it is allowed, and even sperm donation is allowed.
So this has opened the issue. Anyway, I don't want to speak more than this, but I wanted a confirmation from you that in some Islamic countries it's allowed. Another point, sir.
Yes, it is. It is not the country. It is the Shia and the Sunnis. I mean, in the Sunnis countries, Sunni people, it is not allowed. In the Shia, it could be done.
Okay. Well, another remark, sir. When you started the first IVF service in Egypt, I do remember that success rate was 6 to 8%. And then by time, maybe you reach 30 to 40 since maybe 10 years. But from 10 years till now, it is frozen. And that's actually confused me. The curve was going up, and suddenly you froze at 30%. What happened? What went wrong?
Well, the pregnancy rate currently in age plus 35, the clinical pregnancy rate is around 40%, but the take-home baby rate is only 30%. And this is the world results. I mean, this conforms with the ESHRI results, with the American Society result. The last year, the take-home baby rate was 34% only. And this should be very clearly explained to the patient in counseling, because if you do not tell this to the patient and you just tell her that your treatment of the IVF, this is not fair. The patient should know exactly, and not only orally, she should sign in the consent your assessment that the pregnancy rate is 30%, 20%, 10% in a certain age group. And I would like to in this particular question, to say something. In the last 4 years, the IVF pregnancy outcome in the United States and the Europe started to decline. It declines by about 2-3%. This is the general census in both countries. And there are different explanations for this drop in the pregnancy rate. My explanation is that new technology decreases the IVF pregnancy rate. Introducing pre-implantation genetic diagnosis, you are going to through lots of embryos which could have produced babies. There are many new things introduced, like the minimal stimulation, many other things which reduces the pregnancy rate. And there are many procedures which double the cost of IVF.
So, sir, the last question, because we never get enough from you, is a social question, and whether you feel free to answer or not, I'm not sure it's easy or difficult. Okay, in a life of a doctor, or in your life, percentage of reading medical stuff towards percentage of reading non-medical stuff, like fiction, art, culture, 50-50, 70-30?
No, it depends upon the age of the doctor and how many years did he practice. In the beginning, for me, it was 60 medicine and long hours in writing scientific papers and revising it, etc., and only 40% non-medical things. By the time the rate changed, now it is 80% non-medical and 20% medical.
God bless you,
now,
sir.
I really concentrate on the important things. I don't read lots of unnecessary things.
Yeah, I feel that this statement from you is the most attractive to the whole audience, to know how a life could be for a doctor and how he can balance between work, profession, pleasure, art, and culture. Sir, wish you enjoy more on the Mediterranean Sea, and enjoy some barbecue, seafood. And from everybody here, we send you a big kiss. Thank you, sir.
Thank you very much. Thank you, Professor Osama. Bye-bye.
Bye-bye. Bye-bye.
Bye-bye.
Bye-bye. Okay. I'm looking to the counter and I see that we have more participants joining. I think we doubled the number now, and we have geographical distribution from all over the world. I'm really glad and proud that the contents you listen now is not a traditional lectures in a dark room, congress rooms, with a speaker standing with a necktie and dark suit, but you listen to personal opinion. These things you cannot find in textbooks. So let's move to the next speaker. Professor Hassan Salam is a phenomenon, not only in medicine. As I told you, he was a companion to Bob Edwards when he was young. And also he witnessed the birth of ultrasound with Ian Donald. And he practiced in UK for a long time and moved back to Egypt, bringing all these technology. Ultrasound and IVF came to my country by this man. Dr. Hassan Salam is another extension, like Dr. Abulghar, of mix of culture, history, and science. You should listen his lecture about history of Greek civilization. I'm just stimulating you that what we can listen from this man is more than just optimizing embryo transfer in ART. Again, a man companion and friended with Bob Edwards and the pioneers of ART should have a vision about how to improve the success rate. Professor Salam, are you in? Where are you?
Yes, I'm in.
In what?
I'm with you.
Sir, we miss you very much. Can you open the camera to see? Can you open the camera to see your lovely smile, please?
Yeah, I will. I will when we come to the questions.
Okay. Well, I think we don't have time to listen to the history of Alexandria Library, which was dazzling to thousands of audience in a big conference. But now we are waiting your vision about how to optimize the embryo transfer in RT. Sir, the screen is yours.
Good morning, ladies and gentlemen. My name is Hassan Salam. I'm professor in Alexandria University. And I want to start by thanking Professor Osama Shawki for extending this invitation to me to participate in this beautiful and very successful Gyne forum that he is organizing every year and which is becoming a regular and very successful event in Dubai, and congratulate him on the success and also on the success of other endeavors he's doing in Egypt and all over the world. My contribution today is about optimizing embryo transfer in assisted reproduction. Now, this is the lecture outline. At the beginning, we're going to talk about the technique of embryo transfer, then the factors affecting embryo transfer, and finally, the management of difficult or intractable transfers. So how do we do the embryo transfer? Well, usually we put the patient in a lithotomy position. We do cleansing of the cervix with saline or any culture medium with the proper osmolarity and pH. We remove the cervical mucus gently in a manner not to injure the cervix, not bleeding. We measure the length of the uterus by ultrasound, although we could have done this before. We insert the outer teeth of the catheter under ultrasound guidance, and then we ask the embryologist to bring the embryo the embryos inside the inner catheter, and then we deposit the embryos either by the embryologist or by ourselves. This is, of course, if we are doing the post-loading method, as we are going to describe. Then we wait for about 30 seconds. We remove both catheters, and then we rest. We ask the patient to rest for about 3 minutes. Now, again, as I said, a lithotomy position. Most of the people will do the embryo transfer in the lithotomy position, as you can see here. We do the cleansing of the cervix with a swab, cotton swab or similar, gently, as I said. Then we aspirate the cervical mucus if we can see any cervical mucus, again taking care not to injure the cervix. Then, as I said, we measure the length of the uterus. Again, we know the direction of the uterus. Is it antiverted? Is it retroverted? And so on. We could have done this before, but of course the uterus can change position, particularly if the bladder is full or the rectum is full and so on. Then, again, as I said, we could have done a dummy embryo transfer before, which will tell us the direction of the uterus and again the direction of the cervix itself. Again, because if we know the direction of the uterus and the uterocervical angle, we can bend our catheter according to this uterocervical angle. Some women have a straight uterus, and sometimes we have a mild angle, a more obtuse angle, or a retroverted uterus. And here's the inner sheath and the outer teeth if we're going to do the afterloading method. And as I said, there are two methods of embryo transfer. There is the afterloading catheter, which means that you put the outer catheter, then we ask the embryologist to bring the inner catheter with the embryo or embryos inside it, as I said, and then we deposit it. On the other hand, some people like to do the preloading method, which means that they bring the catheter with the embryos already inside the catheter, and then they go with the embryos in one go and then deposit the embryos. This, of course, carries the risk of having a problem during negotiating the cervix, and then the embryos will stay outside the incubator for a long time. And as I said, we put the outer catheter, then we ask our embryologist to load the embryo or embryos. Usually, he or she would do this in between two air bubbles, and sometimes we have another drop in front, another drop behind, as you can see here, and making sure that the embryo or embryos are put in a minimal amount of culture medium. And again, as I said, we go inside the uterus. We make sure not to hit the fundus. In fact, the more away from the fundus you are, the better the results. Then we deposit the embryos slowly, gently, and then we wait for 30 seconds, as I said, and then we go outside. At least this is the way we do it. This can all be observed under ultrasound guidance, and as you can see here, when you inject the actual embryos, the culture medium drop which contains the embryos with slight air before it or after it, you can see these air bubbles going inside the uterine cavity. And again, we give the embryo back we give the catheter back to the embryologist, and she or he will look under the microscope to make sure that there are no embryos left in the catheter. If this is the case, we may decide to freeze them and put them in a subsequent cycle, or to put them back in the same run. Then we ask the patient to rest for 3 or 5 minutes, as I said, because longer than this is not necessary. So this is the technique we do it, and most of people do it this way. So what are the factors which affect the embryo transfer? Because people always ask us or ask about these factors. For example, what is the best position for having the embryo transfer? And there are different factors. We're going to see them one by one. What is the best position? People have experimented with the knee chest position versus the lithotomy position. But is it better? Well, this was a case control trial performed a long time ago by Engels, and they did not find any difference. In fact, only 50 patients versus 50 patients. What about general anesthesia? Should we give general anesthesia to the patient? Well, again, it doesn't seem to make much difference. This is, again, a long study which has been performed a long time ago, and it is only a case control trial. It is not a randomized control trial, but in all cases, there was no difference in the pregnancy rate, the clinical pregnancy rate, between giving general anesthesia or not giving general anesthesia. Acupuncture was also tried. And in fact, does it make any difference? Well, at the beginning, there were some randomized studies showing that it does give some benefit. It increases the clinical pregnancy rate. But some studies did not agree. And then when the meta-analysis was done by Tariq Touhi from St. Thomas's Hospital, London, there was no difference, in fact, between giving acupuncture or not giving acupuncture in the clinical pregnancy rate and in the live birth rate. And this is the forest plot. As you can see, this is the clinical pregnancy rate, and it does not change. What about being gentle and atraumatic and having an atraumatic technique? Well, this is important. This is a meta-analysis we have conducted a long time ago. And as you can see here, if you are gentle, you have a better result concerning the clinical pregnancy rate in the forest plot and also the implantation rate, as you can see here. What about having a trial embryo transfer before the actual transfer, a dummy embryo transfer? Well, people do this. And these are two studies from the literature, one by Khaldoun Sharif from Jordan and one by Raga Mansour from Cairo. And as you can see here, both of them claimed a better result when you do a dummy embryo transfer. For example, if you look carefully at the Mansour study, which was a randomized controlled trial where there was a better clinical pregnancy rate, as you can see here, 22.8 versus 13.9. Mind you, this was a study conducted more than 30 years ago, and as you can see, the results were not impressive. I mean, today, 13.1 is not really a very good success rate, and even 22.8 is not a very good success rate. So, but these were the results at that time, because Henne and Milke produced this paper in 2004. What they did is that they did the dummy embryo transfer, and then they looked again at the patient during the actual embryo transfer. And what they discovered is that the uterus changes position. It was antiverted in 623 cases, but when they went to the actual embryo transfer, only 608 remained in the antiverted position, and there were 213 in the retroverted position. But when they came to the actual embryo transfer, 118 of them became antiverted. So the uterus changes position. So it seems that doing the trial embryo transfer a long time before the actual transfer may not be that helpful as people may think. Full bladder. Is it helpful to have a full bladder? And the short answer is yes. This is meta-analysis by Ahmed Abu Satta from Canada. As you can see here, the clinical pregnancy rate is improved, the live birth rate is improved, and this is probably because the full bladder diminishes the uterocervical angle, which is usually the place where we have the problem. What about removing the cervical mucus before doing the actual embryo transfer? Now, these are two studies, again, Raga Mansour and Nabi, and actually they did not do a randomized study, and they don't work on actual IVF cycles. Mansour looked at the expansion of the dye. She put a blue dye, and she looked whether after removing the cervical mucus or without removing the cervical mucus, whether there will be expansion of the dye, and she found yes. And Nabi found, when he worked with real embryos, he found that there was embryo retention if you do not remove the cervical mucus. What about flushing the cervical canal? Some people like to flush the cervical canal with culture medium or a similar solution with proper pH and osmolarity. Well, Paul McNamee from Honolulu in Hawaii conducted a case control trial a long time ago, and he said at that time that he could improve the clinical pregnancy rate when he did flushing of the cervical canal prior to embryo transfer. But when we did our randomized control trial, we actually didn't find any difference thereof. What about avoiding the tenaculum? Well, nobody has done a randomized control trial to do this. You cannot. It would not be ethical to hold the cervix with a Volcellum just because you're doing a randomized study. But what Renato Fanchin has done is that he came up with a method to measure uterine contraction, and it was Lesney who did this study and studied these contractions when you hold the cervix with the tenaculum. And what he found is that there are some cervical fundal contractions from below upwards, and there are fundocervical contractions from above downwards, and there were some random contractions and opposing contractions. And let us stop here. So there were contractions. Yes, if you hold the tentaculum, you have more contractions. But let's ask ourselves a question. Who said that the contractions will come from below upwards, like the cervicofundal contractions are detrimental? Maybe they could help the embryo. And indeed, when Tremelin conducted this randomized control trial, he found by allowing some people to have intercourse around the time of embryo transfer versus those who are not allowed to have intercourse around the same time, he found that, or they found that, pregnancy rate was actually the same, no change, but the implantation rate, if anything, was better if people had intercourse. So these contractions are not necessarily detrimental. What about ultrasound-guided embryo transfer? Is it better to do an embryo transfer under ultrasound guidance? And the short answer is definitely yes. Well, the first people who did ultrasound-guided embryo transfer were strictly Italian. They used ultrasound to look at during embryo transfer, and what they said that there were advantages, like that the transfers can be done in the orthotomy position, that the catheter sweep can be accurately positioned, the fundus, ejection of the transfer bubble can be documented, and observation of the bubble is comforting to the patient. That actually we took things a little bit further. We thought that the important thing really is the uterocervical angle, because this is the point where most of people will have difficulty. The catheter will go inside the uterine cervix and then will stop at the internal os, and then this will be where this will be the point where difficulties can happen. So we measured the uterocervical angle, and we found that yes, some people do not have an angle in the first place. Some have a mild angle, a moderate angle, a severe angle, and some people have a retroverted uterus. So actually, when the first paper came on ultrasound people started to do this and published studies. Some of them were case control trials, some of them were randomized control trials. And you see, these 5 papers, for example, said yes, ultrasound helps you; it increases the clinical pregnancy rate. But then some other studies said no, it did not make any difference. So the answer was, of course, to do a meta-analysis, which we did many years ago and published it in 2003 in Fertility and Sterility. And what we found is that, yes, the clinical pregnancy rate is definitely increased, and the implantation rate is definitely increased, and also the ongoing pregnancy rate is also increased when we do ultrasound-guided embryo transfer. In the same issue of fertility and sterility, William Bucket from McGill University in Montreal showed the same thing, actually the same figures, because he did the same meta-analysis. So yes, ultrasound-guided embryo transfer helps increases the clinical pregnancy rate. But then came, and this was the Cochrane review at that time, which was published in 2007, including all these studies, even more studies than we had in our meta-analysis, and they showed that the clinical pregnancy rate is improved, the live birth rate is improved when you do ultrasound-guided embryo transfer. Then came this paper in 2008, and this paper claimed that it was a randomized control trial of 2,000 odd patients with ultrasound, and they said, well, we did not find any difference, and we think that the Cochrane review should be updated, which was done. And when the Cochrane review was done and the meta-analysis was done, and then the ongoing pregnancy rate showed improvement, but the live birth rate did not show improvement. But then we looked carefully at this paper, and we discovered that it is not really a randomized control trial, because people who did this from Liverpool used actually different catheters in both arms of the study. In one arm, they used a soft catheter, and in the other arm, they used a firm catheter. And then they say at the bottom of this slide, as you can see, that they wanted to pragmatically test 2 methods holistically, ultrasound plus echogenic soft catheter versus clinical touch with a non-echogenic soft catheter. So they used different catheters, which really violates all norms of randomized controlled trial, because when you remove this study, we actually find that yes, with more studies also which were published in the literature. Now the new Cochrane review, which was published in 2016, as you can see here, confirms that yes, when you do ultrasound guided embryo transfer, you have a better clinical pregnancy rate as well as a better live birth rate. Some people also used, I mean, all what we were saying before was about abdominal ultrasound guidance, but some people also use transvaginal ultrasound guidance, which is a bit cumbersome, of course, but some people use a very slim transducer, vaginal transducer, and they claim that they can do this. And some people even, and as you can see here, this is the vaginal ultrasound study, and some people even used 3D ultrasound. The group of Professor Alan Cherney when he was still in university. And as you can see here, published in 2005. Okay, so the next factor is the soft versus the rigid catheter. Is it better to use a soft catheter? Well, William Bucket did this study and meta-analysis, and he found that yes, when you use a soft catheter, you get a better result, a better clinical pregnancy. And another study by Abu Sata, another meta-analysis showed the same result. Yes, when you use a soft catheter, you have better results. However, they were not talking about ultrasound-guided embryo transfer, because when Ismail Abul Futuh from Cairo purified the study, did subgroup analysis and used only soft catheters versus firm catheters only in people who had ultrasound guidance. Now there was no difference, because when you do ultrasound as we do, we measure the angle and then we bend our catheter according to the angle, in which case there will be no difference between the soft and the firm catheters in terms of clinical pregnancy rate, implantation rate, and ongoing pregnancy rate. What about having air in the transfer catheter as I described before? As you can see here, there are 3 drops of medium. The middle drop contains the embryos, and there is a proximal one and there is a distal one. And between these 3 drops of medium, there are 2 air bubbles. Is this good or bad? Does it make a difference? And the short answer is no. Airing catheter versus no airing catheter. No difference according to this randomized controlled trial. What about the site of embryo deposition? Is it maybe, let's have a look. Well, Corollo conducted this randomized controlled trial, Corollo Italia. They conducted this study, and they showed that the further you stay away from the fundus, the better. You see, in group 1, they put the embryos at 10 millimeters away from the fundus, and the success rate was 20. But when they went a little bit away from the fundus at 15 millimeters, 131, and at 20 millimeters, 133. So yes, we should not be too near to the fundus. The same was done by Pope Italia, and what they have also found is that the more you stay, with each millimeter you stay away from the fundus, you increase your success rate, your clinical pregnancy rate, by 11%, at least according to their study. What about waiting 30 seconds before withdrawing the catheter? No difference. As you can see from this randomized controlled trial, there are not many patients, 50 odd patients, but at least in this study, there was no difference between waiting 30 seconds or not waiting 30 seconds. What about the time between loading and discharging the embryos? Sometimes you go with the outer catheter and the embryologist is coming with the inner catheter with the embryos inside them. And then you do not succeed into getting into the uterine cavity with your outer catheter, and the embryologist is waiting How long can he or she wait? Well, the answer is 2 minutes. As you can see here, the results, the implantation rate and the pregnancy rate did not change until 120 seconds. After 120 seconds, the clinical pregnancy rate dropped from 31.6 to 19.1, and the implantation rate again from 15.9 to 9.4. So 2 minutes should be the maximum for staying outside the incubator. What about having an adhesive compound to help the embryo stick to the wall of the uterus? Well, contradiction. Barhava, Italia, in 1999, conducted the case control trial and said it works when Feichtinger had done a randomized control trial, and he said it doesn't work. Again, Valugiardi tried the embryo glue, and he found no difference really. And now the verdict, and now we have a new Cochrane review, our Cochrane review, which was published in 2014, and they had that, and they said that the quality of evidence was moderate, and they said that it does help a little bit. As you can see, the live birth rate, clinical pregnancy rate, and the multiple pregnancy rate also was increased. However, in a different meta-analysis, we could not confirm these results. When we actually scrutinized the studies, we could not include them all, and when we included the real serious study, there was no difference really made by adding the adhesive compounds to the embryo transfer fluid. Another suggestion was to inject human chorionic gonadotrophin 500 international units prior to embryo transfer. Actually, it was Regaa Mansour from Cairo who suggested this, and she conducted this randomized control trial and said that it does increase the clinical pregnancy rate, and this work was repeated by Santi Bagnese, Italia, who found the same result. And then the implantation rate was also increased. When the meta-analysis was done of all the studies on the subject, it was found that if you add less than 500 international units, you don't get it. You have to add more than 500 international units equals or more than 500. And it only works in the cleavage stage embryo transfer. If you are adding blastocysts now, it doesn't really make much difference in terms of clinical pregnancy rate and also live birth rate. Another suggestion was the mechanical compression of the cervix after embryo transfer. After withdrawing the catheter, after embryo transfer and withdrawing the catheter, one can hold the bevels of the speculum tight, compressing the cervix like this. And this was another suggestion by Regaa Mansour, and it was a single study, and we are waiting for other studies to confirm this initial observation. Bed rest after embryo transfer has also been suggested. However, studies have shown that it does not really add much, and these are two randomized controlled trials and one cohort study. And when the meta-analysis was done, our Cochrane review was done, we found no difference in the clinical pregnancy rate or the ongoing pregnancy thereof. What about using routine antibiotics after embryo transfer? Now, the first question is, does infection affect embryo transfer? And the short answer is yes. These are 4 studies from the literature showing that yes, if you have infection, then your clinical pregnancy rate is going to be diminished. And the meta-analysis, which we have conducted many years ago, showed the same thing. Of course, the clinical pregnancy rate is diminished, and the implantation rate is also diminished. So what is the answer? What Patrick Ekbazi has done is that they added antibiotics only to those patients who had an infection, either at the tip of the catheter or in the cervical mucus. They cultured the tip of the catheter after embryo transfer, and when they found an infection, they added antibiotics. And by doing this, they improved the implantation rate and the pregnancy rate. However, by giving antibiotics to everybody across the board after embryo transfer doesn't seem to work, as we can see from this randomized study by Pekrishvili, Italia, published many years ago. What about the experience of the clinician? Does it really matter? And the short answer is yes. If you have, sometimes in many centers, the embryologist records the results of the different clinicians. As you can see here in the study, clinician A was doing much worse than clinician B. Clinician B had always a good pregnancy rate, while clinician A did not have it. And in fact, if you train the midwives, they can be as good as gynecologists, if not better. These are two studies, one from Oxford and one from Scandinavia. And you can see here the results were as good in both the nurses and the clinicians. And what Papa Giorgio found is that you really need 50 embryo transfers to acquire proficiency. So these are the factors that affect embryo transfer. Finally, we come to the management of difficult or intractable transfer, because sometimes you do many things and then you're stuck with an intractable embryo transfer and you cannot put the embryos inside the uterine cavity. So what do? Well, the first thing to do in these cases, of course, is to change the catheter. There are catheters with a stylet, and then this allows you to bend the catheter according to the angle of the uterocervical angle, as we said, which is usually the place where the difficulty is present. So we bend the catheter according to this using a catheter with stylet. But if it doesn't work, there are other options which we are going to show here. So here, this is the catheter with the stylet, as I said, which is specific for difficult transfer because it has the stylet, which one can bend according to the inclination of the uterus or the angle at the uterocervical. Then people have tried to do transabdominal transmyometrial embryo transfer, to do it through the tummy and do a transmyometrial embryo transfer. To cut a long story short, it is not successful. They have also tried to do it transvaginally, as you can see here. The needle is going through the vagina, guided by ultrasound, as we would do with and then the catheter is put inside the needle, widely bore needle. But again, the result was not very impressive. Another possibility, of course, is to do zygote intrafallopian transfer, is to do our embryo transfer through the fallopian tube. Of course, this is only if the fallopian tubes are clear, like cases of ICSI, for example. But of course, this is a more complicated answer to the problem. Because the best answer really in these cases is to freeze all the embryos and then do the embryo transfer at a subsequent cycle, after which one would have sorted the difficulty in the cervix, even by doing dilatation of the cervix or using maybe a hysteroscope to do this dilatation, and then do the transfer of the frozen embryo at a subsequent cycle. And this is the meta-analysis showing that if you freeze all your embryos and put them back, there is no difference really, even if you put them at the cleavage stage or the blastocyst stage, you still have the same live thread. And although in fact the Cochrane review shows that you even may have a lower incidence of miscarriage, and maybe nobody knows why exactly, but this was the data as you can see them in this Cochrane review actually. The frozen embryo transfer, the clinical pregnancy rate. So in conclusions, ladies and gentlemen, the following procedures have been shown by randomized control trials to improve pregnancy rates. 4 things. Doing the embryo transfer under ultrasound guidance, putting your embryos in the mid-fundal deposition away from the fundus. The soft catheter is better than the rigid catheter only if you're not using ultrasound, and then performing the embryo transfer with a full bladder. These are the 4 things that have been shown to improve pregnancy rate. And meta-analysis have also shown that two things significantly diminish the pregnancy and implantation rates: difficult embryo transfers and cervical infection. But there are a group of factors which do not affect pregnancy, and randomized studies have shown that these things do not affect pregnancy, like staying in bed for a long time, waiting 30 seconds after embryo transfer didn't make much difference, having sexual intercourse around the time of embryo transfer, the presence of air in the embryo transfer catheter, or the routine use of antibiotics. All these things do not seem to change the pregnancy rate. And finally, there are things which need still to be evaluated, like the position of the patient during embryo transfer, under general anesthesia, dummy embryo transfer, the removal of cervical mucus, flushing of cervical canal, avoiding the use of a tenaculum or a valcellum, and the use of a fibrin sealant. All these things have been suggested, as we said, but the results are still not conclusive, as we hope. And finally, in difficult or intractable transfers, there are options. Changing the catheter is the first option. Then transabdominal, transvaginal, and zygote interfallopian transfers are not really very good answers, because the best answer in this case is to freeze all and put the embryos back in a subsequent cycle after dilating the cervix by dimple dilatation or hysteroscopy. And with this, I come to the end of my presentation, and I would like to thank you very much for your attention.
Dr. Salam, can I see
Yes,
you?
I'm with you. Yes, I'm with you.
Yeah, please move the camera. Let me see the wonderful face with the silver crown.
Yes, I'm opening the camera, but I don't know if you can see me.
You are in
Can
the
you
car.
see me?
Yes,
Yeah.
I see you quite well.
Yes,
What a nice skirt. Okay.
Well,
Okay, well, you are giving a big example to everybody that being retired and whatever time and age, but you live like a young chap like Tom Cruise on the beach.
well, he lives like me. Yeah, but I still work. Not exactly on. I'm just on a
don't
break.
tell me that the attitude I see is not work. And if you move the camera,
not today. I'm not working today. Yeah, today I'm on.
Can I know who is sitting in the next seat, please? Or can you move the camera to see who is the lovely Nicole Kidman or Angelina Jolie?
No, not Nicole Kidman.
Not
she's
today.
My wife. If you
not today.
She's more beautiful than Nicole Kidman. No, don't worry.
Okay, yes, I know. There is 270 persons listening to you. Okay, now I see the handsome, elegant Yaqub Khalaf sitting in his chair and charging. You should listen to Yaqub this morning, okay? He bombarded me. He bombarded me because of the hysteroscopy and IVF. I couldn't even argue with him, you know. It's very injurious to argue with Yaqub, okay? You feel that you are walking on a minefield, okay?
Professor Yaqub, he is in a class of himself.
Definitely. And I mean, his credibility makes everybody respect him. You cannot argue. He possesses the power of truth in his hand.
Very kind of you. Very kind.
Yeah, and also the high level of science and of everything. Really, he's a role model for all obstetrician gynecologists.
I want everybody listening to us now to understand that this man have never reached to this position and these titles out of nothing or easy or just by practicing like anybody and reading a journal every month. No, he is a formula of success and social intelligence and clinical intelligence. Dr. Yaqub Khalaf, born in Egypt in the city of Asyut, and quite few people know that he received his primary education in Al-Kuttab. Dr. Salam, do you know Al-Kuttab?
Of course, I know. I mean, all of us, our parents, and so on.
And the teacher used to, to yilahlebu by the stick when he makes mistakes. So he learned under complete strictness. And I think that he developed this kind of hard, tough, and seriousness in his life. And then in UK, definitely he became second to none. His name is known for everybody. Anyone has a problem in infertility or wants a consultation, they go to him. And you know, Dr. Salam, 2 years ago, I saw in the newspaper that there was an article. They chose one of the top surgeons for myomectomy, and he was chosen among them. And I felt really jealous and angry. Where is me? Okay, I am one playing all my time in the operating room. So Yaqub also jumped to be one of the best myomectomy surgeons, and this actually triggered pride and really happiness. So Yaqub Khalaf, professor of reproductive medicine in Thomas Guy's Hospital.
And surgery.
As I said this morning, his signature makes the guidelines. So everybody stand up, open your ears, be ready to the explosive guidelines from Yaqub Khalaf. Are you hearing me, Mr. Yaqub?
Thank you very much. Thank you very much, Osama.
Screen is yours.
You are always extremely kind and generous. And this is a trait, an Egyptian trait with a lot of compliment, including the ones by my role model, Professor Hassan Salam. You talk about my toughness. In actual fact, I am not tough at all, because when you give me this title, I have never come back to you to saying, what do you want me to talk about? And I was lucky because both Professor Abulgar and Professor Salam covered some practical issues to do with infertility and spare me the tedious task of going through guidelines to talk about what works and what doesn't. So I have chosen to speak about guidelines for infertility treatment as a concept and use the process to mention a thing or two that guide my own practice. So clinical guidelines, we know that these are most of the time useful documents because they incorporate the scientific evidence in health decision, and they help us make a decision in the clinic through the recommendation they are so. We are familiar with so many of them, from ISHRA, from the Royal College, from NICE, from any of the Society of Assisted Reproduction in the United States, ASRM, and the lot. And we all the time having updated guidelines, and most of the time they are extremely helpful and they clarify issues. But if we come to the generic description of a guideline, these are systematically developed statements to assist us as practitioners and our patients about appropriate health care for evidence for specific clinical scenario. Guidelines are evidence-based tools that are developed with a thorough methodology. Most of the time it's systematic and painstaking and involving experts. Sometimes it may not be the case. So when they are high quality, they appraise the use of the resources, how much value you get for your money, how much the healthcare system gets value for the money invested, how much the patient concerned get value for money for the investigation or the intervention proposed. They also talk about applicability or external validity of the data that have been proposed and that consider patient values and preferences. It is clear to get hold of this fact. Guidelines are not recipe books. You put a bit of this and a bit of that and you get the best soup. That doesn't work like this. And they have limitations. And for the best use of guidelines, you really need to be a discerning clinician. You need to have good working knowledge of the subject that is being addressed by the guidelines, because you can't just follow them blindly as a recipe book. You have to have your input, your context, your setting, the type of patients, and you have to have the background that enable you to apply them successfully. This is a sad fact of life. Even clinical guidelines must be critically appraised as their quality is variable. And that is a fact. And I may come to some of this, elaborate a little bit on this. We all know that there are good clinical guidelines and there are bad clinical guidelines. When they are good, they can improve health outcomes by promoting intervention of proven benefit. And they tell us that this intervention is not good, like recent guidelines say from ISHRA, talking about something that's so expensive and invasive and potentially harmful called the endometrial receptivity, as say it is clear that it only wastes money, it doesn't add value, it doesn't help increase success rate, and it is not inexpensive. So the guidelines are clear, it's not to be recommended. And I could go on and on, but I'll be happy to take any question about any intervention you seem to believe in or you use in your clinic and you have doubts, and I will give it my best shot. It can also improve the consistency of care because you know that this is being applied, it is being validated, it is being supported by robust research, so you will use it all the time as a consistent approach. It empowered patients to make more choices and to consider their needs and preferences in selecting the best option, because one size does not always fit all, and we need to be able to give patients alternative to empower their decision-making. Guidelines make sense when the practitioners are clear about appropriate practice and when scientific evidence can provide the answer. They are poor remedy in other settings. If you are looking at the guidelines to give you the baseline information, to give you the contextual setting, to give you everything, and you will be just automatically doing this, that is not a remedy really in your setting. The other thing about guidelines, that, as I said, there are good clinical guidelines and there are bad clinical guidelines. And William Shakespeare said a long time ago, there is nothing either good or bad, but thinking makes it so. So what makes for bad guidelines are the ones that are not really well balanced by facts. Those are the ones that suffered from conflict of interest. And we live in the real world. People will be sitting around the table, they are big names, but unfortunately, they're not free from conflict of interest. They will have some intellectual interest, if not commercial. So there will be an element of horse trading around the table, and people will make compromises, even at that level. And if we are not fully aware of this, we will be misled. Because in one of the guidelines, there was something about recommending DNA fragmentation testing for recurrent implantation failure. That is insult to intelligence. Because if everything we know about the cause of failure of IVF is only restricted in DNA fragmentation, that has no bearing whatsoever, there is nothing to validate it, then we are missing a trick. Luckily, that has been removed from subsequent guidelines, and also that was born out of conflict of interest. And I'm using this as an example, but there will be a lot of examples where horse trading has been in action when those guidelines are set. Medical care should ideally rely on research-based evidence of what helps and hinders optimal outcomes. When indicators of what helps versus hinders optimal outcomes are known, patients should be able to depend on us to provide care. And when we apply this, they should be able to trust us and they trust our decision-making. Are guidelines always followed on daily practice? Not really, but let me just dissect this a little bit. We all aware of evidence-based practice and we talk about it, and it is more or less, whether we like it or you loathe it, it is an established concept. However, most welcome it because who wouldn't like the evidence? Some have misgivings about it and they say, in my hand, things are better, in other hands, it may not, and all this kind of bit of trying to grapple with accepting it. Others ignore it altogether, even if it is repeated and it is here time and time again. And the clearest example in our world is doing ICSI for everyone. The evidence is clear that if the sperm is healthy, the patient does not benefit from doing ICSI, and conventional IVF will be the better choice. And year on year on year, data from large registries shows that when you do ICSI for non-male factors, the outcome is not as good as if you did IVF, but still there is almost consensus in ignoring these facts in different parts of the world. The word evidence is the most used and abused and misunderstood part, sadly, because it means different things to different people. Even when the willingness exists, the ability is challenged. Our ability to discern what is good evidence from what is bad may not be equal. Competent evidence synthesis is valuable. If you have a Cochrane review, you have a systematic review that was done with the context in mind, with the clinical context in mind, with the ability to do evidence synthesis that makes sense and change practice, that is hugely invaluable. But unfortunately, the word meta-analysis is almost a dirty word now, because it is a secondary research that is practiced by huge amount of people, and they put apples and oranges and pears and strawberries, and they try to convince us that they are homogeneous. And invariably, the outcome is misleading, and it is negated by a decent multi-center randomized controlled trial. And there are ample examples of this. The medical misinformation mess is the main threat to good practice. In terms of the literature, in terms of our assessment of the literature, is nothing but a jungle. In ideal world, you should be able to adopt this approach to try to practice evidence-based medicine. You are sitting in your clinic, you have a clinical question you would like to ask. And it seems easy. Unfortunately, most people cannot articulate a universal clinical question that they can ask. They will always talk about specific scenario for a patient with certain set of this, and sometimes, unfortunately, that narrow your availability of evidence to guide you in your practice. Once you ask that relevant clinical question, you acquire the best evidence from the literature, and we know where the evidence, the best evidence comes from: randomized controlled trial, systematic reviews that are decent, or Cochrane reviews. And you appraise that evidence, and then once you have made the appraisal, you apply it, and then you assess the performance of what you have applied, and the circle go on. Can evidence and practice coexist?
O sea, que se puede meter para acá y si Kiko está aquí, así sea en el patio, se lo comen. Porque
One of the audience having their microphone on. And we ask them, please, kindly to switch their, mute their microphone.
Hello, please, my dear audience, I appreciate your enthusiasm, but your phone is the mic. You have to mute your sound, and then you can open after the end. Thank you. Yes.
Thank you. Can evidence and practice coexist?
¿Y dónde?
Hello, my dear friend who is talking on the microphone now. Your sound is heard by more than 200 doctors, and this may be disturbing to the speaker. Please mute.
Muted now.
Sound. Yeah. There is down on the left side, there is a sign of a microphone. Press to mute.
Thank you.
Sorry, Professor Yaqub.
Can they exist? Of course they can exist, evidence and practice. How? Because we have no shortage of data and access to information. If you look in the literature, you'll find 21 million articles in PubMed tagged with human. Around 1,263,000 articles identified as clinical trials. 2.5 million as reviews. Approximately 200,000 are systematic reviews. Nearly 1 million articles on human are added each year. So we don't have shortage of resources. And we are also aware, whether you like it or not, the clearest example for evidence for any intervention is a proper randomized controlled trial, where you can confidently say it is shown that this intervention makes a difference or it doesn't. And the lowest on the ranking is the expert opinion, no matter who that expert is. Unfortunately, is not a competition with a randomized controlled trial when it is good. Should evidence and practice coexist? Yes, of course. Why wouldn't we want to have this? Why? Because you can imagine the consequences of shooting in the dark when you are making decisions without any guide. And also, it is intellectually stimulating to have evidence in your practice because it leads us down the path of exploration and lifelong learning. It's not just better medicine for patients, it's also better medicine for those delivering clinical services. They know they are spending their money wisely, they know they are doing their practice safely, and so on and so forth. We asked about the theoretical scenario of can they. Now we're talking about do they. Unfortunately, if you are cynical like me, you will say, no, they don't exist. If you are a moderate person, you say they exist, but not always. And here I will tell you why. Because plenty of unreliable evidence out there, from fabricated studies, fabricated randomized controlled trial, very creative analysis, very creative reporting, to non-discerning practitioner who can't really use the context to believe or not believe. There was a study the other day published in Fertility Sterility about using progesterone in recurrent miscarriage, which suggested that if a patient uses progesterone in recurrent miscarriage, her rate of miscarriage will be 3.5%. That is too good to be true because it's not human. Normal human beings will have a miscarriage rate of 14%, and that will not change. Now, anyone who knows the context would have thrown this out in the bin before even being subjected to review. But it found its way to being published in Fertility Sterility, only to be removed later from Cochrane review because the results were implausible. So we need to be just using our context and our brain to discern without needing even systematic review if we can. Commercial influence, intellectual prejudice, inaccurate mass media stories and claims. When it comes to unreliable evidence, I don't have time to go through this, but those of you who are interested, I would highly recommend reading this very insightful article describing what information we have in the literature without critical analysis. It is the medical misinformation mess, which comprises that much of the published medical research is not reliable or of uncertain reliability and offers no benefit to patients and is not used or is not useful to decision makers. Most healthcare professionals are not aware of this problem. They also lack the skills necessary to evaluate reliability and usefulness of medical evidence. Patients and families frequently lack relevant, accurate medical evidence. The only medical evidence they have is their friend on Google Chat used that intervention and she got pregnant, which is a recipe for disaster. And this is a paper, How to Survive the Medical Misinformation Mess. If you are really keen on getting a bit of clarity in how you approach the literature, I would highly recommend reading this article. Non-discerning practitioner. We are willing to believe anything. If we are told that this little intervention doubles the pregnancy rate, we will embrace it. And we never ask our question, is this even biologically plausible that anything can double the pregnancy rate? And healthcare professionals, unfortunately, they are needed to be tested. And in this exercise that happened in 2017, some not average clinician, there are people who claim that they can recognize the absence of control group in a study to understand the issues of underestimating the benefit of an intervention, to determine whether an intention to treat analysis was performed. Very simple, basic stuff. You will not believe that surprisingly among those feeling confident to evaluate medical literature, 72% failed that simple test. So we assume that we know it all, but we don't. Our knowledge of how to critically appraise the literature is sadly challenged. And I always use this very helpful ladder, the level of competence. You can begin from being unconsciously incompetent. Once you have been made aware and you had the insight, then you appreciate that you are consciously incompetent. Then you try to do something about it. Then you become consciously competent. You have learned something, but you're still really finding your way of practicing it and understanding it until you get to the ultimate of being unconsciously competent. You use your brain, you use your knowledge, you use your discerning ability to find. And unfortunately, most of us are in here between either unconsciously incompetent or consciously incompetent. And that's why we can be sold a dummy every day. Whatever people claim, we are happy to take it and embrace it and apply it and charge our patients for it. So most clinical trial results may be misleading or not useful for patients. So without critical analysis skill, coexistence of evidence and practice remain aspiration. I can hear some of the audience crying and say, but it's just too hard what you're saying. You're making life so hard for us to use randomized control trial or use the literature. I know it is hard, but it is not hard if you really try to just read a little bit, be critical a little bit, and exercise your own judgment. This is a title of a paper in New England Journal of Medicine, Making Evidence-Based Medicine Doable in Everyday Practice. It can, and there is the literature to support you to do this. And nobody said it was easy. It will always be difficult, but when you can't have anything valuable in your clinical practice without some difficulty. Because without this, what we are left with is Google. And we know that well-established fact can be disputed if you Google them hard enough. That is not a good source for knowledge about intervention, unfortunately. We also have to contend with what is happening now, where patients come with a list of investigations and intervention, and they would like us to do them. That is patient-to-consumer healthcare revolution, it's called. In any decent society, that should not be propagated, because if the patient decided to do away with my insight and my input as a decent and competent professional, then I might as well work in Sainsbury's supermarket and give the customer what they come to have. But if I am a clinical professional, I should be able to give her my honest assessment of what worked for her and what doesn't. And if she failed to accept this, then I am not a clinician for her. She needs to go to the right supermarket or the right clinic that will give her what she asked for. There is also the commercial influence, unfortunately. That's the drugs, the intervention that bring more money will always be promoted and will always be marketed without necessarily. And people have already marked that their expected profit, annual profit, and they are not accepting it for this to be low down by discounting an intervention that used to give them most of this money. And I don't need to be preaching to you, ladies and gentlemen. What is right is often forgotten by what is convenient. So we do the easy, the things that we know. So we don't, for instance, know how to do a good ultrasound scan, then we do the thing that we know. And it is not always a good idea, because we can do something less invasive in preference to something that is invasive. But when the invasive is needed, we try to dabble with it rather than asking someone with expertise that will give the patient the best result. And we also do something very interesting. You heard about the evidence triangle. We decide to turn it upside down. Here is a randomized control trial, but all the time we say, my opinion. Your opinion is respectable, but when we are debating something political, even political, you could go to prison. But when it comes to science, there is something called evidence and objective evidence. Your opinion is valuable and we respect it, but it can't serve as evidence. And when you sometimes are having dinner with a group of friends, talk about intervention, you said, oh, in my hands, really, I get good result. What's good result? Patients get pregnant. Patients get pregnant with this, which I have in my office. I don't know whether you see it, with Polument. Does it mean that we go prescribing Polument to all patients? So it is a little bit of common sense need to be injected into that exercise. So we can increase the reliability of the answer to all of this if the reliability of available published evidence would help us. But unfortunately, this may not be eminently reachable goal. So what is the answer? The way forward is to get educated as to what constitutes good evidence and what is not, to get trained in the clinical setting, how to critically appraise literature to detect flaws, biases, and misconduct. And the evidence suggests that standalone teaching can improve the knowledge, but not the skills, not the all-important, that is attitude or behavior. Clinically integrated teaching, that's not theoretical, that we apply in our practice, improve knowledge, skills, and attitude and behavior. So I can see someone of the audience getting confused.com and asking, can you please tell us how to do better? The answer is simple. Don't lose sight of what is important. What is important has already been established after 45 years of IVF. Patients are the main determinants of success. A patient who's 45, you need to be the messiah to give her a baby from IVF. Ovarian reserve is a crucial marker. So if the patient is having AMH of 0.3, you will not make her more fertile by doing a hysteroscopy. Ovarian stimulation. If you do it tentatively, you will undermine the patient potential. If you do it aggressively, you could get the patient into intensive care unit. How many eggs the patient get will determine how much chance of leaving the clinic with a baby from replacing the frozen and the fresh and the frozen embryo. What quality control you have in your lab, how you conduct your embryo transfer, and you heard to a detail that the expert account of that from Professor Salam, how you prepare the endometrium for frozen embryo transfer, how you don't overlook some lesion that could undermine the endometrium ability to be receptive, like intrauterine adhesion, you decide to ignore, how you support the luteal phase just by the standard progesterone. You don't need to give them a pharmacology book where you give them anything from the weird and wonderful because you decided to improvise and to strain when you do IVF, which is invariably wrong. And to remember that resilience is key. Patient resilience, her financial ability to survive this marathon will be undermined by the unnecessary intervention that most of us sometimes do. And one fact I would like really to remember, that IVF 45 years, not a month, but back we celebrated 45 years of IVF. So all the low-hanging fruits have been picked. The essential, the things that make a difference have already been established. So please do not improvise with small little things and claim that they will make the world better. And this fact tend to get forgotten. Age is the most important determinant. Whether the patient has few cycles or one cycle, younger patients have more likelihood of leaving the clinic with a baby. Older patients, unfortunately, with perseverance, their chances increase, but will still be limited by their biology. And no intervention will alter biology. That is just a fact. So we need to stop improvisation according to biological plausibility. Because if you say, like, for instance, there is something called coenzyme 10 that people prescribe to improve egg quality. Total and utter nonsense. And why? Because someone told them that this coenzyme 10 will act on the, if you remember, Krebs cycle will increase ATP, and ATP will increase energy in the egg. All of this is good academia. But when it comes to practical application, there is not a shred of evidence to support it. And if you use this analogies, you will be like the guy who said, atoms are invisible, and we are made of atoms, so I must be invisible. That is just total and utter nonsense. The logic can't go that way. We need to stop exploiting patients because they are vulnerable and they will listen to what we have. And that can only be by clarity of evidence and using the guidelines wisely and discerning when it comes to the literature. Thank you very much.
Well. Always you exceed the expectations, Dr. Yaqub.
Thank you.
Just I want to make you happy that the number of audience has been escalating since you started talking, right?
Thank you. Thank you.
You are really very strong in your points of view. And I do appreciate that. I have only two, not comments, but observations. Two observations.
Thank you.
The world of gynecology, there is assisted reproduction specialists, the IVF people, and there are the endoscopists.
Yes.
Hysteroscopy, laparoscopy, okay? Yeah. And they meet at certain points and disagree in many points. The observation, which is very funny to me, why always the assisted reproduction specialists are always criticizing, bombarding the endoscopists, while the endoscopists have never, ever interfered in the business of ART. They don't tell them, no, transfer should be day 5, day 3. No, we know our business, okay? We don't. And the problem, Yaqub, listen, yeah. I tell you from my point, I have seen a study about the septum, many studies, like a systematic review.
Yeah.
Most of the studies performed in an IVF center by IVF people, the results was far low than the studies done in a professional endoscopy. This is life, okay? So I can find the excuse for IVF people when they try to do treating for the septum and they don't have results. And Dr. Abulghar has clearly set the example of the TRUST study, which I hope everybody remember again. maybe you didn't notice what Dr. Abulghar said.
I did.
It was a comparative randomized study, and the result, the arm of patient treated by hysteroscopy has a less pregnancy rate than the arm of patient, the conservative not treated. So the answer is very clear that your intervention did some damage and led to the result is less. And this was proved by analysis of the study that many of the patient on the second look, the septum was there. Many of the patient has fluid overload, complication, bleeding, blah, 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 which means that the septum procedure was not done perfectly. And at the end, I forgive me for the audience if they don't speak Arabic. كلثوم قالت, the famous singer كلثوم قالت, يلا ظلمتوا الحب وقلت وعدت عليه مش عارف ايه. العيب فيكم، العيب مش في الحب. I'm sorry to say that. So you cannot build a conclusion on a technique. Depends on performance, handicraft. Because if you do a test about the taste of pizza, if you do the study in Mozambique, pizza is tasteless. But if you do it in Italy, yes. So I think it's very unfair to judge a technique. Depends on skills. So this is my observation. And as always, I want to leave the door open between me and you. So next time you scold me again.
No, Sam, it's not really about you and me. It is about just there are differences in concepts.
Yes.
From your perspective, you are forgiven. You are obviously a very distinguished endoscopist and world class. I'm always fascinated by your demonstration and by your skills and everything else. And nobody will take this away from you. But the difficulty that you have is always focusing on the same point. What you don't appreciate, and so many people may not appreciate, that if you do just an ultrasound scan, whether it's ultrasound or saline or whatever, and establish that the cavity takes a tick, in patient under 37, when they had 3 euploid embryos, that they were chromosomally normal, over up to 3 cycles, 94% of them left the clinic with a baby, which means all that uterus you are talking about and making it the be all and end all, we're talking about 6% for the endometrial factor. Don't wish to undermine it, but we cannot see the whole world from that narrow scope. We must be open-minded and know that there is more to conception than this. And also the chance of a septum is 2%. We are left with 98% to grapple with, rather than taking it all back to whether we agree or not. But if you wanted the aggressive side of me, I can tell you honestly, and this is a confession I make, there are much more respectable people in the minimal access arena, and I like them, and I know they are discerning, and they can stand up and don't agree with going with the motion. But the majority, with respect, you don't look for evidence when you are looking at surgical journal, because it is difficult to get any decent randomized controlled trial for surgical intervention. It is not easy. So people always will be influenced by their attachment to the technique, to the surgery, to the equipment, to whatever they have. So we need to keep an open mind with this.
Okay, Yaqub, because the discussion between me and you will never end, but I'm sure everybody is enjoying this debate. So I was deliberately referring to the septum case because Dr. Abulghar mentioned it, and everybody considered Dr. Abulghar is a reference. And the man is very scientific. He quoted what the trust people said. It's 21 doctors over 18 years, and then the randomization, blah, blah, blah. But there was a criticism for the study and showed it on. But my question now, you said there is no evidence by RCT, blah, blah, blah for the septum. My question, simple question, why there is no such noise about the submucous fibroid?
No, there is, to be honest.
Why? Everybody doing submucous fibroid and there is no objections.
There is, it is slightly different because the submucous fibroid does not come in isolation. You'll find menorrhagia with it, and you know there is 90% chance of solving it. So there is additional factor. But back to the septum. The current level of evidence is not really sufficient to say do it for everyone or don't do it for anyone.
Agree.
Okay? So we have to just keep an open mind. So removing it not a must, and ignoring it is not something that also we need to recommend. So we remain with individualization and not getting too biased or too excited.
Totally agree. But before I finish, you actually mentioned something very important. Which septum case will benefit from intervention? Because honestly, I have done the largest number of septums in the world. And I have seen many cases with septum with previous normal 7 vaginal deliveries. Can you imagine? She has a complete septum. Okay, so this exists. But we did a study, me and Hassan Ghaffar, long time ago, to try to understand what kind of septum is more poor reproductive outcome. And Hassan Ghaffar is an excellent sonographer, and I did hysteroscopic resection of piece, biopsy of the septum. And what we found, that septum is musculofibrous, it's not fibrous as people thought, and the poor reproductive outcome is in the more predominantly muscular. So again, it's what people think, that the more muscle component, is the more abortion and preterm labor. So probably this can open a research avenue to know which patient deserve correction. Are you happy now?
I think we need to have evidence in all this, and because only with evidence, when you have complication, you will say, I didn't do it because I like it. I did it because the evidence indicated that I should be doing it.
Do you need an evidence to prove that jumping from an aeroplane without a parachute that you will die or not?
But that is not like this at all. It's far from it. You consider yourself, you conceded that there are so many women that we see having 4 children and they have complete septum, including the vaginal component.
Agree. So I am talking about a patient, 2 years of infertility, coming to you, and the only thing you see is the septum.
But
so you will tell her, I will wait for the evidence?
Osama, I think you need to
certain indication.
Osama, you need to come and spend some time with me, because your knowledge in minimal access is outstanding. Your knowledge of infertility can be helped. Yeah,
I am zero in infertility. Yes.
So then we can.
I agree with you.
Yeah. Thank
you. Okay. Well, so Yaqub Khalaf is never enough, and truly from my heart, I swear to God, it's enjoyable to debate with you. Thank you for being with us from the early morning.
Appreciate it.
And now, as we are, actually, we don't need a coffee break. Why to have a coffee break? Let me share this. So for the audience with us now, please stay with me and watch this. As I said, Zoom made life more easy, more convenient. So instead of sitting on a dark room in a conference with everybody in a suit and necktie, bored and almost sleeping because of the boring atmosphere, now you are following this fantastic event, sitting in your home or in your desk, watching it. Or like Dr. Abu Ghar and Dr. Hassan Salam, they are on the beach. Come on, what a beautiful solution, okay? So everybody can enjoy and still can live his life. So you can watch everyone and share with everyone. And I want to introduce the next speaker. Let's now fly from UK to the city, country of charm. They call it the charm of the Middle East. Who's in the world who's not in love with Morocco? Most of the movies, Hollywood movies, were done in Morocco. The movies of Casablanca is done in Morocco as well. So from the city of Rabat, it's my pleasure to introduce a wonderful human being. Today, you have met some doctors, expert in IVF, like Dr. Abulghar, Dr. Yaqub Khalaf, and some are experts in endoscopy, like Keith and others, and also Tony. But the exception today is Jamal Fikri. Jamal Fikri is the president of the Moroccan School of Infertility. He has a very large, reputed IVF practice, touch wood. That's why he changes his Ferrari every year, okay? We are poor, the endoscopists, we are poor, not like IVF. But also, Jamal is a fine, talented endoscopic surgeon. I confess that all my skills only inside the uterus, but Jamal is player inside the pelvis, inside the uterus, and in the lab of IVF. So I presume you will enjoy the fantastic presentation. Actually, I saw it before, and I'm waiting this moment to see it again, about how to make fertility results better by endo. Jamal, are you happy?
I am very happy to meet all of you and grateful to the invitation. But I'm also happy to meet virtually some colleagues for whom I have great respect, Hassan Salam, Professor Abulghar, the legendary one, and many others, but also very challenged to talk immediately after Professor Yaqub Khalaf, a person for whom I have a great respect. And
I hope he's left, but because if he's here, you are walking on a minefield. Something will explode.
Yes, I know it. I know it. And okay. As conscious and competent, now I know I'm conscious and competent, I will try, from my point of view, to highlight some controversies in those topics, very controversial, with very low quality of evidence, sometimes no evidence, but some evidence seems to me at least debatable, and I would like to know the expert opinion here about those debates.
Thank you, Jamal. As you said, that this forum is connecting people like Nokia, okay? Connecting people, friendship, happiness, and a nice atmosphere. So the screen is yours and everybody is looking forward.
So I first would like to apologize for my poor English. So be patient with me and try to understand what I want to say. So, do you see my screen?
Yes, loud and clear. Go ahead.
Okay. So
the number of audience is still very high. So enjoy and take your time.
Thank you. So I'm coming from Rabat, capital of Morocco, which is the cultural and also politic capital of Morocco, modern and also old city. And I will talk about hysteroscopy for enhancing fertility outcomes. And we know all that when we talk about hysteroscopy, we are going to talk about uterine factors and their impact on reproduction. 3% of fertile women have a problem with their uterus, fibroids, malformation, and any other pathology. And when it comes to ERT results, in the very optimistic scenario, the implantation rate is less than 50%, and the live birth rate range from 20 to 30%, though. So the failures are more than the success. And in this unsuccessful ERT, uterine factors are the cause in roughly 10 to 15%. And in case of repeated implantation failure, uterine pathologies are present in up to 50% according to the literature. And those uterine factors range from 2% in certain study to 60% in others, so wide range. And according to the American Fertility Society, hysterosalpingography is a part of initial workup of infertility, And we all know that it is a low sensitivity tool and low predictive positive value tool. So we can improve our assessments, particularly by using transvaginal ultrasound, which is systematic and can improve the results by saline infusion sonography, but according to ASRM, hysteroscopy is the gold standard, but considered as costly and invasive. Cost effectiveness and tolerance of hysteroscopy. Take the example for a patient consulting for male infertility factor. Why doing hysterosalpingography? Hysterosalpingography is very painful, and most of our male patients are feared about this exam, and many of them don't want to do it. And if I do in my own setting hysterosalpingography and transvaginal ultrasound, the cost is $140. If I perform in one setting successively transvaginal ultrasound, hysteroscopy, and immediately after, during the same consultation, I can accurately assess the uterine cavity, any defects or uterine pathology, hidden hydrosalpinx because I use saline, and that's only for the cost of $100. So it is less costly than a previous exam. And by using the very small hysteroscope, 2.9 millimeter, this procedure is not so painful if used at the appropriate moment with the appropriate expertise. That's what we can do in the one-stop clinic, 3D ultrasound. Immediately after a bubble test, you can assess the patency of the proximal tubes. And immediately after, you do hysterosalpingography, and you can see here that the fluid passed into the cavity and the tube is floating, and you can see the fibria. You can say here that with some quality that the tubes are patent, no hydrosalpinx, and no need to perform costly and painful hysterosalpingography in one-stop clinic. And for the case of we don't see anything, unexplained infertility, the ESHRE recommend strongly to not do anything other, particularly hysteroscopy. It is a strong evidence. And also, let me highlight something, we will discuss it later, that for treatment of uterine fibroid in women, when otherwise unexplained infertility, there is no evidence to make any recommendation against or pro myomectomy. And how can we increase our findings by doing hysteroscopy? There is some factors that influence the findings. In this series of more than 1,700 cases, we can have, if no symptoms, only 9% of pathology found at hysteroscopy. But if we have any other symptoms like abnormal atrial bleeding, hypomenorrhea, or B and C in the past, we can increase the rate of findings. And in this Cochrane library, very recent, 19, they have demonstrated that in case of systematic use of hysteroscopy in subfertile women, the ongoing pregnancy rate is higher than not doing hysteroscopy if any pathology is seen and treated with low quality evidence. And I would like to go to only two topics because the topic is very, very large, only fibroids and septate, and conclude with ART. All of us know about the PRITS systematic review and meta-analysis, and we know all the negative impacts or intramural and submucous fibroid on fertility outcomes. It was demonstrated, and removal of submucous fibroid seems to confer benefits, There is no clear evidence, no strong evidence that removing submucous fibroid, but everybody agree, all recommendation agree to remove them, even asymptomatic. So let's go to what happens after that. What happens is in 2018, the FIGO updated his classification of fibroid, and type 3 fibroid became not intramural, not submucous. Some can consider it as submucous, but is in gray zone. And it is a new challenge for a researcher to find solution for this problematic, because it is demonstrated clearly, young study and this very recent systematic review, that type 3 fibroid impact negatively fertility outcomes for spontaneous pregnancy and also for patients undergoing ART. And this negative impact should be addressed. We know all how fibroids impact the fertility outcome. I will focus only on 2 points because we are talking here about fibroid G3, increasing uterine contractility and endometrial receptivity. This is the basic science on how these two problematics impact fertility outcome. In this very beautiful prospective study done by Yoshino in Japan, using dynamic MRI, he demonstrated when there is a high frequency peristaltis, more than 2 contractions each 3 minutes, the pregnancy rate is 0% compared with low contractility. And we all know that, and after the surgery, he demonstrated prospectively that patients who have a low frequency of contraction, uterine contraction, experienced 40% live birth rate like any other intramural myomectomy, and majority of them were spontaneous pregnancy. Interesting study about contractility. We all know that fibroid G3 are in close contact of the junctional zone and the endometrium. And it is a very important point because it is the point in which uterine contractility is triggered. So we can understand that fibroid impact the uterine contractility and also endometrial receptivity, and all we know, all that publication about markers of endometrial receptivity disturbed by fibroids in the endometrium overlying the fibroid and also in other parts of the uterine cavity. In this very recent meta-analysis, it was highlighted that we have no clear evidence that treating intramural and also submucous, we have an important impact on reproductive outcome. However, all the societies, all the guidelines are in support to do a hysteroscopic myomectomy in case of submucous fibroid and also for large intramural ones. FIGO type 3 fibroid are feasible with no complication reported in this systematic review, with a live birth rate of roughly 40% like any other kinds of myomectomy, and it could be done under hysteroscopy, which is the less aggressive for the uterus. And in this case, the pseudocapsule is the point, and some leading experts advise or support to do this surgery in the settings of clinical research, in case of unexplained infertility, patient seeking ART, or in case of repeated implantation failure, only in very skilled hands and in context of research. And we can do it like this. I will demonstrate how we can approach it by hysteroscopy. This is a G3 fibroid located at the fundus. Good mapping with 3D ultrasound was done before. Here we have access to the fibroid. And the key point, as I say, to do a safe and effective surgery with no complication is the pseudocapsule. And this is the demonstration how we can enter this pseudocapsule. We can disconnect the inner pseudocapsule to the outer one by destruction of this loose connective tissue. If you encounter any vessel feeding the fibroid, you can do preventive cautery at this moment. And you can continue safely to detach the fibroid from its attachment. And when you do so, it is really low risk of having uterine perforation, experiencing hemorrhage during the surgery, or making the uterine wall less strong. After detachment, you can start safely the procedure. The second topic, very debated, are symptoms. And I heard what you said before, you and Professor Yaqub Khalaf. Diagnostic modalities of the symptom is now clear. 3D ultrasound is the first and the most accurate tool to diagnose it with a very high specificity, sensitivity, predictive positive value, and negative predictive value. The impact of those symptoms is well known, particularly when you talk about malpresentation, very high, intrauterine growth restriction, and perinatal mortality was clearly demonstrated, and also high rates of miscarriage. This beautiful study, it is an observational study, symptoms discovered during pregnancy at the first trimester of pregnancy. And this group of patients have only 33% of live birth rate and experience cesarean section in 75% of the cases. Very high rates of cesarean section. Raphael Valle and Geraldine Ekpo reported that about 1/3 of the presentation will be breast presentation, and we don't know how many hip dislocation and their costs for this population. 5% transversal and 20% threat of premature labor with hospital stay and cost. And also, some study reported greater risk of ectopic pregnancy. And when we look at the one of the main problem in my is the cesarean delivery rate, 70% abnormal presentation, 1/3 of the patient. Also, studies about uterine artery Doppler show that before and after metroplasty, there is an improvement of vascular resistance and with the normal delivery outcomes. It was clearly reported in this very recent meta-analysis also that the problematic of malpresentation and miscarriage is lowered by the septoplasty, miscarriage, and also malpresentation is significantly lowered by this technique of septoplasty. And about the risk of perforation, it is the most important risk reported to say that we can be against septoplasty. Here we can clearly see that the number of C-section decreased from 80% to 90% in the reported group. The breech presentation decreased to 3%, and there was no uterine rupture in this series, knowing that 80% of them delivered vaginally. And the risk of perforation is demonstrated to be very low, 1% during the procedure. And to avoid that, we have to keep in mind that the assessment for the patient before surgery should be very, very accurate, and particularly by studying the fundal contour of the uterus. If there is any cleft, the septoplasty should be done very carefully and to maintain at least 10 millimeters at the fundus, so don't be complete in your septoplasty if you encounter this condition. Regarding fertility, there is no clear evidence that there is any impact or improvement, but some study report, this is one perspective, or you didn't know the study of Molo, that there is an improvement in live birth rate in the operated group compared with an operated group with otherwise unexplained infertility. The SWOT analysis also report that there is some strong points to make this surgery more frequently adopted. And we can do it very safely by using cold scissors. With cold scissors, the risk of perforation is very low. And also, if there is a perforation, the impact on the uterus strongness and the risk of having a bowel injury is very, very low. And you can have good results without harming the endometrial healing after the surgery. But this wonderful study came in 2021 and said that septoplasty is dead because there is no benefit to doing it. And also there is a risky procedure. And I have demonstrated that the risks are very low. And when good surgery is done by experts with good assessment, there is quasi no risk. Here, the sample size is questionable because all of us know how trust became this study with changing of the inclusion criteria. And in this study, they expected, compared to the 35 expected live births, to 70% expected in the surgery group, while everybody knows that in the very serious study, we can reach roughly 50 to 60% as a first live birth, and in infertile patients, only 35 to 40%. Though, so something is questionable, at least for and competent. So diagnostic modality in this study are also questionable. You see here that more than 50% of the patients are diagnosed by using hysterosalpingography alone or hysteroscopy plus laparoscopy. Let me show you that. Dutch group published in 2013 that the agreement among international experts on the hysteroscopic diagnosis of septate uterus is poor. And when we use 3D ultrasound, the agreement is very good when using ASRM-QM criteria. And in the study previously mentioned, a recent study, hysteroscopy with laparoscopy is the modality of diagnosis. Also, the post-operative septoplasty result assessment was not enough because they didn't do any hysteroscopic control, knowing that there could be a synechiae or residual septum. Delivery modality are also something debatable. Why in the operated group, roughly 70% of C-section, while in the expectant group, in which we can expect, as reported in the literature, more C-section, I don't understand why. This very recent systematic review reported that the pregnancy loss is significantly reduced after septoplasty. And we can also highlight some possible adverse outcome, because I mentioned before that roughly two-thirds of patients with septum left in place would experience cesarean section, and we know now the impact of isthmus cells, of possible adhesion before cesarean section, complications of cesarean section like hemorrhage and fever, and the repeated C-section, which is costly, and synechiae related to difficult DNC in case of septum left in place, possible tubal damage, and also the psychological burden and low self-esteem for patients knowing that they have malformation causing their problematic with the reproduction. So we can conclude that with low quality septate uterus is the most common malformation with the worst impacts and reproductive outcomes, but fortunately we can correct it in a low-cost setting, in an ambulatory setting with quasi no complication. And even if there is no strong evidence from RCTs, still there is evidence from the huge number of the operated patient with good outcome and also with no negative impact. We have to say that. And the American Society guidelines, you all know that they accept the use of septoplasty after a good counseling of patient. Now, the final point is hysteroscopy and ART. The findings when we do hysteroscopy in patient undergoing ART, we can find many lesions, and in this study, 41% have abnormality detected in the cavity and treated, while in other study they report only 10%. Many studies comes before the very famous INSIGHT and TROPHY study and demonstrate that we need to treat, to do hysteroscopy in 10 patients or 11 patients to have one additional live birth. Other systematic review and meta-analysis by our colleague Attilio Di Spiezio Sardo found that there is an improvement in live birth rate, but with moderate quality evidence, and that further robust RCTs are needed. And here comes the TROPHY study addressing patients with at least 2 failed embryo transfer, and reported that there is no improvement to perform hysteroscopy for patients with normal transvaginal ultrasound findings. In this study, we can see that the findings are quite different in what we have in other studies reported in the literature. Very few pathology, very high rate of pathology. Also, we can see in this study that all patients are under 38 and 3 or 4 are under 35, and that 44% underwent previous hysteroscopy. Many pathology were not treated, and the impact of treated uterine pathology, 4%, is very minimal to make any result. The other study is the TROPHY first IVF cycle, very huge number of patients, randomized control trial, no impact on reproductive outcomes for patients with normal transvaginal ultrasound. And the Cochrane 2019 reported that for the first IVF, we can increase the clinical pregnancy rate, but not. And we can also increase in the 2 groups, first IVF or failed IVF, but the live birth rate will not increase in in the group with first IVF, but could increase in the patient with at least 2 failed IVF. The ISHRA 2022 guidelines advise to not do hysteroscopy at first line, but it could be considered in case of repeated implantation failure or also in case of chronic endometritis. Let's come back to the INSIGHT study to show something disturbing. As I mentioned before, all patients, or a majority of them, were young. This retrospective study, but including more than 10,000 patients, reported that effectively in young patients, no improvement, but in advanced maternal age, there is significant improvement. And all we know that advanced maternal age is likely to show many pathology, uterine pathology in this subgroup of patients. And also something different, there's 2 randomized control trial, the INSIGHT, and also this one by Al-Setouhi, published in 2015 before this one. And it was reported that in this second study that including patients of all age, not only young with good prognosis, there is 43% of patients showing uterine anomaly according probably to the age, and there is a significantly higher pregnancy rates in patients undergoing hysteroscopy and correction if any anomaly. The last meta-analysis, including 6 randomized trials and others, but if we focus on only randomized control trial, this study took clinical pregnancy rate as a primary outcome, and they found significant improvement in clinical pregnancy rate, but failed to find any difference in live birth rates. And we can see when we return to the other study that the weight of the study done by Smith is very important when mixed with the other study. And here we can also see the same thing. The Smith study has different outcomes from all the other studies. So it is something we have to pay attention to, and probably to investigate more this problematic of hysteroscopy and ART. So to conclude, hysteroscopy remained the gold standard for uterine cavity assessment. Chronic endometritis, adhesion, polyps, dysmorphic, and many other pathology could be found and treated in the same setting, particularly if you are have the skills to do it in outpatient and better in office. But we have to say that actually the certainties are much more less than the controversies. And I hope that I have highlighted some problematics in the point of view of conscious and competent. Thanks a lot.
Well. Jamal Fikri, thank you. You covered everything, Jamal, okay? I think that your topic was comprehensive and holistic view about the debate. And while I was listening to your lecture, I was thinking in the statement that Dr. Yaqub Khalaf told me, okay? Yaqub told me, Osama, you are one of a kind class endoscopic surgeon, but you understand nothing in infertility. So I wanted to answer back. It is vice versa, Yaqub, okay? You are a world class of infertility. I just sent him now a message with that WhatsApp. I thought, okay, you are a word. Why, as I said, this observation, why the infertility specialist is always pushing their nose in any endoscopic procedure. They are not happy about endometrioma. They are not happy about the polyp. They are not happy about the septum. They are not happy about the T-shape. For every procedure, they try to undermine it and prove it's of no value. Although they didn't give us the chance to prove it, okay, most of the studies done by IVF people in collaboration with some endoscopists, the TRUST study done by 18 or 21 doctor, and the chief investigator is a resident. Dr. Ricken is a very young lady resident, and she is the one. So how can you expect? I am not blaming them or underestimating them as a scientist, but I cannot accept that the conclusion that septum should not be treated, because when they treated, they found that the results is low, is even inferior than if you don't treat. And when we criticized the study, me and Carlo D'Anglais, we found that many of the cases on a second look, the septum was still there. It is from their own publication that the septum was still there. And many cases, they have perforation, blah, blah. So that explains why your results was low. And how can you ignore the huge literature about improvement of pregnancy after septum? So anyway, we will keep the discussion going on. So please, Jamal, would you unshare your screen, please, so I can go to the next topic. And as I said, please, you don't need coffee break. Okay, nobody. You are already on your coffee, and even some of the audience send me picture. For them, they are in the gym. One of my fellows, he's in the gym exercising and following the Congress. So we have still a lot of interesting topics, and I'm eagerly waiting for Tony from USA, the man who investigate. He is the crime scene investigator, okay? Crime scene investigator. He is still, I'm just motivating you to wait him, but now, before we come to the crime scene investigators who will, Sherlock Holmes, who find how the crime, how it happened, the accident. We will have now with Dr. Botros. Dr. Botros is an esteemed endoscopic surgeon in Al Corniche Hospital. Let me find his picture. And is he with us? Yes. Okay. Dr. George Botros is a consultant gynecologist and with a special interest in endometriosis. And I always say to my fellows that those endometriosis people are supposed to be the best laparoscopic surgeon, okay? Those who can play next to the ureter and the internal iliac, they have the courage to do that. So these are the most I trust them. So George Botros, Arnaud Vatier, Mario Malzoni, these are the world-class endoscopic surgeon. But today, he chose a very, very controversial issue. It's a new fashion. It's a trend. Even I don't know how to pronounce it. Niche. What is niche? You know, in our house, my mother used to have a niche where we put the plates and the forks and knife. Okay, so what's niche? Some people call it niche. Some people call it cesarean scar defect, cesarean scar diverticulum, ismucil. When you find too many names, you know that nobody knows about it anything. Okay, everybody wants to give a theory, and I'm sure that Dr. Botros would like to put solution through laparoscopy, and definitely. I am the Rottweiler for hysteroscopy. Understand this? The Rott. Okay. You cannot come. Yeah, I don't wanna to interrupt your lecture, but in my personal opinion, there is no treatment for niche. There is no treatment. Whatever you do, even you excise and reanastomose, you are making another scar in the same weak area. So I do believe, from my point of view, we just treat the symptoms of the niche. We don't want for collection of this viscid mucus, dirty blood in that pocket, okay? We treat the symptoms, but the niche will stay, okay? So, Dr. George, truly happy to see you. You look younger than the last year, so probably some antioxidants, okay? But you don't paint your hair. I paint my hair black, and you want it to be gray, okay?
I'll leave it.
Okay, so the screen is yours, and looking forward to know what about this niche.
Thank you very much, Professor. It's a great pleasure to be invited in this amazing forum. I have to be honest, to listen to all of the eminent speakers from the morning until now, it was quite a treat, really. I've been out with my wife, had lunch outside, still having my phone plugged to my ears, and I'm listening to all the lectures. I've enjoyed every single bit of the lectures from Dr. Abulghar, Dr. Salam, Professor Yaqub, yourself and your commentaries and your debates. Amazing day. Thank you very much for inviting me to be part of this forum. So as you could see from everybody seeing my screen. So as you could see, as you summarize my lecture in these two sentences that actually very interesting to reiterate what you said, but I will talk about it from a debate point of view. That's why I chose the title of my topic, Ismucil is a self-inflicted headache. Which means it's an introgenic thing, as all we know. We know that the ismucil is to do with the cesarean section. And very rarely we see something related to congenital anomaly of the cervical canal or the isthmus that has a niche or a ismucil. But that's one not talk about. We talk about the niche due to cesarean section. So this is Corniche Hospital, where I've been practicing for the last 5 years after coming back from UK Liverpool University Hospital, and hoping to move soon to the new state-of-the-art Corniche Hospital that's being built at the moment. So I have no conflict of interest to declare. So Cesarean section is always incriminated to a lot of problems since we started to do cesarean section. Of course, saves babies' lives because it's a must to be done for the right reasons. But we know that the rate of cesarean section has increased recently up to 30 to 40% in some parts of the world. So as you said, what is the niche? So some people call it niche, some people call it diverticulum, isthmusine, reservoir, cesarean scar defect. But the definition of the niche was defined by Gyne as more than 2 millimeter in the myometrium at the cesarean section, or 80% defect of the myometrium at the cesarean section scar. So why are we talking about it now? The first cesarean section was done in the 16th century. The niche was first described in 1995. Now, in the recent years, in the last 10 years, everybody talking about niche and linking it to infertility, linking it to menstrual disorders, and also linking it to complications in pregnancy. So we will talk about that because of the high number of cesarean sections. Probably in the last few years became quite obvious that the complications and the problems to do with post-cesarean section is noticed significantly. So has an impact on obstetrics, fertility, gynecology, and the emotional and psychological impact with all of the above. So the incidence is variable in the literature. So some quote incidence about 1%, 2%, but actually the reality is that the incidence is quite high, especially with high order cesarean sections, whether symptomatic or asymptomatic, because sometimes we do a scan, ultrasound scan for patients who, for other pathology and pelvis, ovarian cyst, or fibroid, and we find the niche, and it's completely asymptomatic. So we're talking about incidence of 1 in 3 to 1 in 4 patients would have the definition, which is more than 2 millimeter defect in the myometrium, or more than 80% of the myometrium deficient due to the cesarean section. So what is the impact on obstetrics? We all know about the life-threatening condition, which is a placenta previa, accreta, where the placenta gets implanted where the cesarean scar is, and it's quite a risk to life condition, and it's also, you might end up having a hysterectomy during the cesarean section because of the placenta previa accreta. Rupture, uterine rupture, and scar dehiscence. Somebody who had 3-4 cesarean sections. How many times when we do elective cesarean section for a lady who had previous 3 or 4 cesarean, and we hardly find any myometrium, and it's only peritoneum. You can see the baby's hair or head without even making any incision in the uterus. So transcar pregnancy, this part of the world, because we do quite a lot of cesarean sections, because patients like to have more children and family, and it's a population need to grow. So we see quite a lot of cesarean scar pregnancies. Definitely, I see quite a lot of cesarean scar pregnancies here in UAE, more than what I used to in the UK. Miscarriages related to the cesarean scar is quite common, and we see that due to the toxic environment that produced due to the secretions and the persistent old blood in the uterine cavity. So abnormal uterine bleeding as a gynecological condition, the more we do cesarean section, the more patients come in afterwards with symptoms of abnormal uterine bleeding. Sometimes they have, due to the adhesions from multiple cesarean section, they come with pelvic pain, they come with dyspareunia, and of course the secondary fertility. So why secondary fertility linked to the cesarean section scar or niche? It is because of the persistent blood and mucus, which is in the cavity, toxic environment for fetal implantation, inflammation at the site of the glands where the isthmus is present, impairing the sperm penetration and the implantation. Mechanical impairment of the embryo transfer catheter, as we all know that there's distortion at the side of the cesarean scar where the defect is, and also the contractility, which is quite proven now that it's very important for fertility and for embryos to implant in the uterus. How it happens? It's because of the cesarean section. So there's many theories. Nobody knows exactly what is the clear etiology. The commonest factor is devascularization at the site of the repair or inadequate repair, which using the repair of the cesarean section at the upper layer, where the serosa and upper half of the myometrium, leaving the decidua, and the lower half of the myometrium unrepaired is sometimes incriminated. Multiple cesarean sections is one of the reasons. One of the trials showed that actually, one of the papers showed that actually emergency cesarean section with a low incision in the cervical canal can be a risk factor for formation of cesarean scar. Using the locking of technique in closure of the cesarean section can devascularize the myometrium and reduce the blood supply to the area of the repair, and this is the risk of formation of the niche or the esmose. This is a paper, a meta-analysis, systematic review, was published comparing 2-layer closure versus 1-layer closures, and it showed that the evidence showed that the increased myometrium thickness if we do 2-layer closure and reduction of the dyspnea rate. How we diagnose esmose. The 85% of the diagnosis is simply by ultrasound with a 2D or 3D. Sometimes, due to the difficulty identifying all 3 dimensions of the scar defect, we tend to use MRI scan. So the measurements is usually the width of the defect, the depth of the defect, and the most importantly is the myometrium thickness if we are intending to repair that defect, because the modality and the route of the repair depends on that principal formation, which is the myometrium, and I'll talk about that later on. So surgical correction, hysteroscopic, vaginal, laparoscopic, or robotic assisted repair. Because I am talking here with an expert in hysteroscopic surgery listening to me, so I'm not talking about the hysteroscopic repair in my talk. I'll leave it to Professor Osama Shawki, but I will elaborate more on the laparoscopic technique and the way we repair it here at our hospital, and we will reflect some data. We'll talk about some of our data that we've been collecting since we started doing the procedure at the Niche Hospital. So the laparoscopic technique that we use, as you can see on the small clip up there, we tend to use hysteroscopic and laparoscopic technique to eliminate trans-elimination of the area of the scar to be able to excise it and repair it without any residual defect left behind. So that's called Renders-Voss technique. What about the outcomes? So some people say hysteroscopic better, laparoscopic better, or vaginal approach is better. So this is presented in the American Society of Reproductive Medicine recently, and they found that actually combined hysteroscopic and laparoscopic approach for abnormal uterine bleeding is proven to be better than hysteroscopic only or vaginal repair. But from fertility point of view, there is no evidence to suggest that either any of the techniques is better than the other because of the lack of standardization and intuition of the data. This is a schematic, just a pathway, usually whether we use the hysteroscope or the laparoscope, dependent on the myometrium thickness, as I mentioned earlier. And we use most of the papers use a cutoff of 3 millimeter. So if there is less than 3 millimeter, they tend to go for laparoscopic repair due to the risk of perforation, and also if patient wants to get pregnant and leaving a residual myometrium of less than 3 millimeter, there's risks during pregnancy. If woman does not desire pregnancy, we add always medical treatment, we add a Mirena coil or medical hormonal treatment, or we tend to go for laparoscopic hysterectomy, or we do hysteroscopic repair and put the coil at the end of the procedure. So what is the risk factors in reduction of the success rate? Of course, experience of the surgeon and the technique. There is no standardized technique in the literature. There's lots of data and papers published about how to do the repair hysteroscopically or laparoscopically. For example, hysteroscopic way is resection of the anterior or the lower edge. Some people say excision of the lower edge and the upper edge. Some people say 360 degree. You remove the upper lower edge and you go back on the posterior and remove the that area as well. So I'll leave that to Professor Shawqi to tell us more about this, his expert technique. But from other type of failures is the high number of cesarean section. If you do a repair for a patient who had a small defect, rather than doing a repair with a woman who had 4 or 5 cesarean sections and a big defect of about 3 centimeters. And it's, I will show you some of our data and our experience in, to do the high order cesarean section when we do laparoscopic repair. Adhesions and inflammation prior to repair. Women who had previous 4 or 5 cesarean section, uterus is plastered on the abdominal wall, and you have to dissect that uterus down to be able to mobilize the bladder and then do the repair. Is totally different where you have 1 or 2 cesarean section, you just mobilize the bladder and repair a small defect. Adenomyosis is considered and one of the independent risk factors. Actually, I'm looking in the literature and I found one of the Chinese paper who had large number of repairs, published about 331 cases done all vaginally, and they looked at the adenomyosis group where 50 patients treated vaginal repair versus non-adenomyotic group with 228 patients. And if we look at the data and the result, we find that actually there is statistic difference in the success of the repair with adenomyosis versus non-adenomyosis. So with the adenomyosis, the success rate is much lower and the optimal healing is much lower. See here from the data, overall, the success rate is 44% for non-adenomyotic, which is still less than 50% success, but here in the adenomyotic with only 30%. Going to our data, local data, we looked at 2 years of our practice, 2.5 years, so 2019, 2021, and some 3.5 with some of the 2022, and now we're building our data and we're trying to hopefully in the next few months publish our data. So we looked at 36 cases for symptomatic niche. Most of these patients were mainly for fertility reasons. They referred from IVF units before embryo transfer. They identified previous failure of IV implantation in 1 or 2 previous attempts, and they didn't identify any other reason for failure of implantation. They sent them to us to repair the defect. This is the only factor. Some women who had abnormal tram bleeding and desired fertility and wanted to repair. This is some of the other group that we treated. So in total, we had in total, we had 36 cases. If we look at the number of cesarean sections that we counted, then find that actually more than half of the patient had 3 or 4 cesarean sections, meeting some of that previous 7 cesarean sections. That's the highest number I did repair for, but actually more than half is more than 3 or 4 cesarean sections. 7 out of the 36 were suboptimal repair. We find with ultrasound scan, because we have a protocol in our unit that when we do the repair, we put them on contraception for 6 months, 3 months with no break, so they don't have period, and the second 3 months as a method of contraception cycle complete. Second approach, we tend to see them immediately 3 weeks after surgery, and then 3 months we do first ultrasound scan, and 6 months before they go and have their embryo transfers, we do another scan. So 7 had suboptimal repair with 2 and more than 2 millimeter defect. That many of them didn't stop them from growing and having the embryo transfer, and some of them had successful actually pregnancy, in spite of the fact that there was residual defect of more than 2 milliliter. One patient had repeat repair 9 months post initial procedure and got pregnant spontaneously in spite of failed one IVF after the second repair. 11 pregnancies in this small series we identified after the repair. So if we look at the right-hand corner, this is the total number. The gray corner is the 36 patients we treated. 32 had laparoscopic. We only did 3 because of the type of patients that come to us, where mainly the myometrium thickness is 3 millimeter or less, and we confirmed that ultrasound. If it is not clear on ultrasound, we did the MRI. One had open surgery because she had an open myomectomy. It's a large fibroid, and during that time, we did the repair of the niche. 17, we did a technique of end-to-end, and 18, we did an overlap technique, and I'll show you the images of the 2 techniques. 15, we had to do antiversion because of retroverted uterus, and when we do the antiversion of the uterus, that would help to reduce the risk of reformation or persistence of the niche or reservoir after repair. 7 had, as I said, residual defect more than 2 and 11 pregnancies. So here, this is our surgical technique. If you see the hysteroscopy, you see the upper end of the niche or the reservoir and the lower end. And you can see here in this image, you see the defect between the 2 edges. Laparoscopically, we mobilize the bladder. We have to do extensive mobilization. Imagine how difficult it can be when you have 4 or 5 cesarean sections and the bladder is completely adherent to the anterior wall of the uterus. And then we do the trans-illumination technique. We excise the niche and then we repair it again with the interrupted sutures. These are the images of the cases some of the cases we treated, and you could see before and after. So the left-hand corner is before and the right-hand corner is after. And you can see that here from the third picture on this side, there's hardly any defect. And here you could see here that is due to the antiversion. This is not the defect. This is but it's the canal here, and this is just a gland. I could see here as well, there is approximation, but there's a slight effect there. So there is a variability of the repair success. And here, if you see, this is the technique of overlap. If you could see here that it's like a key and a lock. You see, this is the upper part of the myometrium. This is the lower part of the myometrium, and you could see that its approximation is very tight, and there's no distortion of the cervical or the endometrial canal. Here, this is one of the failed cases that I mentioned, that with adenomyosis, this lady who had 5 cesarean section, uterus completely plastered on the abdominal wall. And we mobilized the uterus first. It was very friable myometrium. It's very difficult, difficult surgery. And when we mobilized the bladder, we identified a large defect with transillumination. Obviously, almost there was hardly any myometrium or at the cesarean scar. We excised it and we repaired it. And then this is the MRI before the surgery, and you can see the defect here high up in the uterus. And then this is the repair, and you can see the suture line. That's a few weeks after. And then 6 months after, you can see that actually the healing was suboptimal. This is the video of the clips that have been presenting earlier throughout the presentation. Thank you very much.
Hi again, Dr. George. You hear me?
Yes, I hear.
Good. I think that you chose a topic of interest of many people, okay? We have to agree that cesarean section became an epidemic, and there is a little joke in my country that the commonest indication of cesarean section is being pregnant.
Yeah.
Okay. And some figures say it's up to 90%. If the patient is not coming fully dilated in labor, the cesarean section is the choice. But still, there will be no clue why it happens. Some people say because of the technique of closure, suture material. But what I would love to invite the audience to check on YouTube, the collection of my videos, just type Osama Shawki and niche. I show you quite well from inside that 99% of cesarean scar niche or scar, it is in the cervix. It's not in the uterus. It is lined by cervical epithelium, which means the incision is very low and the internal os is higher. Why this is happening now? Probably the explanation I have in my mind, because most of the cesarean sections nowadays are elective. So the lower segment is not fully stretched. So when we teach the residents, dissect the bladder, go down, eventually it becomes at the edge of the cervix. When after healing and involution of the uterus, it's at the edge of the, and my proof is visual. I didn't publish any articles. Observation is visual. All the videos on YouTube, you will see that the defect in the cervical epithelium lined by endocervix and secreting this thick viscid mucus. So the collection of the mucus of the blood is the cause of all the symptoms, like continuous bleeding, pain, and also infertility. But by the way, I have seen some approach laparoscopically, which actually looks logic. I was operating in Uzbekistan a couple of months ago, and in the next room, there was a Russian surgeon, but I don't remember his name. And the Russian surgeon was doing the same technique like you do, okay? Excision and end-to-end anastomosis, but also he adds a cerclage using a Mercelin tape. So that sounds logic, that he enhance and enforce this weak area by like a graft of this cerclage. But up till now, there will be no uniform agreement about what is the best technique for cesarean scar niche. And I think that the technique of Gyne is the most used nowadays. And Gyne, he excised the upper edge and the lower edge of the defect. So that what makes like the pouch become flat. So in short, we convert the deep soup plate to be flat saucer, okay? So that will prevent the stagnation of blood. So once again, thank you very much, Dr. George, and looking forward to, by the way, when you showed the picture of the corniche, you brought a lot, very lovely memories. You know that I visited this hospital with Dr. Jacques Amo, Ray Gary, and Jim Daniel. I think nobody knows these names now, okay? I was little kid, and Ray Gary and Amo was very senior. So I was very happy that I'm a little child watching Tom and Jerry, and they invited me to do hysteroscopy at that time. And it was very primitive hysteroscopy. And I can say that all my cases was very lousy. I don't know why they were impressed, but it was terrible at that time. Anyway,
amazing.
Thank you.
Can I ask a question before? Can I ask you a question before we move on?
Sure.
From your expertise about hysteroscopic as a hysteroscopic surgeon, do you consider the myometrium thickness for women desire pregnancy as a deciding factor, whether you do hysteroscopy or a laparoscopy? The way I presented it, 3 millimeters. What's your cutoff point?
Well, okay, George, let me confirm a fact that might not be pleasant to everybody. I am a very Descartesian man. You know Descartes? René Descartes, okay?
Yeah.
I don't believe unless what I see. So there are many publications claiming that there should be minimal residual thickness. But personally, I have never seen any case of ruptured uterus after correction. Maybe it will happen later, but up till now, I do only excision of the lower edge. You know, the niche has upper cleft, lower cleft. I excise the lower part together with some of the endocervix. So there is no secretion of mucus now. And I've never seen a case of ruptured uterus after that. But logic, I just want to ask those people who put a minimal thickness of few millimeters, did they have a record of incidence of ruptured uterus? They are the one to answer that, but I've never seen that. Okay, so thank you. Thank you for staying with us. And now time to, can you unshare your screen, please, George? Hello? George?
Yeah, I'm still sharing.
Unshare your screen.
Okay.
And I
I'll leave
wonder
and
if,
I'll come back. Yeah.
yes, our next upcoming star is here or not. Yes, I see his face.
I'm here, Osama. I cannot leave you alone. I cannot leave you alone. Even if I am on the boat into the sea, it's strange that I have connection, and so I cannot lose the occasion to be with you today.
You are deliberately teasing me, and you are deliberately wants to make me angry and envious of you. I know your character, okay? So I would say that Scandal, he is in his boat now with a lovely blonde with a bikini and giving it, okay, God bless you.
But I'm wearing the shirt, you see, in order to be better. So
there is no bikini.
But however, I sent my pre-recorded lectures because I wasn't sure that the connection was fine. I hope you can enjoy the lecture, and then I'm available for question at the end. Thank you, Osama.
Thank you for staying with us. Enjoy your time, and the screen is yours, Attilio.
Dear ladies and gentlemen, once more, good afternoon to everyone. And thanks again, Osama, and even to you, Keith, that you are the honorary president of this 15th Gyne Forum in Dubai, for inviting me to have this presentation. I thank once more Osama for the very challenging title of this presentation, GPS to Master Hysteroscopy. So what is a GPS? A GPS is a global positioning system. So it is a satellite system that provides useful information for an accurate navigation. If we translate this concept in hysteroscopy, we can say that navigating the world of hysteroscopy and learning to master this wonderful technique requires a lot of skills that you need to acquire throughout your career. And we will analyze the main aspect of all the skills that are needed in order to master hysteroscopy. First of all, knowledge. And knowledge at the beginning is just theoretical knowledge. And I would say that the prerequisite for doing a good hysteroscopy, but a good surgery, is that you have a good theoretical knowledge. This is the reason why I try to contribute for the new generation, producing a book in 2014, then revised in 2021. This is a book that is distributed for free by car stores, and I think that it can be a good instrument, like many others available in international literature, for studying hysteroscopy. So first you need to study, and then and you can see that even in the GCIA program, the theoretical knowledge is the first mandatory pillar of the scheme of the GCIA program. Then, after the theoretical knowledge, it is important that you acquire your ability. But to be more specific, it's important that you acquire your psychomotor skills, like hand-eye coordination, the ability to hold the camera with one hand, with the other hand you have to hold the grasping or the scissor. So all the psychomotor skills needs to be acquired in a dry lab. So first you acquire this psychomotor skill, and then you can move in your clinical real practice on patients. And you see that the GCIA program, that this program that the European Society has developed in order to standardize the training of people in gynecological endoscopy, has met different pillars. The first we have seen before is the theoretical knowledge, so the e-learning. Then you have the second pillars, that is to acquire and train your psychomotor skills. And as I said before, these psychomotor skills needs to be acquired in a dry lab. Then you have to do your advanced training, and advanced training means to do training in vivo. I have arranged in the last 15, 18 years of my careers many training in vivo, and mostly when you have the patient awake that can judge what you are doing to her, it's very, very challenging. The training in vivo has two phases. The first one is the observational phase, when the junior or the not expert, however, is going to observe the senior doing the procedures. And then most difficult is the last phase of your training, is the preceptorship phase, when the not expert is doing hysteroscopy and the expert is going to supervise and help the doctor. And of course, this training in vivo is much, much more difficult when the patient is awake. So the training in outpatient hysteroscopy, I can say that is more difficult than the training with patients sleeping in the operating room, so the inpatient training. Then, of course, you need to learn throughout your careers, and to learn what? First, which are the different instruments that are available in the market in order to perform a safe and effective hysteroscopy. It's important that you understand how important has been the miniaturization of the optic, and consequently even of the total size of the hysteroscope throughout the years. And smaller is the hysteroscope, easier is the entrance in the uterine cavity, and so more possibility to perform even operative procedures. Then learning means that you have to know even the evolution of technology. For example, here I represent in these slides the evolution of the bipolar generator throughout the years in the world of hysteroscopy, and even the advancement and the evolution of the electronical irrigation and suction device in order to provide a constant and uniform pressure inside the uterine cavity. Of course, you have to be aware also of the new instrumentation that are available in the portfolio of hysteroscopy. And I just want to emphasize that two of the most important, according to my opinion, innovation that we had in the field of hysteroscopy are the advent of tissue removal device and the advent of the mini resectoscope. The mini resectoscope, because has brought the same surgical maneuvers that you do in inpatient setting with your standard size resectoscope in outpatient setting. And so more and more procedures that before the advent of the mini resectoscope had to be moved in the inpatient setting under general anesthesia now can be performed in outpatient setting. At the same level, the tissue removal device has make quicker so some procedures, and has tremendously increased the feasibility of outpatient operative hysteroscopy, because mostly when you deal with retained product of conception, polyps, or thickened endometrium using the tissue removal device without the need to go in and out from the uterine cavity, you can speed up your process. Learning means that you have also to know the rules when you perform hysteroscopy. For example, in vaginoscopy, the 6-12 o'clock rules is mandatory to perform a good vaginoscopic hysteroscopy with the 4-oblique view scope. It's important that you know the pressure inside the uterine cavity. It's important that you know that you should have the lowest as possible pressure inside uterine cavity, however lower than the pressure present within the tubes, in order to avoid the spillage of liquid through the tubes, and so the occurrence of a vasovagal reaction. And what is important is that you have to know how to deal with small diameter hysteroscope. And what is important is that you have to know how to use oval profile hysteroscope, mostly when you face with stenosis of the internal uterine ostium, and it's important that you know how to rotate the scope in order to align the main axis of your scope with the main axis of the internal uterine ostium, in order to make easier the entrance in the uterine cavity. And with the novel profile scope, it's much easier. If you have a round scope, of course, if you want to pass through a novel profile internal uterine ostium, is more challenging. You stretch the fibers and you cause pain to your patient. Of course, it's important that after you acquired your theoretical knowledge, you acquired your psychomotor skill, it's important that step by step you acquire your surgical competencies. And you see that the third pillar of the GESIA program is to acquire surgical competencies. And surgical competencies can be acquired when you do hysteroscopy on patients. And so in your career, starting from easy procedures and moving towards more complicated procedures, you acquire step by step your surgical competencies. And you have to understand that everyone at the beginning was a beginner, and then step by step you acquire one of the main objectives that we have in our clinical activity, so surgical experience. So you have to understand, mostly when you perform hysteroscopy in the outpatient setting, this is the scheme of treatment indication developed by Stefano Betocchi in 2002. And at that time, in the first year, when I tried to do hysteroscopy in outpatient setting, I was a beginner, and so I did only biopsy treatment of a small addition, small polyp, medium polyp. Then when you become intermediate, so I mean, in my career, I started to do some small septa or bigger polyp in outpatient setting. And only when I became a little bit more expert, I started to treat in outpatient setting even small myoma, type 0, type 1, so with prevalent intracavitary development. And you know that the advent of bipolar electrosurgery has allowed to perform in my activity most of the operative procedures in outpatient setting. So you know that one of the first techniques that you need to know how to be performed is the endometrial biopsy. This is one of the reasons why many doctors still rely their clinical activities on DNC and other blind technique of biopsy, because they do not know the key points, the real steps to perform a proper target type biopsy in order to have an adequate specimen for a proper histological diagnosis. And you have also to understand that when the endometrium is atrophic, the biopsy is completely different. So don't use the grasping crocodile forceps, because you are going to ruin, to destroy the grasping forceps, but you need scissors, or you need to use a bipolar electrodes in order to perform a proper biopsy on atrophic endometrium. And even, for example, for other common endometrial pathology, keep in mind that endometrial polypectomy represent, even in an expert center, as my center is now, nearly 50–60% of the overall operative procedures that you are going to perform in outpatient setting. And first, you perform small polypectomy, which means polyps smaller than internal uterine ostium. Then you are going to perform polypectomy of polyps that are a little bit bigger. And when the polyp is bigger than 0.5 centimeter, but however smaller than the internal uterine ostium, you can straight away cut the pedicle and remove the polyp in one block. But when the polyp is bigger than internal uterine ostium, you have to slice the polyp in several pieces. Otherwise, it would be impossible and painful for the patient, the removal of the different fragment of the polyp. And acquiring experience also means that you have to understand that mostly when you do hysteroscopy in outpatient setting, it's not a matter of the size of the lesion, but it's a matter of time. And even the best patient, the most compliant patient, when the procedures last more than 15-20 minutes, starts to get anxious, to get painful, so to complain about the procedure. So if you have a pathology, if you have the proper instrumentation and proper experience, and you think when you see the pathology that you are able to remove in less than 15-20 minutes in outpatient setting, go ahead. Otherwise, it's not a blame that you schedule this patient for inpatient setting. And then last but not least, I think that in the growth of each of ourselves, so it's important that at the end of our surgical learning curve, we come out of our comfort zone, and we step by step do even more challenging and difficult procedures. But before coming out of our comfort zone, we need to acquire all the main skills that I have shown you before, and only when you do that, you will be able to be a master in hysteroscopy. And a small secret that I want to give you is that you have to understand how to reduce the rate of failed outpatient hysteroscopy. And failed hysteroscopy in outpatient setting are mainly related to pain and severe cervical stenosis. And most of the time, severe cervical stenosis cause pain because we don't deal with this cervical stenosis in the proper way. So what is important is that you have to understand that there are many different techniques to overpass cervical stenosis. We have seen, for example, the use of oval profile hysteroscope, how to rotate the scope, always maintaining in the perfect position your camera, and so you don't have to twist the camera, but only the optic in order to align the main axis of the scope with main axis of the internal uterine ostium. In some situation, this is not enough, so you need to use your grasping forceps in order to enlarge the external or the internal uterine ostium. In some situation, even the grasping forceps are not enough, and so you can use, for example, scissors in order to cut the fibrotic tissue which makes very tight the external or internal uterine ostium. So don't use the grasping like I'm doing in this case, because you are going only to destroy your grasping forceps when you are not able to open the jaws of the grasping forceps inside the stenotic internal uterine or external uterine ostium. Please use the scissors to cut the fibrotic tissue, or if you have a very tiny external uterine ostium, you can use your bipolar electrodes in order to perform a star incision at 3 o'clock, 9 o'clock, 6 o'clock, and 12 o'clock in order to enlarge the external uterine ostium, as in this case, and let the hysteroscope to get easily through this stenosis. So I want to thank for the opportunity of this talk, and once more I want to emphasize that in order to become a master of hysteroscopy, you need to acquire many different skills. Don't run, but it's important that you understand that to be a master of hysteroscopy means that you have to acquire step by step many different skills. And this morning in my previous talk, you have seen that it's also important that you activate all your 5 senses every time you are going to perform an hysteroscopy. Thanks, Osama. Thanks, Keith. Thanks all of you for your attention. And I hope to be connected later for some questions.
Well, I tell you, as usual, you are different in your presentation. You touch the areas that nobody else touch, okay? The GPS is a new concept, but let me add something about the difference between laparoscopy and hysteroscopy. Because if you ask 10 persons, they will say that hysteroscopy is easier, all right? In hysteroscopy, you work in a very small restricted cavity with very difficult expansion and distension with only one instrument. You don't have a retractor, you don't have an assistant. So I don't agree upon those who say you do 10 cases and then you can do it. No. And I find the best description about how to be good hysteroscopist is to borrow the statement of Winston Churchill about success. He said, success is going from failure to failure without losing enthusiasm. And that's hysteroscopy, right? I'm sure you know what I mean. How many times we failed even to enter the cavity, In laparoscopy, you don't have this problem. In laparoscopy, it's a trocar and chuck, you're inside. In laparoscopy, when you enter and you look, you know this is your home. You know that this thing in the middle is uterus and over it, so your identification is easy. So the entry itself is very challenging and you have to expect a lot of failure. But thanks to your GPS, I find it very good roadmap for the beginners. But one question I want to ask you, you know that we agree in everything except one thing, which is the office, okay? You know that. Well, I find, is it easy to do training for beginners in the office while the patient awake and the patient listen and know that there is a beginner new is exercising? I find it extremely impossible that she will tolerate that. So how you solve this problem?
Okay, Osama, I agree 100% with you. And I also agree that to develop the office approach, what is important, even the country where you work, because there are differences among ladies throughout the world. And what is important is that, of course, the doctor is going to deal with awake patients has to know perfectly how to move with the hysteroscope, all the rules that we have to follow. And of course, the training at the beginning, everyone does when the patient is sleeping. So that's why when we do, for example, resectoscopy in our operating room, first, before doing resectoscopy, before dilate the cervix, all the young doctors do vaginoscopy with their diagnostic scope. So it means that they learn the technique first when the patient is sleeping. Then, of course, when they feel confident in the entrance of the uterus, then they can do the training even in outpatient setting and they can deal with awake patients. Of course, always supervised. Believe me, it's very challenging. So, and recently we did training with many doctors that have already been trained very well by you, some common friends from Ukraine, and we did 60 procedures outpatient. So, and there were these doctors coming from another country, speaking another language, that they do hysteroscopy. So I think it's important, the motivation of the patients. So when they sign the consent form, my assistant perfectly explains what is going on. So they do not have to be scared of the pain, of the discomfort that they feel, because if they are scared of pain, as soon as they start to feel pain, of course, they think that something is going wrong.
Yeah. So should I understand?
And so, I mean,
which is better, to start for the beginner the training while patient is sleeping, so if he has a shaking hand or something like this, and when he acquire the preliminary skill, then he can jump to the and also to choose multiparous cervix. I know not multiparous, not
Yeah, but I mean, I think this is the learning curve of everyone. Of course, people think that outpatient hysteroscopy it's easier, but it's not easier when you deal with an awake patient.
Thank you. This is what I wanted to hear from you. And then you look very nice without shaving your beard. This is the George Clooney style, okay? George Clooney style. So whomever with you in the boat, enjoy it.
I cannot turn the screen, so okay.
I know. And enjoy the Barolo bottle.
Yeah, when you want to come to Italy, you know that I always say that if there is an Italian more Italian than me, is Osama Shasky. So
I tell you, last question before you leave. If any, we have now more than 160 audience now. If they choose to visit the south of Italy, please choose one of the following: Sorrento, Amalfi, Napoli, Capri. What you suggest for the audience? This is more important than
we are lucky because they are 1 hour, one each apart.
Okay.
So if you come to Naples, 1 hour with the boat, you go to Capri. 1 hour with the car, you go to Sorrento.
Really?
And from Sorrento to Amalfi, it's half an hour. Because now there will be some meetings in Rome, Naples, Amalfi. So please come, Osama. You are invited as well. And mostly in spring, summertime, my area, I think, is one of the best in Italy, to be honest.
So you understand from him that it is very connected by boat. So there is no big hustle. You can see many beautiful places moving by the boat. Good. Okay. Thank you. Thank you very much. Enjoy your time. All right.
Thank you, Osama. Thank you.
Okay. Bye-bye. Bye-bye. Ciao. Ciao. And now, ladies and gentlemen, as I promised you, the crime scene investigator or air crash analysis. Okay, you know these programs where they bring the disaster, air disasters, okay?
Yes.
Well, I listen, my friends, a complication during laparoscopy is not as scary like in hysteroscopy. You know why? Because in laparoscopy, the big view cavity and you can see well, you have an assistant to save you. You have 2, 3, 4 instruments to catch the bleeder or to suture whatever cut, okay? And you have a senior standing with you. But in hysteroscopy, you're alone. There is no other, you cannot call, say, okay, Tony, come and help me. Once you did that disaster, you cannot correct it. And another thing that about fluid overload in particular, I warn everybody that when it happens suddenly. There is no gradual deterioration. Like during laparoscopy, if you have bleeding, the patient blah, 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 and you can have time to save. But fluid overload, you forget the time and you're working, everybody is happy, and suddenly the anesthetist is screaming, pulse, low pulse rate, all pulses. So this is really scary. So I'm very glad that we have today one of the, I will not say expert in complication, okay? This is not a good praise. Okay, but he's the only one among all my colleagues who is so keen to know and collect every complication from the world. I borrowed from him many videos, by the way. He go and hunt from this country, from that country, and apparently people trust him to give them their scandals, okay? So, Tony, we are glad to have you tonight. You're looking, by the way, very charming tonight. I don't know, you did some Botox in your face or something like this. So the screen is yours, and everybody is eager for the thrilling complications.
Thank you so much, Osama. Let me share my screen. You all see my screen? Yes, right? Okay,
yes,
very good.
Loud and clear.
Very good. First of all, thank you so much for inviting me. I'm not as lucky as Attilio Di Spiezzo presenting from a boat and eating pizza. I'm here in my room, and all I have is a cheeseburger from McDonald's here in Miami. So, again, thank you so much, Osama. And I want to take this opportunity to thank you personally here in public for the Hysteropedia work that you're doing. I share, you have Hysteropedia 1, 2, you're soon going to have Hysteropedia 3. I'm going to tell you, I share it with my residents. All my residents are members of Hysteropedia, and not only that, I go in the morning to work, and they're commenting of the cases that happened last night on Hysteropedia, and we keep going talking about the cases. So thank you so much for really doing such a great job with that, and a great educational job. So we're going to talk today about hysterectomy complication inside the uterus, right? And as I say, I want to clarify it. I'm not an expert in complication. Just because I shared a couple of complications with Osama, he thinks now I'm the expert. I just collect them. So first of all, this is what we're here for, right? First, do not harm. And there is one good thing about hysteroscopy as opposed to laparoscopy. At some point, you can always stop and come back later. So when in doubt, when you don't recognize the landmarks where the tip of your hysteroscope is, please stop. That is the way you will decrease the chances of creating further damage. Because at the end of the day, what we want to avoid is this, right? We went in for a diagnostic hysteroscopy, we end up having to do a laparoscopy, we have all our distension media inside the patient, we have to put ports, and that's not what we went for, right? But things happen, right? Complications happen, and there is this group from Italy who published an old lady that went for a hysteroscopy for a polypectomy, and she had a complication. They did not diagnose the complication. Patient came back a couple of days later, septic. She needed to go on emergency hysterectomy, ICU. She almost died, and then they found out that she had an anterior perforation, an arterial perforation, and a rectal perforation. So things can go very wrong, and they just published this article saying, well, hysteroscopy is dangerous. And a very smart guy, look here the name, sent a letter to the editor immediately saying, hold on a second, wait a moment. The fact that you had a complication doesn't mean that there was negligence, right? As long as you follow what I call the hysteroscopy rules, this is how I talk to my residents. There are hysteroscopy rules that if you follow them, then a complication might happen and it's impossible to avoid. And the rules that I have, first of all, is the patient. You have to select the right patient and perform the right procedures. So identify what are the complications. Always recognize your landmark. And this applies for any endoscopic procedure. If you do not recognize, if you do not know where the tip of your hysteroscope is, stop, don't move. Obviously, there are rules that you do not advance the resectoscope when it's activated. You activate, from the distance to the proximal. Again, visualization. If you do not perform any procedure without adequate visualization, keeping monitor of the fluid deficit. And my favorite one, listen to your patients. And avoid wishful thinking. If you have a patient who you perform surgery the day before and she calls you the following day that she's distended, she has fever, she has abdominal pain, she doesn't have gastroenteritis because something that she ate is wrong. She has a bowel injury until proven otherwise. So listen to your patients. And surgical complication happens, right? I mean, it's impossible, but it's important to differentiate what the complication is, which is something that's circumstance that makes something difficult, from an error, which is a mistake, is a miscalculation. Two different things. As I always say, there are two kinds of hysteroscopies: those who have perforated the uterus and those who just don't perform enough hysteroscopies. And then when I gave this lecture in another meeting, they say, well, and also there is the one who have perforated and the one who will perforate. So it's almost unavoidable. But complications happen most of the time, 80% of the time, for poor surgical judgment, poor surgical technique. But there is also a small 20% of complications that are just unavoidable. That's the nature of the business. But about those that are preventable, the vast majority happen because of inexperience. And when I said inexperience, it's hands-on inexperience. You can read 20 books, but until you do it with your own hands, you do not gain the experience. And that's where you're prone to have those kind of complications. When we go and look at the literature, I like this study very much because they divided the hysteroscopic procedure into two big groups. There's diagnostic hysteroscopy and then operative procedure. And you see, they look almost 11,000 diagnostic procedure only 14 complications. So the rate of complication in diagnostic procedures is almost negligible, 0.1, as opposed to when you do operative procedure that the complication is about 1%. Still a safe procedure, but there is always chance of complications. And what are the most common complications? There are listed here of uterine perforation. There is a very scary one, which is the gas embolism. You can have fluid overload, and we're going to come back to fluid overload in a second. And the other ones are bleeding and vasovagal reaction, that I will come back a little on vasovagal reaction also, which is one that we don't think about. But for those who perform hysteroscopy with the patient awake in office, it's the most common one. And again, as I was saying, hysteroscopy could be diagnostic of operative, but I want you to bring your attention to this. Operative hysteroscopy, I like to divide it into simple hysteroscopy, which, you know, any gynecologist should be able to do. Simple polypectomy, small myomas, removing IUDs and things like that. Any gynecologist should be able to do this, what I call simple operative. But then there is intrauterine surgery. Note that I don't say simple and complex. It's simple operative and intrauterine surgery. That for this, you need a whole different set of skills. You probably should be a dedicated hysteroscopist, endoscopist, with a lot of years of the 10,000 hours under your sleeve. And again, practice with your hands. You do not become an intrauterine surgeon by reading books. So when we go about complication is, I'm going to present the good, the bad, and the ugly, right? The good is we prevent them, right? They don't happen. But unfortunately, as I said, there are some that are going to happen anyways, and then that's the bad. But you should diagnose them and manage them appropriately. But then the ugly is when you have the complication, you either don't realize, you just don't diagnose it, and you keep operating, or you identify the complication, but you manage it wrongly. And the complications, I want to divide it in pre, intra, and post-operative complication. And you will tell to me, Tony, how could pre-operative complication happen? You haven't even started the surgery, and you're telling me you already had a complication. How is that? And the answer is yes, you can have operative complication even before starting the procedure, when you do not recognize a contraindication of the procedure. And a formal contraindication of hysteroscopy is acute pelvic infection. There are patients who have died as a result of hysteroscopy during active PID. There are others that are on relative contraindication, like ongoing pregnancy, definitely more than 12 weeks you should not do. But there are some studies coming up around that removing of IUDs and other minor hysteroscopic procedure can be done early during the first semesters of pregnancy. Cervical cancer is another one questionable because they might bleed. But what I want to highlight is what is not a contraindication: endometrial cancer. Some people say, oh, you're going to spread the disease, you spread the endometrial cancer into the cavity. There is no evidence that that is the case. So endometrial cancer or the suspicion of endometrial cancer, it is not a contraindication. The other preoperative contraindication is you have the wrong approach. And I like to bring this case because this is the case that actually happened in my hospital. It's a patient with a submucous fibroid. You can see here 9 by 7 centimeters. And the residents run to me and say, oh, Caruño, here is she has a submucous fibroid. I know you're going to do hysteroscopically. And I say, well, I mean, this is an 8 centimeter fibroid. No, I don't think I could do probably this one hysteroscopically. But there is some others that you cannot do unless you are an expert surgeon, and then you embrace the real difficult stuff. But to do this, you really need to be confident and have a set of skills that not like the gift. You have to be like the Messi of hysteroscopy to tackle these kind of cases. Otherwise, we'll be unsafe. Remember always to keep in mind that with fibro, for example, it's a volumetric diameter, right? That creates a 4 centimeter fibroid is not twice as big as a 2 centimeter fibroid. It's exponentially bigger because it's, all we know is the volume that we're talking about here. So the right approach sometimes is abdominal. I tend to do them robotically, but definitely you have to select the right patient. The wrong environment is another preoperative complication. And here, every single one of these could be a single lecture, but for those who, I perform office hysteroscopy a lot, basically you have to limit office for diagnostics or quick procedures. It's funny that the Dispietro just presented the same data, 15 to 20 minutes is the most. I totally have the same number that as he has. Longer than that, the patients start complaining. The pathology is to be only superficial, and you have to select the adequate patient. Not all the patients, patients with anxiety, chronic pelvic pain, those things are not good candidates to do procedures while they're awake. The other thing is the wrong device. You know, as technology starts, and keep coming with new devices and making almost a video game our endoscopic procedure, so we can embrace the new devices, and we have to select them appropriately. Wrong patient positioning. And here I'm going to bring this slide from laparoscopy just to condemn this slide and bring out the differences. When you placing a patient for hysteroscopy, first of all, you do not want the patient on Trendelenburg. Patient must be flat. The other thing is you don't want to use this kind of case syrup. You want to use syrups that allows you to really bring her legs up or down. And another important point is here. If for laparoscopy, the patient stands up the table about 4 inches, for hysteroscopy has to be way more further down. Otherwise, you'll be hitting the table, especially if the patient has an antevaral uterus. And then the other preoperative complication is wrong surgery. If you just do not have the skill to tackle the pathology, you're probably the wrong person to do the procedure. And you should be humble enough to refer the patient to an expert. Now let's go to intraoperative complication. And you know, we have the anesthesia complication that are outside of the scope of this talk. The vasovagal syndrome, and I recently published this review, which I strongly recommend you to read it, because it gives a very practical point of how to manage vasovagal syndrome. Has a prevalence of about 2%, and you have the patient as you're performing the procedure, she starts having blurred vision, she's dizzy, she has an altered mental status, she becomes cold and pale because there is vasoconstriction of the peripheral vessels. But what happened here is it's because at the level of the cervix, there is vasovagal nerves. And what happened is as you traumatize and stretch those fibers, there is the signal that goes to the brain. And there's this disconnection between the vagal nerve and the cardiovascular system. So there is a vasodilation, but because of the disconnect, instead of being tachycardia, there is to compensate, there is bradycardia. So when you put together vasodilation and bradycardia, the blood pressure goes down and the patient has this vasovagal syndrome. It's not dangerous. You have to stop the procedure. You have to monitor the patient, and you can give her some amniotic salve to smell. It's only, this could be a problem only in the patients who have prior, like cardiopathy, arrhythmias, and things like that. Otherwise, it's a very scary but quick things to resolve. The other one is the creation of a false passage. And here, what I want to highlight is you have to recognize the anatomy and how the cervical canal looks like. See how here you see this shredded tissue. Look at the tissue here, and look at the tissue how on the right of this slide, how the cervical canal should looks like. You don't see this shredded tissue. You do not recognize fallopian tube. You go to the end, and it's all like a tubular structure. Be very wary that you're here on the false passage. Again, you have to recognize the anatomy and the structure of the endocervical canal, which is not shredded tissue like this. Again, the most common mistake is people trying to align the image. Remember, you're using an angle scope. So the image, you want to align the scope to the canal. And if you want to align the scope to the canal, your visualization is going to be 30 degrees down. So your endocervical os should be on the lower part of your screen. In that way, you have aligned the scope to the canal. If your hole is in the middle, of the screen, then your hysteroscope is 30 degrees in relation to the cervix. And if you keep pushing, that's how you create the false passage. Again, this is another video that, see, this time you recognize, yeah, this is the endocervical mucosa, you're good. And then there is here an area that they're not really sure, is this the endocervix? And they keep going. And they see what looks like the endocervical canal, but you will see immediately after this, see again, that those shredded tissue that now is no longer looking like the endocervical tissue looks like, see, the band of shredded tissue. So they say, well, this doesn't look like, they come back a little bit and they realize that probably, see, on the top, there is another hole where they should have gone through, and that's the real cervical canal. See, the mucosa, it's like the endocervical mucosa should look like, and when they decide to go through that little hole that they missed the first time, voila, they find the uterine cavity. But you can also miss the canal, or you can actually create in a very elegant way a false passage. And there's, you know, this technique, they go with the scissor because they think they are cutting into adhesion on the cervical canal, and they keep going. And this is a well-defined technique when you have cervical stenosis, but they keep going with the scissors. And again, see the shredded tissue that I told you, that now they're putting pressure. That's another technique for cervical stenosis. Keep applying pressure. Then they say, well, no, let's use the grasper. And now they use the grasper to overcome this cervical stenosis, and they keep going, And this, see, at the very end, if you can pay attention there, that's probably already a serosa of the uterus, and they keep going as they go back. You see that they'll realize that, oh, they missed the real cervical canal, and they actually created the cervical canal with the scissors. So you have to be careful, mindful that you can actually create the wrong path, and see that they go in and out. This is clearly the uterine cavity. I like this video because it shows the shredded tissue that I was telling you. See, when you see this, beware. Get this image in your brain, because when you see this shredded tissue, you're very likely in a false passage. And to continue here, they keep going, and they keep putting pressure on this shredded tissue until at some point you can tell that boom, they perforated, and now you're looking at bowel. Or you can have the wrong cavity, right? So you go, this is a cystoscopy. This is inside the bladder. And then you look around the bladder and you find a Mirena IUD. So I don't know how Mirena ended up into the bladder, but yes, you can. You can have the. I know. That's your video. That is your video. You can have the wrong cavity right there. So uterine perforation, and I love this video because so you have the you see the bowel, you see the rest of the bowel there, and then this is what you see. This is how a uterine perforation looks like. You don't see anything. It's impossible to distend the cavity. And get this image in your brain. This is what you have when you have a uterine perforation. And that's what I love this video. The famous Japanese flag, all you see is red. It's impossible. It doesn't matter how much you increase the flow. suction, anything, you cannot distend the cavity. You're not going to have adequate visualization. And this is what you need to do. You need to retract and remove your hysteroscope. Also be mindful of the location of the pathology. This is a small fiber, but it's located at the cornea. Remember, the cornea is the thinnest part of the myometrium. And they're doing this cold technique, and boom, just 1 millimeter perforated. Is just because of the location of the fiber. Have this fiber been in this fundal or in an anterior wall, this would have not happened. So you have to be mindful of where the location of the pathology that you're working on. Same thing is the strength that you use when you're using your resectoscope. So this is going to be a resectoscopic ablation. They identify the area that they want to resect, and then when they see that they're resecting the endometrium, and they not only resect the endometrium, they're resecting the entire thickness of the uterine wall. And they continue to do it. That is the other problem. I want to highlight this. The problem with hysteroscopy, when you have a complication as opposed to laparoscopy, sometimes it's hard to identify the complication. And you see people keep operating, and even in the presence of a bad complication. Then the other thing is when you don't know the rules. Remember, you do not advance your device forward, because this is happening. And then you have a perforation, right? You say you see you already perforated. They don't recognize it, and they keep going. They keep operating, and this is where dangers can happen. And again, you cannot distend the cavity anymore. And at that point, they realize that they probably are in trouble right there. But that's lack of knowledge of the technique, a lack of knowledge of identify the complication. So the perforation, it depends on the location of the perforation, what the consequence could be. So if you have a lateral perforation, you should be worried. There might be bleeding because you might hit the uterine artery. If it's a fundal perforation, you might hit the bowel. Posterior or anterior perforations, like here, you can have bowel or bladder injury. So depending on where, the three things are important in perforation: the location, the size of the perforation, and the device that caused the perforation. Was this a device with energy or not? So the question that you always ask yourself is when to do a laparotomy, a laparoscopy when you had a complication. Well, then whenever the patient is unstable, you're forced to do a laparoscopy to check what happened. If there is bleeding that is not stopping, if you use energy during the perforation, if you had a lateral perforation that could hit the uterine artery, if there is manipulation inside the peritoneal cavity, you didn't realize, and you continue manipulating and you were into the peritoneal cavity instead of the uterus. And my favorite one, if you have the gut feeling, that something bad is happening, do a laparoscopy, can always be safe. Remember, there's 2 types of hysteroscopy: those who have perforated the uterus and those who have not done enough hysteroscopies. This is a patient, a case of, she went for a diagnostic hysteroscopy. It was in the OR. She came out of the OR and she complained of excruciating pain that was unproportionate to the procedure that she had done. So they do an ultrasound and they find this huge broad ligament hematoma. And the team has the great idea of taking the patient back to the OR to explore hysteroscopically the broad ligament hematoma. And this video that you're seeing here is the unique video on how a broad ligament hematoma looks like in hysteroscopy. Obviously, you should not, you just watch those, you don't operate on those, especially if they're tamponated itself. So I strongly discourage people to continue to explore, but this is what they wanted to do in this case. And see you can see to the left, there is the hematoma, and they actually decided to go inside the broad ligament hematoma. And this is what you'll see the blood clot formed, and there is yellow, which is omentum. This is a perforation that went all the way inside the cavity, and they're exploring with the hysteroscope. I discourage that tremendously. This is another patient who had an IUD that was wrongly placed. See how the IUD is embedded into the endocervical canal. If you go with the hysteroscope below, that's a totally normal uterine cavity. So in the interest of time, I'm going to advance. So the IUD is slowly removed, but in the process of removing this IUD that was already perforating the uterus, so there is a big perforation, and you can see there. Remember, there's shredded tissue that denote a perforation, but look how interesting. All the fluid of the perforation dissected the retroperitoneum. There is not a single drop of fluid inside the peritoneal cavity. It's all retroperitoneal. And this is what can happen also. See how all that, if you have a hematoma of the broad ligament, the broad ligament could easily bleed into the retroperitoneum like that, and you do not see anything inside the cavity. A good trivia. I know Osama likes trivia. So if you're performing a hysteroscopic mammectomy and then suddenly there is bleeding, the uterine cavity collapses and you cannot see anything. What is the most common cause of this situation? And the most common cause is that you run out of normal saline. You run out of your distension media. What brings me to the topic of fluid overload. And the key word on fluid overload is anticipate. You have to anticipate the patient, the procedure that might keep you in fluid overload. You have the patient who tolerates less, so you have an elderly patient, and you talk to the anesthesiologist in advance. You tell the first, don't give them too much IV fluid before the induction of the anesthesia, because I'm anticipating that this patient could have fluid overload. Again, the concept of the mean arterial pressure, right? On which you want to be below to prevent the passage of fluid from the distension media into the cardiovascular system directly. You need to remember that the tubal pressure is about 70 millimeters of mercury. So if you are below 70 millimeters of mercury, there will be no spillage of fluid from the uterine cavity through the fallopian tubes. And as we said, the maximum volume that allow it's 1,000 cc for hypotonic solution when you use monopolar devices. And when you use isotonic, normal saline, basically, is 2,500 milliliters. What's important? What's important is the duration of the procedure, the type of fluid is normal saline, and the fluid pressure. And that's what we're going to talk in a second about the pressure, because the whole intrauterine pressure and the maximum pressure that you can use, it's so relative. And here is the proof. The whole pressure thing, first of all, it's very complex. There is variation of fluids in the bags. There's been studies where they said that the bag has up to 10% more than what it really state is the amount of fluid inside the bag. It's difficult to estimate the deficit. There are fluid management systems that are based on weight, there are based on volume. But the real intrauterine pressure is impossible to measure. And what is the ideal pressure? The ideal pressure is the minimal amount of pressure that allows you good visualization. It's not a number. The other important thing is, with normal saline, hyponatremia is no longer an issue. There's two things that also are important. When there is extravasation of fluid through the fallopian tube or through an undetected perforation that is also a source of extravasation, that fluid goes into the peritoneal cavity, and the peritoneal cavity will reabsorb it slowly. It's like a dialysis. When you do peritoneal dialysis, don't they throw a lot of fluid inside the peritoneal cavity? Nothing happened. When you're doing isotonic solution, in the past, when you have a hypotonic solution into the peritoneal cavity, was an issue. But with normal saline, it's no longer an issue. With normal saline, the issue comes when you have intravascular flow that flow goes directly into the cardiovascular system. Very different. And that happens when your pressure is on the fluid is above the mean arterial pressure. But what's important here is the surgical time. If you're effective, you're an effective surgeon, it doesn't matter how high you go in the pressure. If you conclude your procedure quickly, If you coagulate the active vessels and you move in an effective way, the risk of fluid overload, it's almost negligible. Having said that, bad complication really, really happen. And this is a case that you see. Yeah, it's obvious that you're into the peritoneal cavity, but here they're probably not realizing that they're looking, and they keep bringing the resectoscope back, and now the resectoscope, now this looks like pink. I don't know what they are. They're looking around trying to identify, I don't know, the polyp or the fibroid that they were chasing. And then they keep retracting the resectoscope. And well, they probably think they see these pieces, we should remove it. And they continue to resect a little bit more until a guy come by and say, you probably need to do a laparoscopy here. And they decided to do a laparoscopy and look at the size of the uterine rupture. These are the things that should never, never happen. Another case, this is in office. Remember the shredded tissue that I was saying? Well, if you keep pressing, you keep pressing, you keep pressing. And like in this case, they continue to press, and all of a sudden, boom, you're inside the colon. This is how a colonoscopy through a hysteroscope looks like. They perforated the posterior uterine wall, the rectum, and now that's feces that you're seeing inside the colon with the hysteroscope. This is one of my own cases. This patient had cervical stenosis, and I'm trying to overcome the stenosis. The internal os is clearly occluded, and I see, I do the technique with the grasper, and as I keep going, keep pushing, thinking that's the internal os, let me open it a little bit with the grasper, and I keep pushing, and then I'm almost there, a little bit more with the grasper. I remember this is my own case. I keep going, keep pushing, and all of a sudden I see this, and I say, oh my God. Remember, I had the video of the colonoscopy that I'm preparing to give the lecture. And then I stay quiet, I clean, and now it was all blood, and I was actually inside the uterine cavity, but it was just all blood accumulated, and was lucky enough. It was not the rectum, but it's scary enough. Postoperative complications, you have immediate complication, infection, bleeding, and things like that. But you can also have late complications. So this is a hysteroscopy. You go, you see this yellow stuff. Yellow should never be inside the uterus. It's the omentum that goes to obliterate whatever perforation happens. This is a very interesting case that we published. This is the endocervix, and you see this polypoid tissue that looks strange. Is the fimbria. There was a perforation. The fimbria prolapsed through the perforation and through the internal os, and what you see in here is the fimbriated end that prolapsed to the perforation. This is another interesting. This is a patient who had an isthmosil repair, and for several days later came back with this. So that is a fistula from the bladder to the uterus, because of necrosis of the defect on the isthmosil repair. You can see, I'm going to advance here. So you see down is the uterus, above is the fistula, above is the bladder. That is a fistula. And when you see a cystoscopy, this is a cystoscopy, you can see the end here. See the hole on the bladder. That's because that area necrosed because of thermal damage. This is another case. It's a patient that comes in, the fetus is she came crashing. That you can see the fetus is almost outside the uterus, and they start her a C-section, and the patient had a hysteroscopy with a perforation. She got pregnant quickly after that, and she had a fundal uterine perforation, and the fetus prolapsed through there because she got pregnant recently after a perforation. So can a patient die from a simple hysteroscopic procedure? The answer is unfortunately yes. There been happening. You can, if you Google the, the hospital was sanctioned. This is a doctor who actually lost his license after perforation. Severe hyponatremia that used to happen with monopolar, and patients die. Septic shock for undiagnosed bowel injury. Patient came back afterward and died. So I don't mean to scare you, but respect hysteroscopy. Pay attention to details, practice, hands-on practice, not reading books, hands-on practice. Be ready for the unexpected. Listen to your patient, please. Avoid wishful thinking. And as I said at the beginning, when in doubt, please stop. Avoid causing further damage. Remember, for any endoscopic procedure, it's like holding a baby pigeon in your hand. You have to hold it soft enough not to squeeze it, but hard enough not to let him fly. Because at the end of the day, the rest of the life of your patient, when she's on the table, is in your hand. Thank you very much.
Tony, do you hear me, Tony?
Yes. I hear you.
Okay. Now, I regret that I invited you to this.
Why is that?
I regret. You scared all my guests, okay? You scared all that was a scary. I think you should put the title of the presentation, Scary Movie, okay? Scary.
You see those videos? You see, it's amazing.
I couldn't imagine. The real thing, that those who perforated and continue
that is the problem. Yes.
This can never happen in laparoscopy. In laparoscopy, once you cut the ureter or the bowels, you know your limit, okay? But in hysteroscopy, as I always say, there is a loss of orientation. You don't know where you are. There is no identifiable left, right, anterior, posterior. So, and the tissues looks all the same. And I always repeat that hysteroscopy is a tissue character surgery. The surgeon should know the difference between endometrium, endocervix, myometrium, and serosa. So thank you very much. You were really a big addition to this event, that because we want to put some brakes for the enthusiasm for hysteroscopy. And my famous classification that I blasted a long time ago, there is a hysteroscopy and there is an intrauterine surgery.
Exactly.
Absolutely different equipment. The equipment is different skills, different complications. So we have to distinguish, because every new beginners, they attend the workshop, they get the certificate, take a selfie picture, and then they go to do septum and big myoma. Impossible. Exactly. No, hysteroscopy is diagnostic, biopsy, polyp, missed ICD, very short septum, and myoma less than 1.5 centimeters. That's hysteroscopy. And everybody can do this. You'll never miss. But if you have the courage to go into cavity without having a landmark, you will do this catastrophe. Okay. Thank you very much, Tony. What is the time now?
And you do not become an intrauterine surgeon without hands-on practice. Do you agree?
I always say this in the groups, but some people doesn't like it from me. I say you cannot be a surgeon from a textbook. You cannot learn bicycle driving or playing tennis from a textbook. Okay, this is just and even simulators. Okay, when I wanted to play golf, I went to Florida and I bought the most expensive simulator. And I went back home, and then my trainer said, "Osama, you are stupid. Do you think by this simulator you can be a Tiger Woods?" Okay, it's impossible. Yeah. Well, so
thank you so much.
Tony. Thank you, Tony. And if you want to stay with us or if you want to move, because time is running, we have only 3 presentations, and I see that the number of audience is not changing much. Only 3 people left, so we are left with 3 nice topics. From me, I'm going to take you in a journey about the wonders of hysteroscopy. And then Dr. Narendra Malhotra, the president of Foxy, ex-president of Foxy, and a well-reputed infertility specialist, will talk about PRP and how this can help improve the endometrium, and then we will finish by the Asherman by Dr. Yahya Shawki. So if everybody is ready, let me share my screen. Okay, and again, I see that, I repeat that it's a pleasure that many of you are sitting relaxed on the couch or on the beach or in the gym and following this nice conference. Okay, well, talking about wonders of hysteroscopy, I mean that I have to show you something you didn't see before. First, I would love to welcome all of you to my home. People ask me, Osama, why you are in deep love of hysteroscopy? Confidentially, the answer is like that. Since I was a child, I was dreaming to be a hero in many things. I dreamed to be a hero in tennis. I was dreaming that I would be Federer or Nadal, but I failed. And then I thought I can be Messi or Cristiano Ronaldo, but I was very lousy. Nothing I succeeded in except this. Inside the cavity of the uterus, I found myself. I found the best time of my life when I'm inside the cavity of the uterus. So it's also very challenging. What to tell you today? They're very limited topics. Polyp, septum, myoma. So what's new? Should I impress you? What are the topics, the subjects that I can attract your attention and to say, yes, we learned something new? Well, let me start by a word that you repeated, vaginoscopy. Everybody know that vaginoscopy was published in the late 90s by Stefano Bitocchi and Luigi. And actually, you know, in their first experiment, they used to put a speculum and then go by the telescope. Later on, they said no speculum, no tenaculum. And the purpose of the technique is to facilitate insertion without instruments to make it easy in the office. But however, when I was thinking, the word vaginoscopy is not correct. The classic article is still there. You can read it, okay? It does not mention anything about examining the vagina. So the innovation that I'm bringing to you today, one of the wonders, that in the office, we have a beautiful tool to examine the vagina, to see the corners of the vagina, and to see the portio vaginalis of the cervix. This is fluid distension vaginoscopy. You can see each and every corner of the vagina. And this is the strawberry pattern of trichomonas infection. If you put a vaginal speculum, you will not have this view at all. So that's a new vision in gynecology. Look at this. This is a postmenopausal atrophic changes. I call it my vaginoscopy technique because the purpose here, the purpose is to do endoscopic examination of the vagina. This is postmenopausal. And you know that, my friends, in postmenopausal women, it's very difficult to put a speculum. The vagina is very narrow and the mucosa is very atrophic and brittle. So putting a metal speculum is untolerated. But look at this examination. Again, this is the strawberry vagina, portio vaginalis of the cervix. And you can see a lot of hidden pathology. Look at that. This is a deep infiltrating endometriosis. Not only to diagnose, but also to treat. So I'm bringing to you another wonder, another amazing application. That's why please share with me my vision. Stop saying hysteroscopy. No, it is not hystero. It is office gynoscopy. Gynoscopy because we examine the vagina, the cervix, the uterine cavity, and even the proximal part of the fallopian tube. So it's a total examination of the female genital tract by this 2.9 telescope, and it gives a clear vision for the gynecologist for inspection and more accurate diagnosis. Let me share with you another application. This is a V1 anomaly, longitudinal vaginal septum. It's a kind of anomaly. And the traditional technique was to put two retractors and go by scissor and cut. Enjoy the procedure. That's an intravaginal endoscopic surgery. you have a panoramic distension view. So there is no worry to injure the bladder or the rectum. It's much more safe than putting a retractors and cutting without vision. Here I can look down, look up, posterior and anterior, and stay exactly in the middle. Exactly in the middle, and you readjust your level according to the distance between the anterior and the posterior. If you have one bleeder, don't panic. Go and touch. You see how, I will not say easy. I will not say how easy. It's not easy, but I say how simple it is. It is simple if you learn how to do it. And this video is real time. Real time, it's 1 minute, 12 seconds. 1 minute, 12 seconds. That's the vaginal septum all the way till the external os. This is one os, and that's the septum release. Actually, it's 1 minute, 40 seconds. Okay, 1 minute, 40 seconds. And no bleeding, and no need to take sutures. Let us jump to another wonderful application. Examination inversions. You know that in certain cultures, the hymen is as important or even more important than the eyes of the girl. The family can accept problem in her eyes, but not to damage the hymen. So what about girls have bleeding and a polyp like this? You will be amazed. And I think those from the Middle East will know that fact. The family can accept a recommendation to do laparotomy, bisect the uterus and get this polyp out. And they will not accept violation of the hymen. But this is what I share with you now is a transhymen. That's a transhymen approach. Beautiful. You can glide through the hymen very easy, whether by the large or the small resectoscope. Definitely the small resectoscope is easier, but here I'm using the large. And you can retract and push the polyp to one side. And you can see the pedicle. And then you can cut it. Imagine the outcome. Solving this problem for the family is so appreciated. And we know that young girls are curious about their bodies. 4 or 5 years girl, they sometimes they play and put some foreign body inside the vagina. Like this girl. This is like a ring, metal ring inside the vagina, and the family know, they can see it through the hymen. So I go by the transhymen, but because it's metal, it's difficult to catch. You see, it slips. So let me show you a wonderful solution, because the topic today is wonders. Wonder that you didn't see somewhere else. Wonder that when you see it, you say, okay, today we learned something new. So I passed a thread of Vicryl through the hole of the ring, catch it from the other type, and then pull both of them together like that. So now this is, and you get it out. Well, let us go back to standard things like the septum. I know that you have seen so many surgeries about septum in lectures today and before, but it's nice to see the same thing with a different way, different attitude. Okay, I see that most of the surgeons, they tackle the septum by pushing kifal, and I find this is not accurate, not precise. And when you're near the fundus, if you push, you might perforate. So enjoy this video. First, you have to achieve a proper intrauterine distension to stretch the septum. And this is the Collins knife aligned with the GPS point, the tubal ostium. It's very clear. People sometimes say, okay, Osama, you are lucky, you are a fast surgeon. I operate very slowly. I'm not a fast surgeon. But once I see well, listen, my friends, the trick in the septum or intrauterine is that you see well. If you see well, you'll finish quickly. Let us agree upon some facts. Still, some people are not aware about. Septum is not fibrous tissue. It's a predominantly muscular. Septum is part of the anterior and posterior uterine walls. We published this work 2016, and I think Stefano and his colleagues published 2020, the same study, histological analysis of the septum, and we found that it's very rich in muscles. And today there was a debate between me and Yaqub Khalaf that it's difficult to identify which septum will cause infertility. What we found in this study that the septum was predominantly muscular. It had the worst reproductive outcome. So by color Doppler, we can know that if the septum is muscular or fibrous, so we choose, or in my opinion, the predominantly muscular one should be treated. My proof that septal tissues is muscles belong to the anterior and posterior wall is this video. Look at that. Moving the electrode from side to side, this is the technique that I advise, and I will show you the video later. And you can obviously see and clearly obvious that the fibers retract anterior and posterior. There is no residual fibers. And this actually answered the question, should we incise or excise? Because there was a big turbulence due to a recent article also from colleagues from Europe saying that the septum should be excised. So my only reply to them, this is the end of surgery. This is the end. Do you see any residual part? There is no residual part. And even the tissue is retracted. Look, this is the endometrium, and this is the septal scar. So you just incise, no need to excise. Enjoy 2 minutes septum procedure. Move the electrode from side to side. Stay exactly in the middle. Look at the tubal orifice, the tubal ostium. The tubal ostium is your landmark. Don't go up, don't go down. Exactly in the middle. And move, steady hand. Until both tubal ostia are at the same line. You will see it now. Both tubal ostia should be viewed at the same line. Both tubal ostia at the same line. This is the cut-off limit. And this is the real time of the procedure, 4 minutes. And this is the final view. Complete release. Please don't say excision. It is a release, not excision. And the results will be shown in post-operative hysterography. Now, before and after. So I told you wonders that I want to show it my way, okay? To see the same thing with different way. When you do the septum with this technique, you have a perfect reconstruction, unification of both cornea, and no scar, no charring, and no fibrosis. Should we use any post-operative regimen? No. No. Osama, what is your proof? It is my observation. As Dr. Yaqub said, there is the experience or expert opinion. On YouTube, there are more than 2,000 septum. You can watch them. I don't claim I did 2,000 septum on a paper. I don't have a paper saying this, but I have a channel with you can visit. There are hundreds of septums, and I do follow up and second look. I will show the second look. So no need to use any post-operative regimen. And this is the second look after one cycle. Everybody, look at this beautiful view. Look at this. People thought that the healing will come from the sides. So the logic says that the healing comes from the side, but no, there is an islands of endometrium. Islands of endometrium starts to float and regenerate. And there is a new blood vessels coming. This is only 1 month. So I will show you after 1 month and after 3 months. This is the scar of the septum, which was very white. Now starts to have pinkish islands. And if we repeat another second look hysteroscopy, we have an absolutely normal regeneration of endometrium and no need for any post-operative treatment. And this patient can be left for pregnancy, whether spontaneous or assisted reproduction, after 3 cycles of that surgery. A unicornate uterus is another congenital anomaly with a controversy, should we treat or no? My personal opinion, if you listen to me, the problem in the unicornate is not of a small size cavity. No, because you know that in the normal uterus, it can accommodate for twins and triplets. So it's very ridiculous to think that the small size cavity is the reason of reproductive failure. No. In my opinion, whether in unicornate or in the septum, it's increase in the muscular thickness in the wall. So treatment by expansion metroplasty, and the purpose of expansion, as I repeat again, is not to increase size of cavity. No, is to decompress the thickness of the myometer. Osama, from where you get this information? From my observation. Look at the thickness of the myometer. It's very thick. So I prefer to do it with the scissors. Any reconstruction in the uterus in a small cavity is better by the scissors. In the septum, I can do by electrocautery, but here I do. Look at today and tomorrow, we have a workshop. We have a complete half day about how to use the scissors. It's not easy. It's very ridiculous. It's easy. No, it's not easy. How to rotate the scissor, how up and down, how to cut, how to retract. So this is cutting in the lateral wall. I am sure many of you wants to ask, what is the limit? You should have a pre-operative ultrasound, preferably 3D ultrasound, and measure the thickness of the walls. So this is the tubal ostium, and cutting on one angle and the other angle, and this is the final. Everybody look at this. Tony, if you are still here, look, Tony, look at the original endometrium she has. This is the original endometrium she has. Okay, and look at the white on the left on the side. Okay, like the highway with the two ways on the side. So imagine how much expansion we have added. So it's plus expansion of the cavity, it's a decompression of the myometrium. Fibroid is a very hot topic. And today in the workshop, I was telling Tony, listen to this example about complications. If I bring 10 beginners gynecologists to stand with me watching TLH, and they have never done it before, and watch me dissect the bladder and push the ureter and cut the uterine. And after I finish, I say, okay, who is ready to go alone and to perform the next case? Nobody will have the courage. But if I bring 10 beginners to watch me doing myoma resection, and after I finish, I say, who wants to try? Everybody will do, okay? Everybody, yes, it's easy, okay? Myoma resection is much, much more difficult than laparoscopic myomectomy. Laparoscopic myomectomy, you have the myoma here and big abdomen. So you have a space, right and left. And you have 1, 2, 3, 4 instruments. But here you have only one instrument, and the cavity is occupied by the mass. There is no space. So step number 1, create the space. Create the space is not as simple as you think. Create the space is a long story. How to handle the inflow, outflow, how to use the nozzle of the resectoscope to direct the push of water to push the myoma to one side like this. Now I created it again. So you direct the jet of water toward the myoma, and then it's pushed to one side. Now you created the space, you can cut. Another important advice. Don't keep going out, in and out, in and out. Another very important skills, my dear friends, is how to handle the tissues and the debris. Also by using the electrode to push them to one corner, or the jet of water, collect them to one side and keep on working. If you go out, the cavity collapse, some bleeding, and you go in again, you lose the visibility. And the chance of fluid overload is still high. So also, I see many beginners, even expert, they take very thin slices like potato chips. This is not good, because you will end in a long time, and time is not money. Time is fluid. Time is fluid overload. Another thing, that when you take thin slices, you will have a crowded cavity. So instead of potato chips, cut a thick bites, which is wedge potato, like this one. Push the electrode, hug the myoma, and pull the electrode back. Listen, my friend, push the electrode, squeeze the myoma between the electrode and the posterior wall. Don't be afraid of perforation. If you see well, let the electrode to go deep into the myoma. So by this, you will cut a wedge potato. You take a big bite, okay? You take a big bite and then pull the electrode, not all the way back, because if you pull the electrode all the way back, the cut tissues will come to cover the lens, so you will not see anything. So pull the electrode halfway by the working element halfway, and then all system out. Halfway, all system out. Watch this. And this is the final view. Final view when you see the myometrium. Sorry, I was getting my Panadol. So now you appreciate how I love you all very much. I'm very tired in Dubai and I'm taking Panadol to stay. Well, so the final view when you see the myometrium, this is the myometrium, okay? How to identify the myometrium? It is interlacing crisscross fibers. This is myoma. This white thing is myoma. But the myometrium, which is the cut-off limit, this is the myometrium. Look at this. This is the myometrium, all right? And at the end of surgery, you enjoy your victory. If you face bleeding, with all my respect to the complications that Tony said, I don't agree that bleeding is a complication in hysteroscopy. Have you ever heard about patient died of bleeding in hysteroscopy? No, unless if you puncture the iliac vessels. I mean inside the cavity of the uterus. You see the mouth of this vessel? The vessel is coming through the myometrium. So eventually, after you finish the surgery and the uterus contract, it will stop. But the problem is that if the intrauterine pressure is less than the arterial pressure, this bleeder will be troublesome. It will turn the view red. So you have to cauterize like this. Come close and touch. This is how to do hemostasis. Now, bleeder stop, other bleeder. This is the base of the myoma. This is the base of the myoma. The purpose of cauterization here is not because of patient safety that this bleeding will be fatal. No, this bleeding will stop spontaneously, but to be able to see and continue the surgery. So the last wonder in fibroid, to show this, when there is less than 50% bulge inside the cavity is type 2, but still the myoma is big enough that also bulging through the serosa. So this myoma is type 2 to 5. So traditionally, hysteroscopy is not indicated. But why I try to remove it by hysteroscopy? Number one, because I love the challenge, but also patient safety is important. This patient had previous 7 laparotomies, and this myoma is not accessible by laparoscopy or laparotomy. So let us enjoy a nice technique. Using the scissor to cut into the fundus. This is the fundus of the uterus, all right? Tubal ostium. The fundus is sagging down, falling down, as if a septum. It's not a septum. It is the myoma here. This is the myoma. You can see it. And this is the myoma capsule. So this is cutting the thin fibers of the capsule to expose the myoma. And the view is like that. Okay, this is the myoma, but still, it is not accessible. It is not accessible. This is the myoma, all right? Bulging, you can see it, but it's not accessible. So let us share now a very nice approach using the laparoscopy myoma screw. Side by side to the hysteroscope, side by side. It's a long story. You have to dilate the cervix, insert both together, and then screw the myoma and pull down under full visual control. Is it easy? I wouldn't say difficult, it's nearly impossible. Maybe I tried 20 cases, I succeeded maybe in 12 only. But this encouraged me to improvise and improve my technique to have higher success rate. So this is a solution to remove a deep intramural myoma in patients not easily accessible by laparotomy or laparoscopy. You see now I'm pulling the myoma down, 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 down. It's almost at the cervix now. The myoma is detached, and this is the final view. It's a beautiful view, beautiful view. Okay, this is the myoma bed. I know that the hysteroscopists will love this. Will love this. It's an enjoyable victory that you could jump over the challenge and remove the myoma safely from the fundus. People ask, what about this defect? Will it stay like this? No, it will collapse. When you decrease the fluid pressure, it will collapse and edges come together. This patient got pregnant and cesarean section. Adenomyosis, you can diagnose by ultrasound. If there is a role for hysteroscopy, yes. As long as I identified where is the site location of adenomyoma, you can go by the resectoscope. This is not a perforation, Tony, okay? This is not a perforation, all right? This is simply the adenomyoma. You see that? A beautiful approach. But I should know beforehand. I depend on the ultrasound GPS to tell me where is this mass. Another adenomyoma, wrongly diagnosed as a fibroid. This is not a fibroid. You will ask me, Osama, how could you know this is not a fibroid? Look at this. Please, everybody, train your eyes. In my lecture, I want everybody to benefit. Train your eyes. This is not a myoma tissues. This is an adenomyomatous tissues, okay? With these circular lines. So be prepared, Tony, to see something scary now. Something very scary. I'm cutting in adenomyomatous tissues. And suddenly, oh my God, what is this? Is it a perforation? Okay, Tony, this is another uterine cavity. It's a mini uterine cavity, deep intramyometrial. So this is endometrium, you see? But it was not full of blood. So what I have done, I excised the adenomyotic tissues and cauterized this lining. Nobody have spoke about this, but it's all innovations in hysteroscopy. Another big adenomyoma and the location near the fundus. So you cannot see it. You will love this, Tony. You will love this. Can you see any bulge inside the cavity? No, there is no bulge. Okay, but by the magic, jadugar, jadu means magic. Okay, I say hocus pocus, and observe what will happen now. And slowly the bulge is forming. So you could make the invisible to be visible. Okay. How to do this? By uterine massage. And this is now the hysteroscopic procedure to cut into the mass, the bulge inside the cavity. And don't be frightened, sudden gush of blood. Okay, this is not fecal matter, not colon. No, it's dark blood inside the cavity of an adenomyoma. That's it, okay? This is the adenomyoma cavity, and then I did cauterization by the roller ball. Okay, now come to the most wonderful case of the day. Everybody look at this, don't miss it. Malhotra, don't miss this one. This is a IUCD perforation transtubal. And don't ask me how it happened. Probably during insertion, the uterus was rotated and the doctor pushed bullseye perforating through the ostium. Let us see one of the wonders of hysteroscopy. Observe, look, and enjoy. This is the tubal ostium. Look at that, Tony, okay? So the perforation you see it only once in your lifetime.
Hysteroscope देखने नहीं डालता ऐसे blindly डालता है
your sound, please?
तो वो इतना जोर से की ना कि
please mute yourself. Others, please mute yourself.
And the direction of traction, Tony, should not be down. No, in the opposite direction of the perforation. Perforation like this, so you push like that. This procedure was done office without anesthesia. That's a scary movie.
I have to include your video in my talk.
Wait until the surprise at the end to see who was the surgeon. It was not me. It was not me. So twisting on the loop, make it more extracted. So the transverse arm should come now. The transverse arm is still there. Be prepared to see the transverse arm now. You have to catch from the nearest point of perforation. So the fulcrum of power should be strong enough. And now you will see the transverse arm extracted. It's coming bit by bit. That's it. Half arm out. This is the real time of the procedure. I swear to God, it was done in the office, no anesthesia. Look here, this is the perforation site. But this is not a hysteroscopy complication. It's a complication of IUCD insertion. Now it's totally extracted. This is the perforation site. No need to do laparoscopy, no need to do laparotomy, and you can reposition it and leave it inside. Ladies and gentlemen, let me introduce the person who did this case. It was not me. Okay.
Para sama Eric rupanya ini
I have to. Wait. Okay, so this is the gentleman who did the case. So I was traveling, I was in India at that time, and he took the opportunity to do the case. So the case before the last, very strange. This case was in the city of Trishur in India. They told me that this patient is infertility and there is a foreign body inside the uterus, but we don't know what it is. Any idea what it is? It's not an IUCD. It is an abortion stick, all right? So the patient inserted a wood stick and it perforated the fundus. It perforated the fundus, and this stayed inside the uterus for maybe 10 to 12 years. And by hysteroscopy, you could disengage, dislodge, and get it out from the perforation. So now you trust me when I say wonders of hysteroscopy. Everybody's happy? So we come to the last thing before I tell you goodbye and introduce the next speaker. Another wonder. Since I was a medical student, it was amazing to me how the sperm travel from the cavity of the uterus to the fallopian tube. So watch that. This is the last video. These are not real sperms. They are sperm-like particles, okay? And observe what will happen when it comes near to the ostium. Here. Look at this. It is suction. Look at that. Look at the ostium. And now you will see a beautiful phenomena. The methylene blue test. Look at that. Beautiful, beautiful flow of the methylene blue through the ostium. Thank you, my dear friends. Thank you, everybody. Thank you for waiting till late afternoon. Everybody is enjoying, and I'm enjoying more than all of you. I thank all the participants, and we are almost about to finish by the last two talks. Usually, it's easy to introduce a speaker who you know as a colleague and friend. But when he is like your non-biological brother, you don't know what to say, okay? You don't know what to say. We think in the same way, we have the same heart, the same mind. And family-wise, he cares about my children more than myself. I love his family. He is a very, very respected man in India. He was the past president of the Federation of Obstetrician and Gynecology of India. And the funny thing that his wife became the next president after him. There is no big title that he didn't became the president. He was the president of the Association of Infertility, of the Federation of the Ultrasound. This is out of two things: of his academic level, number two, about love and respect from the people. So it is my privilege to introduce Dr. Narendra Malhotra from the city of Agra, where everybody knows the Taj Mahal. Narendra, thank you for being in my life.
Pleasure to be, sir.
The screen is yours now.
So if you stop sharing your slides, then I can share.
I will do.
So very good evening to all of you. It's about 7:30 here in India, and I see a lot of my Indian friends have suddenly joined in. Thank you for joining in. What we're going to talk to you about today is stem cells and PRP in human reproduction. And that is what my latest or our latest love is now, because we feel that we are moving from cell treatment, from pill treatment to cell treatment. So PRP and stem cells and OBGYN, is it there? Does it work? What is it? Now, the only man is not content to leave things as they are. And we've seen that example in Dr. Osama Shauki and his son Yahya Shauki. As they are, but must always keep changing. And when he has done so, he is again not satisfied with the result and he keeps changing again. That's Osama Shauki for you. Advances in science is always for the betterment of human being. In science, the important thing is to modify and change one's idea so that the science advances or the ideas advance. Now, we know that the stem cell revolution is here. Everybody knows that, or at least hopes that it is true that the stem cell revolution is actually here. We need to understand what are stem cells. Everybody of us have stem cells. Everybody uses stem cells. Everybody every day use stem cells, and we regenerate our body by the stem cells which we have in our body. And these are in various places which we'll just talk to about. So we have a stem cell, and this stem cell can differentiate into other stem cells and specialized stem cells. So it's an application of stem cell. It involves transplantation of autologous or allogenic stem cells into a patient, either by a local delivery system or systemic infusion. And then these stem cells will home themselves to where the damage is and will start producing that. So stem cells can make more stem cells, and they can differentiate into other stem cell type, which is now happening. So where do we get them? The maximum number of stem cells we get is in the cord. umbilical cord Wharton's jelly, umbilical cord blood, the placental blood, which we throw away. And this should be stored, and this should be stored because it can be of future use for self, sibling, public banking. The other things which are rich in stem cells at birth is the amniotic fluid, the cord blood itself, the umbilical cord itself, the placenta, and all this should be stored and cryopreserved. Unfortunately, we don't have that many cryopreservation labs. Otherwise, we will be very, very rich in stem cells. 27 million deliveries occurring in India alone, and we can supply stem cells to the whole world. What are PRP? PRP or platelet-derived growth factors are released from alpha granules in the platelets when they get activated. Supposing we have an injury, the injury gives a signal, and all the platelets and our WBCs rush there, and they will repair that injury. So there'll be IGF release, there'll be PDEFG release, platelet-derived epidermal growth factor release, there'll be platelet-derived growth factor release, transforming growth factors, endothelial cell growth, VGEF, and basic fibroblastic growth factor. And this will all repair that injury. That's what happens to a body whenever we have surgeries. That's why all the scars heal and the injuries heal. So is the treatment with PRP a real science, or is it hype? Now we should know that where they are, where can we get the PRP, what are the functions they serve, what is the basic science data which we are based on, and what is the clinical data about efficacy and available. So there are different types of platelet-derived factors, or PRPs also there. There is pure platelet-rich plasma, or we say PPRP. There is pure platelet-rich fibrin, or what we call as PPRF. And there is a leukocyte and platelet-rich plasma, that is LPRP, and leukocyte platelet-rich fibrin or leukocyte LPRF. And these are the things which are needed for healing. So is this treatment there, or are we going to, what are we going to do with stem cells? So we can use currently experimentally stem cells for male and female infertility, stem cells in gynecology, stem cells also in obstetrics, stem cells in aesthetic gynecology and cosmetic gynecology, which is coming up, and stem cells in sexual dysfunctions. And that is what I'm going to try to show. Let's start with infertility. Infertility, three major problems which we have no treatment is refractory endometrium, male infertility, and decreased ovarian reserve. So how promising is stem cell here? And is it a hope for no hope disorders? So this is Dr. Sunita Tandulwadkar's lab in Pune, the solo stem cell. And that is what we are doing there. We take out from the iliac crest, as with aspiration, the patient just sits there, and then we prepare them, because you are not allowed to process stem cells into differentiated and then inject. We can inject. This is how it is being taken out. In live you can see, and that is the animation you can see. And we will just, with the stem cells, we will just process them immediately. And this is autologous stem cells, which are then semi-processed and injected back into the endometrium or into the ovaries or wherever you want healing. At first, they are prepared through centrifugation and cleaning, and only isolated stem cells are prepared. So this is how we prepare or get them. So where are we using them? When we run into refractory thin endometrium, when we run into recurrent implantation failures, when we run into POI or POF, and after surgery, if healing is not occurring, Asherman surgery, how good you do it? Because you need at least 7 millimeters of endometrium for pregnancies to occur in ART. There are pregnancies reported at 6, but 7 is the minimum which you need, and it's not happening. By some studies say 9 is ideal, 9 to 14 is ideal. We need the thickness to grow. And if it doesn't respond to estrogen, that means there is a pathology, and the pathology may be impaired glandular growth, decreased VEGF, poor vascular development, and the blood flows. So what are stem cells going to do when we put them into, or PRP going to do? Now this will cause neoangiogenesis, so new blood vessels develop. This will cause proliferation of new endometrium if it is in the basal layer, and that is what Dr. Shawky taught me, and it will differentiate, and then endometrial cell migration will occur. So it will have antimicrobial, anti-inflammatory, promote the regeneration of the endometrium there. And that is how we are doing. And this is Shawky's, Yahya Shawky's technique, not Osama Shawky's technique. And this is how we are doing it. You do a hysteroscopy, you take, first you have performed whatever you want to do to increase the cavity, cut the adhesions by the scissors as it was shown, or by the current or whatever. And when your cavity is all right, you want healing because the endometrium has not come. So wherever there is good endometrium, we'll take the ovum pickup needle with the bevel up, put it under the endometrium. And when we put it under the endometrium, we inject in various places, 5 or 6 random places. And you see, when you put, you'll see the bulge. And when you see the bulge, you know that the stem cell is gone or the PRP is gone. And it will not come out because it's the hysteroscopic fluid is going, pressure is going to keep it in. If you leave it just in the canal, see the bulge. So it's gone under the endometrium. And that is exactly what we want. So that is how we do it now. And we're doing it quite frequently. And we also got our paper, which is just coming out in this time. So, and there are various studies which I can quote, which say that this helps. And here is one of our cases, which you see how the endometrial blood flow helped when we did this in one of these cases, where only stem cell, only PRP was injected. There was no surgery. Otherwise, we are doing it even after big septums in the raw area for healing. We are doing it after Asherman's, and we are also doing it whenever we are doing any surgery intrauterine hysteroscopic surgery. And see the blood flow, how beautiful the blood flow is, and the pregnancy rates in our case. What we're going to do now is show you evaluation of the uterine cavity. So first we evaluate the uterine cavity, as I'm showing to my trainees here. And the cavity first by 2D ultrasound. Then I'll put in a small Foley's catheter or just a normal feeding tube in the cavity. That's where I'm putting the feeding tube, you can see. And then with the vaginal probe in, the feeding tube is there. We will see and look for the intracavity lesions. And once the fluid fills up, the submucous polyp, fibroids, Asherman, all can be delineated very well. And you see here, the fluid has gone here and it was not going. And then, of course, we go and do the hysteroscopy and confirm our findings and correct that lesion or that Asherman or that polyp and remove all that. So that is how we've been doing. So see, we saw the Asherman adhesion, and exactly now I know that I can cut it with scissors or I need to use and whether I'm going to put in PRP. And then I put in the PRP in the normal area around the cut area. So I want that endometrium to come and cover this cell. So this is what we've been doing, and we're getting good pregnancy rates and we're getting good endometrium at least. So after Asherman's, in the adjacent natural normal area is where we are injecting. Severe Asherman's like this, very bad Asherman's, again, we've been able to manage, not in one sitting, sometimes maybe in 2 sittings with PRP injection. And this is a study this is a case from our friend in Ahmedabad, where they injected autologous platelet-rich plasma and mononuclear cells mixed with each other, which are prepared and which also we can get. And then they got this pregnancy. And this is what we reported together. So the other thing is, in thin endometrium, see, sometimes we might have adenomyosis, irregular endometrial myometrial junction. And that tells us maybe there is a little bit of adenomyosis there. Even for healing of those, we'll put. Let's come to the ovaries now. Ovaries, we know that premature or decreasing ovarian reserve or premature ovarian insufficiency or premature ovarian failure is now quite common at a younger age group. And this is very distressing. Even if it is not for pregnancy, it has got long-term effects on bone health, cardiovascular disease, others. So we need to rejuvenate these ovaries. And the rejuvenation of these ovaries, because we want the woman to have adequate estrogen till the natural menopause sets in, or till the age of 50 or so. So that you can use it for premature menopause also. Now, 10% of women undergoing IVF showed that they had a diminished ovarian reserve. And what do we do in this? We give some drugs, we give DHES, we give CoQ10, we give arginine, things like that. And then we do pooling, multiple stimulations, pooling of the oocytes, but still the aged follicles, eggs which you get, you don't get pregnancies. So what have we started doing is that we have tried to inject ogonial stem cells into the ovaries. The pre-treatment of these are progesterones, dihydrogesterone, estrogens, aspirins, CoQ, and lastly, what we've started now experimenting is ovarian PRP and stem cells. And this comes into the algorithm of treatment for POI. So fertility intervention in POI, you see highlighted in yellow is that ovarian PRP stem cells should be tried. And what do? We need to make the ovary like this with good blood flow and good oocytes. So we need to rejuvenate or recharge the ovaries. And we started doing it laparoscopically, and we have some 10-15 cases. Then India, laparoscopy, invasive. Laparoscopy is easy to do because you can pick the ovary, fix the ovary, and then inject it under the cortex, exactly where you want. And that is what I'm doing here. So this is easy. The difficult is to do it ultrasound guided. So here we started trying ultrasound guided. And again, you can see my trainees who are there with us. And in the ultrasound guidance, we are using the 22 gauge needle. In laparoscopy, we were using the thicker needle, 17 gauge. And because it's going to stay, because you know where it is. And with this, if I use the 17 gauge transvaginally, the ovary gets pushed because it's a small ovary and it will not pierce. So we need a very sharp, thin needle. And believe me, to put in a 22 gauge needle through the vaginal fornix into the ovary is not easy at all. So we identified, you look, it's a very small ovary, and that's what I'm identifying. And with my biopsy guide, I'll try to go into the cortex. We are gonna also have now about 15 cases of ovarian PRP done transvaginally with mononuclear cells and autologous stem cells. And we have still not got a pregnancy, but the reserve and the pooling has started. We've just started this treatment about only 6 to 8 months back. And that is in my IVF lab. So that's what it is. There are many studies published on it now, and evidence is coming that this is a help. So use of PRP is not yet approved. It is experimental. Use of stem cells which are modified is not yet permitted world over. So we can accumulate oocytes, accumulate embryos, do ovarian autotransplants. Again, ovarian small pieces are cut, frozen before chemotherapy, and then re-implanted back. Or start the new option of stem cell and the ovarian PRP, which we are doing. So autologous mitochondria transfer, augment is available. That can be done. 3 parent babies are there. Germ lines can be done. These are all very experimental. But these experiments have produced babies. And also in these women from the adult stem cells, we can make sperms and oocytes. So artificial gametes is now possible, and it has been made. And we also have the first babies born, baby Zain and Zainab, and one in Canada, which to an Indian couple. But before we offer all these, you have to determine the cost effectiveness. You have to have evidence of proven benefit. You have to be aware of the patient demographics. And are we causing potential harm just to get a baby, or what is the cost? And we have to know the long-term effect this might have on the children which are being born. So oocyte donation was a simpler method, but now with the laws in India also, oocyte donation is difficult. Otherwise, it was being rampantly followed for decreased ovarian reserve. Experimental methods to preserve male fertility. Yes, even in the testes, and injections of PRP and stem cells start this, or the testicular tissue is taken and implanted into animal testes and they start producing male. So, and if this man needs surgery or he needs this thing, the testicular tissue can be frozen and re-implanted back, or from the frozen testicular tissue, we can extract the sperms. In obstetrics, it has been only tried to seal the ruptured fetal membranes. Yes, premature rupture of membranes you can inject PRP through the cervix and it seals them off. Wonderful, miracle. And that is how this is being done here. You see the PRP has been taken in, and the PRP plug was stable and attached to that amniotic tear, and it plugged it for nearly 2 months, and the baby was born after 2 months. What about the uterine wound niche? I heard such lovely talk on uterine wound niche, whether to repair or not to repair. If we repair, if we do it, cut it, like what Dr. Osama showed, yes, cut the lower end, inject PRP into that niche. It will heal much better. If we are going laparoscopically, we are cutting that, reshaping it, resuturing it, inject PRP into the resutured area, and you'll get better healing. Management of Asherman, we've just shown you, and these are some of my cases which we have done. Some are with Dr. Osama when he was here, some are our own and done at various workshops. And that is all of these very bad Ashermans which we have handled. We are now routinely putting PRP instead of putting a balloon or estrogen therapy and things like that. So surgery plus PRP subendometrial is becoming our this. Now this we have also started putting it after doing endometriosis cyst removal. So cyst is removed, cyst wall peeled off, and in the raw area PRP is injected. And if we can manage, if the patient agrees, mesenchymal cells is injected. Healing is much, much better. And ovarian preservation is much better. Skin wounds which don't heal, PRP works. I'll give you a very, very easy technique that all of you can do. As you deliver the baby, take out the placenta, take the cord, wash it, squeeze out the Wharton jelly. While you are suturing the uterus, the Wharton jelly is mixed with normal saline and centrifuged and then filtered. And you get a clear fluid. And this clear fluid is rich of PRP. Inject it into the fat before suturing or over the rectus. And then the rest of it is made into a spray bottle, and the patient can go on home and keep on spraying over the skin where the stretch marks are, or where the stretch mark will disappear. You'll never see stretch marks even like this. So that is there. Now, the other thing is sexual rejuvenation. So female injecting PRP at the G-spot, treating vulval dystrophy by energy-based devices, and treating lichen sclerosis like this, all these diseases, after we do a laser, surface laser on them or a vaginal laser, we are now injecting PRP into these. So we get these diseases get cured. Vulval pain, there is no vulvodynia, there's no treatment except injecting PRP and laser. So here is how I do my laser. The fractionated automatic laser intravaginal, and that is the post laser's picture for vaginal atrophies, and then we smear it with PRP, so we get a healthy vaginal, or what we call as the vampire injections, where blood is to be injected. We have also used in this case with my friend Dr. Pranay, where we detoss the ovary, ovarian cyst, and some amount of blood flow. It was a para-ovarian cyst, and instead of operating, we injected PRP in the supply. We've also used PRP in breast. So breast augmentation, breast surgeries after that, so you get healing and the firmness or the collagen improvement. We've also used PRP at the clitoral areas for enhancement of sexual in women who complain with that, or what we call as the O shot and the P shots, and it also the G shot, and also in the penis, which is called the P shot, so the erectile dysfunction can be treated. So this is what the uses. And then of course, the cosmetologist in our department uses a lot of PRP on the face. So for wrinkles to vanish, do a laser or a HIFU and inject PRP on that. And that is, or for hair growth. And for hair growth also, you see how it is nicely it is working after hair transplantation and even without. This is some of my cases which I saw yesterday. Very severe vulval infection, did not know what it was. Very severe post-methotrexate vulval atrophy. And of course, a niche scar which I repaired laparoscopically and injected PRP. And these three are doing very well. Just last week, we treated them. So, ladies and gentlemen, to conclude, this is a treatment of the future. It has got a very promising future. Right? It is not the treatment of today. Today it is experimental. But someone has to experiment, someone has to do experience, someone has to publish, and then only we will get results. So autologous PRP, which is easy to prepare, autologous stem cell, which are easy to prepare, can be used for a whole lot of things in gynecology. There is no doubt that this revolution has come, and the labs are understanding, and all of us are understanding stem cells. In fact, the Nobel Prize for this year's 2007 went to Mario Capici and Martin, who described the stem cells. So it is a miracle care which is around the corner. Right now, maybe it is not miracle, but it is going to be a miracle. Thank you very much, Professor Osama, for giving me this opportunity to share my thoughts on PRP and stem cells in reproductive medicine. Thank you.
Narendra, you're always a teacher, okay? The way you organize your information, which flows easily into the mind. This is a lesson to all the audience, how to present a topic and in step up flowing until people absorb it, okay? So I enjoy, even I do remember one of your lecture was cesarean section. I still remember everything you said. So this is something that I encourage people to learn from others. To learn, not only to learn how to do surgery, but also to learn how to speak, how to present. Yes, I remember we did a couple of PRPs in your hospital, and I want to say that the discovery of this technique was by chance. That I read an article about PRP infusion into the uterus, and then I was talking to Yahya that I saw one of my family relatives. Okay, it's confidential. I will not say her name, but she was injecting PRP in her face. So I told Yahya, come on, Yahya, if it works under the skin, so definitely it will be better than just to infuse into the uterus. And to infuse into the uterus, like putting a cream on the skin, but to inject under the endometrium. And the challenge was how to find a long needle. So it was Yahya's idea to use the ovum pickup needle. And I do remember that the first few cases, we did first case, and the first case we did, she got pregnant. So I was in one Congress and I said, as a joke, my success rate in PRP is 100% because I did only one case. So everybody was laughing and said, you cannot say that. It's not scientific. Yes, I know. And then they said Yahya should do a clinical study. So his MS thesis was about the PRP. And the follow-up was not for pregnancy, but was for the quality of the endometrium. And actually, the images he showed by ultrasound was fantastic. Endometrium was triple line and very good. So, ladies and gentlemen, despite this heavy, delicious, juicy meal of open buffet speakers, we are only 10 minutes beyond schedule. So I congratulate everyone on staying on time. Now we come to the we call that the dessert or the last speaker, and well, it's very difficult to present part of you. Yahya is not only my son. He gets angry when I say my sunshine. He doesn't like I pamper him. Okay, but actually Yahya came to my life as really a torch of light. Since he joined me in my work, I remember this also to tell people how you develop. When he was young and assisting me in surgery, like hysterectomy or he said, Dad, sometimes you see things before me. You anticipate that the uterine, but I cannot see it like you. That was in the beginning, but truly from my heart. Now, when I'm doing an Asherman, sometimes this young devil, he tell me to go right or left, up or down. He see things before me. Maybe the effect of age, but he is my GPS especially. No, I am better than him in the myoma, okay? But in the Asherman, he really know how to go into the jungles of adhesion. That's why I asked him to present how to navigate, how to put a scoring system and to anticipate the prognosis. We didn't publish our work, but we have at least 3, 4, or 5 cases every week, of maybe more, of terrible Asherman. And I want to say that the Asherman that we meet in Cairo, in Egypt, is not like that in Europe. In Europe, the post-DNC, post-cesarean section, there's light adhesions, or in US. But in my country, because of the deliveries in the countryside and in small localities where they don't have proper sterilization, so when Asherman happen, it is catastrophic. So, ladies and gentlemen, it's my privilege, my happiness, my ultimate pride to introduce the football player, the gym freak, and the hysteroscopic surgeon, Dr. Yahya Shawki. Dr. Yahya Shawki, are you hearing what I say?
It's very difficult to come up to such an impressive introduction.
No, don't try to be nice. Don't try to be nice. I know that when you will meet me, you will give me hard words. Why you said all this long? I know you quite well. Okay, and you will complain to your mom that dad said so many unnecessary things today. I know. Okay. So the floor is yours, Yahya, and let us finish this event by the Asherman.
Perfect. So first of all, welcome to all the delegates here. You've seen a conglomerate of international surgeons. You've seen all the way from India to Italy to the United States, and then back here in Africa and the Middle East. So a delicious compilation of very interesting topics. And I wish I had something a bit more optimistic to talk about, but Asherman syndrome really is the nightmare of gynecologists. And now it's my pleasure to try to raise the hopes of tackling this very, very terrible disease. So can we see the share screen now?
Yes, we
Go
can
ahead.
see.
You can share it, yes.
Yes, can you see it?
Yes.
Perfect. Okay, so when we are talking about Asherman syndrome, the first thing that you should do is have an idea of the diagnosis. And this was a very debated topic, even as recently as this week on the Historypedia platform, as to how we diagnose Asherman syndrome. Should we ask for an ultrasound? Should we ask for a CT? I see many saying MRI, or what about the hysterosalpingography? There is no gold standard, as we say, for congenital uterine anomalies, for intracavitary lesions. There is a gold standard. For Asherman, there is not, but take it from the person I believe is one of the top experts in the world, which is Dr. Osama. For Asherman syndrome, it is the hysterosalpingography. Why? Because you have utmost technicality of injecting the dye into the space and seeing where the dye is flowing and where it is blocked. You have an idea, okay, this area is free, this area is blocked. Maybe if I go up here, go right, go left, the hysterosalpingography is your guide. You get the image, you correlate it with the clinical diagnosis of perhaps a decrease in the menses, amenorrhea, or an infertility. And it can be as good as a small filling defect, or as Dr. Osama says, we get the terrible Asherman, which is the zero cavity. You see the proximal part of the cervix, and then you see nothing else. So here we have the speculum, this is the cannula, this is the first part of the cervix, and there is no uterus. We need the GPS, which is the hysterosalpingogram, so we can get from point A to point B and tackle this most terrible disease. So the scarred uterus, this ugly, disfigured organ that we are trying to revert back into something that can give new life. What are the causes of the Asherman? Dr. Osama briefly told us about the reasons, but let's go a bit more in detail. Yes, the blind DNC, the abuse of the DNC. A very nice word from Dr. Shawki is this: it's not dilatation and curettage, it is a deliberate crime. This word stuck with me very much. When I was in my residency and seeing the residents being taught how to do a DNC, it is criminal. Complications are frequent, and even when you think that the procedure is, you only mention the complication of DNC when you perforate. not about the long-term complications, the sequelae, the infection, the Asherman, all these problems. We don't hear about them so much. It is true, the blind DNC is a big culprit when it comes to Asherman. Number two, the abuse of cesarean section. Cesarean section is not the normal route of delivery. In Egypt, the recent numbers we are having is somewhere close to 80 to 90% of cesarean sections. Abuse of cesarean sections is not good for the mother, not good for the baby, and definitely not good for the doctors who are treating the Asherman syndrome that are coming from post-cesarean Asherman, which I believe is our #1 cause for adhesions in Egypt and in our own practice. Number three is the microorganism, the infections that happen that can be spontaneous or can be post-surgical. Infections cause a very severe form of the Asherman, very difficult to treat. And also, I believe in India, tuberculous infection of the female genital system is one of the leading causes of Asherman syndrome. And we go from a microorganism to a macroorganism, which is unfortunately yourselves, the rather non-experienced hysteroscopists and gyne surgeons who go in and do surgery on the uterus. Well, they should probably still be mentored or still not confidently doing these surgeries. The abuse of surgery can lead to Asherman syndrome. We've seen this in cases of post-myomectomy, post-hysteroscopy for septum, for submucous fibroid, even for polyps. If you abuse it, you will get adhesions. There are also other causes such as radiations and other rare causes that can cause adhesions in the uterus. You should always be minded by the clinical scenario that the patient is telling you about. One of the topics of today is how to classify, how to grade an Asherman syndrome. And this has been around as early as the Society for Hysteroscopy's classification, which was followed by Valenciara's classification in 1988 and Donet and Nisol in 1994. There have been many classifications on how to classify Asherman, and towards the end of this topic, we will be talking about how we can do a surgical classification of Asherman. Me as a surgeon, when you tell me that the grade 1 is just a thin or filmy adhesion, I don't know where it is. Okay, is it a thin and filmy adhesion in a patient that has had the adhesions for 3 months or 3 years? Was it post-surgical? Was it infectious? It's not helping me so much. When you are telling me grade 3 that there is obliteration of part of the cavity, yeah, which part? It is more of an academic classification rather than a surgical classification. And this is a recurring problem in hysteroscopy. Even when you have the congenital uterine anomalies classification, it doesn't help me to perform the hysteroscopy when you are telling me that it is a partial septum or a complete septum. We want more details, and there is more coming in that area as we go along. Firstly, let me give you the pseudo-Asherman, and this is Professor Shawqi's favorite case. This case, she comes with a horrible diagnosis. She comes with a history of HSG, hysterosalpingography, that shows a zero cavity. She had an attempt of hysteroscopy, which said zero cavity, no hope, but she does report menstruation. In these cases, we call them pseudo-Asherman, and this is the false track. So let's watch what this is. Okay, you can see here, 1, 2, 3. So this is actually one of our own cases.
Dr. Yahya, are you sharing your screen?
Yes.
I see only your face.
I should be. I asked you if the share screen is on. You said yes.
Yes. No. Can you share the screen again? Maybe it went out. Share your screen again.
Like this, you can see.
Yes. Now we can see. Yes.
Oh, you didn't see any of the past?
No, only for the last slide. Okay.
The last slide. Okay. So you can see it like this.
Yes. Can you share screen now?
You can see it. When I'm sharing the screen, you are saying it stops.
Oh, but we see now the slide with false tracks. Yes.
Yes, you can see it now. Good. So you can see here, the problem was that the surgeon went into a false track. And this can be a very, very bad prognosis for the patient, because she is told that she is a complete, total Asherman, no hope, do not try. When in reality, she has a perfectly good cavity. You can see here, both tuber osteums are seen. She has a healthy endometrium. And as the surgeon pulls back, you will see the false tracks that the other hysteroscope it went is to, which is here and here. So they actually did 2 false tracks. Let's see this again. So there are actually 2 false tracks. And the problem here was that the direction of the cavity was rather difficult. It was extremely AVF. Please stay with me online, Dr. Osama, to tell me if the videos are clear or not. So how to...
Videos are working well, but the screen is small, no problem. Wouldn't you like to try again, share screen for one last time?
Sure. Can you see it now?
Go to the next slide. Because
Next
it's black
slide.
screen. It is getting black.
No. Then let's
the video
keep...
disappeared. The video disappeared.
Okay, so I'll keep it the slightly smaller screen so you can see the videos.
All right.
Okay. So how to avoid this problem? Can you see this?
Yes.
The tricks of the trade.
Yes. Everything is clear now.
You have to use the optimum pressure to see, which is not a number. There is no number that I'm going to give you. It can go up, it can go down. To be able to enter the cavity, it does not matter what pressure you are using. It will never cause an overload. Number 2 is to follow the endocervix. Do you see this image, Dr. Osama?
Yes. Trick over trade.
You don't see the image.
No. Either trick or trade.
Give me 1 second.
Now I see the image of the railway track.
Let me close this.
Tricks of the trade.
Yeah, they are not letting me share the screen properly.
Let me. No, you should be able to share the screen. Now you share the screen to your face.
No. I'm changing it again.
Okay. You know the green button of share the screen, huh?
No worries.
Share screen is the green button down.
I am sharing the screen now. They are not allowing me to share the screen. Now you see it.
Yes, I see now the railway, the tunnel.
Yes, the tunnel view. So the tunnel view, you follow the tram lines of the endocervix. Same like these lines. All of these lines, they converge at the internal os. You see the internal os, even if it's a very, very small dot. All the lines of the endocervix, they will converge, they will meet at the internal os. This is how you don't get lost. So don't push posteriorly or laterally. You follow these lines till you can see the internal os, and that is how you navigate a difficult cervix. Okay? And it is always a problem of either direction or diameter. It can be a tight cervix or it can be a normal cervix, but the direction is extremely AVF or extremely RVF and difficult to see. So let me share when you don't follow these rules. I know Dr. Tony gave you a very nice presentation about complications. When you don't follow the rules, you will see the problem that happens. Can you see the video, Dr. Osama?
Yes, I see the video. The video is very clear.
This video is not our work. So a full disclaimer, this is not a scandal from a private practice. This is a colleague. So we can see here, this is not optimum pressure. They are not using a good pressure to distend. Now it is getting better. And we can see if they are following the rules, this is the internal os. The lines are all converging here. And the surgeon is starting to go in a proper direction.
So it appears like there will be no problem. This was a case of Asherman syndrome. And look the problem that happened when you don't follow the rules. So the surgeon starts to dissect, but they are abusing the scissor and not going in the proper direction. So the proper direction is here. It is at 10 o'clock. The surgeon is continuing, claiming that these are adhesions in a 12 o'clock direction. And then going completely false, and now going at 3 o'clock. Hysteroscopy is a tissue identification surgery. Immediately, you should recognize that this is cervical substance tissue. This is the cervical stroma. You should be able to recognize this is not adhesions. Not at all. And continuing to dissect and feeling like these are adhesive bands until, according to the surgeon, they have entered into the uterine. They think they are entering the uterine cavity. And I believe those of you who have a keen eye will be able to recognize this is not the uterus at all. This is the substance of the broad ligament. This is a lateral perforation through the cervix and into the broad ligament. This here is paracolpion. And still, it's not even recognized. This is the problem. When you don't recognize, when you don't follow the rules, you can cause big, big problems. This is probably a branch from the uterine, a very small branch. And this was deemed to be atrophic endometrium and a very severe Asherman, which is completely false. This is actually a perforation into the broad ligament. And in this particular, this is almost all the way to the pelvic side wall here. And you will start to see the ureter and the iliac vessels. The worst thing you can do with complication is to be ignorant about them and not be able to even recognize that you are creating a complication and making it worse. So always remember these rules. So let us talk about the grade 1 adhesions, which we say are the flimsy adhesions that can be cut either by the tip of the scope or by I call it Shauki technique, which is the hydrodissection. So here you have a narrow internal os. This case has multiple levels of adhesions. And you see it is not just fluid and it is not just push or mechanical power. It is both a direction and a fluid pressure. So you see the adhesion here, and this is actually cesarean scar. And you will be able to see, so this is a post-cesarean Asherman or intrauterine adhesions, and you can see how you will see how these light adhesions are broken. Always take time in hysteroscopy to see and focus on the nearby images. See the RBCs as they go through the small capillaries. This is not wasting time. This is allowing the fluid to go ahead of you and begin the dissection plane. Same like in laparoscopy when the CO2 gas dissects the plane before you. So look at this curtain of adhesion. Slowly, slowly, with a meticulous direction and adjustment of the fluid pressure, you will see how the curtains of adhesions are broken. Look at this. Very gentle. This has not yet become dense connective tissue. And the last bit of the adhesion, release, 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 completely released. And we have gone inside the cavity, and very nicely we see the bubbles running towards the right tubal ostium. She has some still adhesions inside the cavity, but it is not that bad. So this case actually would have a good prognosis. So this is the grade 1 adhesion. What about a grade 2 adhesion? These are more dense adhesions that require an instrument to be broken. So some do with the resectoscope, some do with the scissors. We will comment on this a bit later on. So this case, more advanced. It requires. We don't say this is easier or more difficult because a grade 1 cavity can be very difficult to even enter into the cavity, and a grade 2 adhesion. This particular case is actually one that I did when I was still in the start of my learning curve. So even if it is supposedly harder, it was not so difficult, especially when you have an expert standing beside you to guide you. So here it looks like there is a septum, not an adhesion, but wait, is this another septum inside? Oh, a third septum inside. No, this is not septum. This is actually one of the best. I have only seen a case like this once in my life, which is what you wish was Asherman syndrome, which is just, bands of adhesion between anterior and posterior walls that you can go in and cut, and the patient will have a great prognosis. The tricks here, you need to distend the uterus. So the anterior posterior walls should be stretched. So the adhesion is stretched between them, and then you can see them clearly and you can begin to cut them. So you see here, we are using the scissors. We always prefer cold energy when it comes to adhesions because we want to be as atraumatic as possible on the endometrium. This is a damaged endometrium. We want to save it as much as possible. Exactly in the middle, the plane of least resistance. The fluid is doing half the job. It is guiding us as to where to cut. And we do very, very gentle snips. I hope the image quality is good. And we are starting to see here behind the adhesion, we are seeing the tubulostium.
Image is good and video is working nice.
We always want in Asherman's, in all of hysteroscopy really, look at this pushing technique. We always want the landmarks. So the landmarks in the cervix are the endocervical glands that help you reach the internal os. In the uterus, it is the tubulostium. I remember at the second we were debating, cut the medial or the lateral. You know, when you have a bomb and you cut the red wire or the green wire. And there is the right tubulostium. And to appreciate the value of the fluid pressure, look at this. Look at the tiny snip and release of the adhesion into a beautiful cavity. So this lady has an excellent prognosis. She has healthy endometrium. Areas that are denuded will heal. And we will talk about how to help and aid in the healing. And you can see how we are restoring the cavity to the normal shape. So for these cases, always start from normal anatomy. Same like when you have in laparoscopy a case of a frozen pelvis. We want to start from where is normal. So we either start from the pelvic brim or lateral to medial. We want to start from a normal anatomy. So if it is a total Asherman, start from the internal os. Identify, okay, if she has a cesarean section, this is the cesarean section. So the direction of the cavity will start here. This is the internal os. This is where the end of the cervix starts and the start of the endometrium. When you are dissecting within, if you have one tubulostium seen, start from there, begin to dissect, aiming to reach the other side. Start from normal anatomy. And two, the proper tools. The proper tools is not just the instrument. Okay, so we can, in our experience, it is always better to use cold energy versus electrocautery for Asherman syndrome. We want to, regardless of what, if you're using monopolar, bipolar, whatever, there must be some damage to the endometrium from electrosurgery. When you're using cold scissors, this is minimal. But it is not just the scissor. It is also, in my opinion, more important to have a good distension, which can only happen if you have a proper pressure inside the cavity. So the distension system you are using is equally important. Use your landmarks very wisely. if you are getting lost, it will be like the case I showed you a little bit before. You will start to go laterally and perforate. You will go too high up, too far down. It's a problem. If you don't know the difference between the cesarean scar and the internal os, you begin to dissect the cesarean scar, you end up in the bladder. If you start to dissect improperly laterally, you will reach the broad ligament. If you don't realize the difference between adhesion and muscle, you can finish the adhesion at the fundus and keep going until you reach the bowels. So you need your landmarks in the cervix and in the uterus, which are the tubal ostium, and to identify endometrium, even the poor endometrium, the weak endometrium that has been closed by the adhesion, the myometrium, and the serosa. And finally, you want optimum exposure. I don't have a retractor here. How to get the exposure? Only by fluid distension, a proper pressure. And as I said again, the identification of the tissues is very, very important. You need to know the difference between endometrium, myometrium, adhesions, and serosa. To end in terms of the adhesions, I want to show you a grade 4 adhesion, which is the worst, the zero cavity. I will play this video almost non-stop, and then we will discuss it. So enjoy this one.
Dr. Yahya, would you comment, please, and explain? There's no sound.
Comments towards the end. So we followed the rules, okay? And apparently we are inside the cavity. We followed the endocervix. We identified where the internal os should be, proper pressure to distend, and we are using the scissors to probe and use. And apparently we reached the cavity, but is it enough? No. This is not the whole cavity. And you can see here, identification of the adhesions tells us still there is more work to be done. And then we go in and we see the rest of the cavity. And now we have the right tubal ostium. A beautiful view, and there is still some healthy endometrium here. And as I said, you start from the normal anatomy, and then you can begin to dissect the other side. It's very difficult sometimes to be able to fully reconstruct the cavity and reach both tubal ostia. But if they are there, we will show you how. Okay, so we see where this one is. And we know geographically where we need to look for the other tubal ostium. So we dissect the lateral adhesions. Look at this. A very important question. Okay, you are saying the difference between adhesion and muscle. The adhesion is pure white or a little bit yellowish if it is tinged with infection. You can see evidence of end arthritis in these adhesions. Some of the adhesions are vascular. Look at this particular area. There is some fluffy material coming from within the adhesion. This is the dead endometrium that was trapped in this area. So this is how you tell the adhesion. The muscles, they are white but pinkish. You will not be able to say that this is muscle and this is adhesion once you see both. You will be able to tell the difference. You have to have a good eye and be able to recognize the difference. And look here. This is where the adhesion meets. You see this black line. So, and we go in and we use a Hilton technique, and the line of least resistance breaks. Look at this. Don't push the scissor too far in. Just very, very clearly, small Hilton technique to separate and be able to see and look at, is this a perforation? Are we inside the peritoneal cavity or are we inside the bladder? No. Be able to recognize with your eyes. So you see the texture of the adhesions. Very gently. These snips, these are millimeters. Hysteroscopy is a surgery for millimeters. And you see the beautiful left tube there, here. The left tubal ostium, surrounded by a little bit of endometrium. Once you have the landmarks, you can easily correct the cavity completely. It becomes an easy job now to restore a normal cavity. And you can see this normal cavity after a little bit more work. Okay, so I have one tubal ostium, the other tubal ostium, all the adhesion. So this one on the hysterosalpingogram was a zero cavity, was the worst. And there were multiple levels of adhesions at the level of the internal os, at the mid cavity, at the fundus, multiple levels of adhesions. And in our practice, we prefer to leave a Foley catheter, especially when we have these extensive adhesions. And we always prefer to inflate it under vision. It is not necessary. You can do it on the ultrasound guidance. But we find that the best results we get is when we do it hysteroscopically. We can exactly place the balloon where we want. And we can always readjust the balloon to fit perfectly inside the cavity. So here, I think this is the same case. Yes, it is. See the same lines of adhesions. And you can see the Foley catheter. And you will see how we inflate it under vision. Also, so we know exactly how much fluid we need to inflate. You can see the balloon starting to inflate here with the fluid. So a little bit more, little bit more. And then we can correct the orientation of the balloon. So we can pull this and make it a little bit more vertical. And the balloon is perfectly placed and we can say, job done. In terms of the post-operative protocol, some advocate the use of an IUCD versus the balloon. There is a place for both. The balloon gives a bigger surface area, so it prevents the cavity from sticking back together again. The value of the IUD is you can leave it for longer. In terms of hormonal support, there have been many papers on how much estrogen you can give to give a hormonal support. Some say it's not very useful, some say it is useful. In our practice, we do give the estrogen support post-operatively. The new adhesion gels have shown promising results, but more trials are needed to do this. And we always follow them up with a hysterosalpingography immediately after we remove the balloon. This is to see the immediate post-operative effect. And then again, after 2 cycles, so we can see how much the cavity shrunk again, and if we need to do a second setting, third setting, etc. And the future is now for the new techniques, the PRP, the stem cells. We are already doing these trials now, injecting these materials into the endometrium to aid in the regeneration of the endometrium. I always say we have a very, very high success rate when it comes to the surgical outcome. So we can go in and we can create the cavity. We will do this 99%, inshallah. However, the success is not just the surgery. The success is to have the endometrium regenerate and to have a pregnancy and to deliver a baby. And for this, we need the help of these new techniques because the limiting factor so far is the regeneration of the endometrium. What about this new classification? All right, as I said, as I touched on before, we want a classification that helps us as surgeons. I don't want a classification of hysterosalpingography, thin strand, thick strand, half the cavity, total cavity. It's not very useful for me to, as a surgeon and as a clinician, to tell the patient what her prognosis is, because I give you a small example. A case who has a zero cavity, who just has the isthmus stuck with adhesion. This one you can just, you know, with the sound in the office, or even with the office stethoscope, you open this isthmical adhesion, she has a normal cavity. This lady, if she went just with the hysterosalpingography picture and said she has amenorrhea for 3 months, they would tell her you have zero cavity, you have no chance. It's not a very useful classification. Our work is not yet published, but it is registered now on the clinical trials, a new classification for Asherman syndrome. Something big is coming. This classification is, in my opinion, it is a game changer when it comes to people who are doing the surgery. It will be a game changer. How to have a good classification and be able to talk to the patient about her prognosis, and something that will actually help you to be able to perform the surgery. This is coming soon. The results we have are in, and it is just in the process of being published now. And even though this is not the topic of today, but a similar issue is also coming for congenital uterine anomalies. We are very, very passionate about intrauterine surgery, and we are trying to make it easier for everyone to be able to perform surgery for these uterine anomalies, for these difficult cases of Asherman syndrome. And in the end, I say thank you, and I invite anyone who is interested, who is passionate about intrauterine surgery, to share in the Historypedia platform. We have a daily confluence of cases of international sharing, where everyone is very keen to help others and to build bridges internationally. Thank you, Professor Osama, for giving us this opportunity today, and I hope it was useful for the participants.
Well, Mr. Yahya, thank you very much for this comprehensive coverage of the nightmare, as you said, for gynecologists. And I do believe that operative intervention for Asherman is like laparoscopy in frozen pelvis. In frozen pelvis, there is no landmarks, okay? And as you said, I repeat again, hysteroscopy is a tactile and tissue structure surgery. You feel the resistance of the tissues when you are moving, and you feel also, you visualize the color of the tissues to distinguish between endometrium, poor endometrium, myometrium, and serosum. Well, despite this long day, we are only beyond schedule for only 10-15 minutes. So on behalf of myself and the Gyne Forum Committee, I would love to thank each and everyone participated in this wonderful gathering. I call it really from heart to heart. Every speaker spoke from his heart, not from the textbook. Every speaker provided his personal experience and personal opinion. I do believe that Professor Abu Ghar, Professor Salam, and Professor Yaqub Khalaf, the strongest ART authority, have covered covered exactly all the updates and guidelines of fertility practice. The endoscopic surgeon participated, Keith and Jamal and Tony and Dr. Botros and Yahya. Everybody also showed in depth his personal experience. That's what I care in the Gyne Forum. It's not of value that any speaker come to repeat what is written on Google or any textbook. So I hope that every participant has got a benefit and value of that. When I look at the number of participants from the morning till now, we lost only 6 audience, okay? But it's an achievement to have the full audience staying till the end of the day. And I promise you that the Gyne Forum and the Historypedia will come to your places and to provide training and science. If you cannot come to hysteroscopy, hysteroscopy will come to you. So for everybody, big kiss. Thank you, Tony. I see you're still here. Thank you, Yahya. Thank you, Narendra. Thank you, Keith. Thank you, everybody. And love you all. Bye-bye. Bye-bye. Mr. Yahya, take care of my patients. Take care of my patients until I come back, okay?
Do my best.
Bye-bye.